Wherever life plants us, bloom with grace. Life is a wonder. Every day in our life matters, and what makes it count is a simple smile of happiness. Welcome to MVR Cancer Center and Research Institute. We believe in eternal happiness. One of the finest cancer centers and research institutes, MVR-CCRI, is named after Kerala's renowned veteran leader, M.V. Raghavan, in recognition of his contribution to the cooperative sector in the state of Kerala. A milestone in India's cooperative sector, MVR-CCRI connects international experience and healthcare services with a world-class facility.
MVR Cancer Center and Research Institute is the first multidisciplinary standalone cancer center. Came up 3 years ago in Kerala. In 2012, some of us like-minded people under the leadership of Mr. Vijay Krishnan formed this Care Foundation with an aim of delivering world-class cancer treatment at an affordable cost to the people of this area. This hospital has 35 different cancer-related subspecialties and 35 departments working. And also we have about 60 odd very well trained expert doctors in the for the management of cancer are working in this hospital. So we have a facility for all cancer treatments like surgery, radiation, chemotherapy, immunotherapy, and any other form of treatment currently practiced in the world. We have about 8 surgeons, surgical oncologists working in this hospital, and about 8 modular theatres, state-of-the-art theatres for the surgical management of cancer. We also have 2 linear accelerators, very latest equipments, and it can take about 100 to 150 patients for radiation per day. And all these latest radiation equipments can give radiation with a very accurate dose. We have a large 80-bedded daycare chemotherapy unit, as well as 12 world-class BMT suites under medical oncology. When the cancer is progressing with all the standard treatment, and when bone marrow transplant is the only cure for them, we have facility for taking up 12 patients at a time. We also have a well-equipped pathology department, transfusion medicine department, a microbiology department, and an infection control team, as well as we have other supportive departments like medical nutrition and well-equipped physiotherapy department as well. This hospital so far has treated about 30,000 patients for a period of 2.5 to 3 years, and we have performed almost 6,000 to 7,000 surgeries with a complication rate of less than 5%, which is a remarkable achievement. And we have delivered radiation for more than 20,000 patients. Also, we have facilities for clinical trial. Clinical trial is a department which offers a new treatment which is not in practice, but it is available as part of trial, which is available as part of multi-centric, multinational trials, whereby patients can experiment treatments which are not at the clinical use. By this method, even patients can have treatment which is going to come 15 years later. So this hospital is well equipped, and the team of doctors are having good experience and experts in the field, in the different subfields of cancer treatment, as well as we have a very good team of paramedics which deliver the treatment without any complication or without any failure. So our aim is to get the best results out of our treatment, and I'm sure with this type of team and the equipments, we can deliver the best, and we aim at achieving the status of the best hospital in the world by 2020.
The hospital's state-of-art design, functionality, and technology makes us one of the most modern hospitals in the subcontinent. Our passionate team of professionals and their patient care helps us provide accurate diagnostics round the clock during any emergency.
I am Dr. Prashant Parameshwaran. I am consultant in Department of Medical Oncology and Hematology at AMPI-KC Center, Calicut. I am in charge of hemato-oncology and bone marrow transplant program in MVR. We are offering a complete hemato-oncological program, state-of-art leukemia induction unit. We take care of lymphomas, multiple myeloma. We have a well-equipped blood bank, an apheresis unit, and a state-of-art hematopathology, which includes 10-color flow cytometry and all immunohistochemical markers. We are having a bone marrow transplant unit, which is a kind or one of the biggest in Kerala, with around 11 transplant beds. We have done autologous bone marrow transplants for myelomas, lymphoma, and allogenic bone marrow transplant for acute myeloid leukemias. Aim is to make it as a state-of-art unit, and we have already started postgraduate training programs. We are planning for more and more training programs in the field of hemato-oncology and transplant.
Our surgeries are conducted in a world-class, fully integrated operation theatre complex with 8 operation theatres and a high-end cath lab within the complex.
Department of Surgical Oncology at MVR Cancer Center and Research Institute has 10 consultants which work in a site-specific and organ-specific manner. Each consultants have got exemplary vertical skills apart from good horizontal skills, and they take care of certain areas of interest pertaining to their areas of expertise. The department has got 8 state-of-art theatres, and we do around 200 to 250 surgical oncology procedures every month. Few procedures are specific to our institute, like we have got a department of peritoneal surface oncology where we do cytoreductive surgery and HIPEC, and we do around 60 to 70 cases per year, and it's one of the most high volume center in South India. We also have good expertise in bone tumors where we do limb salvage surgeries with custom mega processes, and in fact our amputation rate is less than 5%. We also have got great expertise in breast tumors where we do a lot of breast oncoplastic procedures, taking care of the oncological aspect as well as the aesthetic aspects of the breast. Our breast conservation rate is around 75%, and we do mastectomies in around 20-25% of patients. Apart from that, the department works in unison with medical oncologists, radiation oncologists, rehabilitation and other allied specialties, and we work in a multidisciplinary team approach. Thank you.
The blood center in MVR Cancer Center and Research Institute has been developed as a 100% blood component issuing blood center. We are focusing on collecting blood as much as possible from voluntary blood donors, of which we have reached almost around 80% of our blood components being issued are from voluntary blood donors. In the aspect of reaching to that expectation, we are conducting at least 1 blood donation camps per week, and we have been able to achieve the blood license, all components that is being possible to be issued in India. And we have also developed our blood bank to a status of hematopoietic stem cell collection and processing.
Hope on Wheels. Our hearts puff up with pride to introduce you to our moving hospital. Yes, a hospital on wheels to extend our medical support to the remote corners of the country. A fully functional mammography unit, an advanced laboratory, and a team of talented technicians rendering their genuine services.
The laboratory services of MVR Cancer Center have excellent facilities. We have the departments of pathology, which also includes histopathology and hematology, clinical biochemistry, microbiology and serology, and molecular oncology. Under molecular oncology, we also have cytogenetics. So basically, the laboratory services here are fully equipped to cater to the oncology patients. And we offer services at very reasonable, patient-friendly rates. We always try to keep up to the best of quality, use the best of ingredients, best of kits, and try to give reports in a very competent manner. We have also started COVID-19 testing In fact, we were one of the first private labs in Kerala to start the real-time PCR testing for COVID-19. And we were one of the first labs, private labs in Kerala to be recognized to do the RT-PCR test for COVID-19.
A dining experience offering cuisines that pleases versatile palates. Care store that caters all your basic needs. Delicacies from the Care Cafe with a lively ambience and other warm services to rejuvenate you. They say that if you have a library, you have everything you need. Yes, we have an exceptional library. Our comprehensive pediatric care consultants are specially trained in taking care of children.
At MBR-CCRI, we have a dedicated pediatric oncology department dealing with all disorders in children. The hospital here has a very child-friendly campus with a dedicated child-friendly OPD area, daycare facility, as well as inpatient care. All the staff involved in the care of children are specially trained for pediatric patients. We treat all children, whatever be the age, from newborn to older children, adolescent children, with blood-related disorders as well as cancer-related disorders. The treatment period during pediatric cancers is a very stressful period, and we make sure that all the children who receive treatment here have a child-friendly atmosphere during the whole period of their care. We have a good dedicated play area as well as all areas which are dedicated child-friendly areas.
Department of Radiology at MVR Cancer Center offers a complete spectrum of the leading-edge technologies that the medical world operates on.
Hello, good evening. I'm Dr. Dinesh, Head of the Radiation Oncology Division at MVR Cancer Care and Research Institute. Our department, Radiation Oncology Department, has commenced functioning 3 years back with 2 state-of-the-art LINAC facilities, which you're seeing now. This is our first LINAC, which was commissioned way back in 2018, I would say. And we are treating around 110 patients daily on this machine. Even during COVID times, we are extremely busy because most of the referrals for cancer treatments cannot be delayed in spite of these difficult times. And what these linear accelerators entail us to do is, it helps us to give very precision radiation therapy, because radiation oncology practice have changed over the years, and it is extremely important to deliver the radiation dose precisely to the target volume. So we take extreme care in seeing that our patients are treated in the right way, in the right manner. As you see now, we are just giving you a demonstration of a patient lying down on the couch, and this is a very, very important machine in the sense that we are able to image the patient during treatment for the right targeting of the tumor. So we have got a cone beam CT, we've got imaging facilities, we have got facilities for stereotactic body radiation therapy, stereotactic radiation surgery, we have got micro MLCs for very precise targeting of the treatment. The key factor in radiation therapy in this era is precision radiation therapy, and we use immobilization mask in all these patients in various ways to see that they don't move during treatment. And this is the mask we use on these patients, and we fix it over the head. And for children, we use very special devices like vac locks. We use individualized mask. For children, we have devised to improve the tolerance and to reduce the mask anxiety. We paint some good designs, and this is done by our technologists, so that it's a very friendly way of administering radiation therapy, so that they won't be anxious during treatment. So very personalized care, even in spite of having the best of technology, is important to improve the compliance of these patients during treatment. And this is one of our strategies. And this is done.
Nothing in life is to be feared. It is only to be understood. Now is the time to understand more, so that we may fear less. When Madame Curie said these words, she would have seldom thought that these words would be the spark for several youngsters to pursue science and technology for centuries to come. Good morning, ladies and gentlemen. Welcome to the annual meet of Association of Medical Physicists of India, Kerala chapter. Hope you all had a comfortable journey to this picturesque location of AMPI-KC Center and Research Institute. I, Dr. Reshma Bhaskaran, along with Ms. Amalu Hanna Alex, are your host for the day. In radiotherapy, we navigate the invisible, harnessing the power of radiation to bring about tangible and life-changing outcomes. Large-field radiotherapy, like the total body radiation and total skin electron therapy, are being practiced since several years now. However, these techniques are still a nightmare for the physicists and clinicians alike, with the enormous number of measurements required and the difficult post-treatment managements. Today, in this session, we try to understand some more about large-field radiotherapy so that we may fear less about its implementation and practice. Let us begin the day with a prayer. I invite Ms. Abjishri S. to the dais for the prayer.
എങ്ങുമെങ്ങും നിറയും വെളിച്ചമേ എൻ മനസ്സിൽ കൊടിയിരിക്കണമേ എൻ്റെ പാദം ഇടറാതിരിക്കുവാൻ എന്നുമെന്നിൽ പ്രഭ ചൊരിയണമേ പൂവിലൂറുന്ന പുഞ്ചിരി നീയല്ലോ പുസ്തകം തരും ജ്ഞാനവും നീയല്ലോ പുല്ലുമാടവും പൂമണി മേടയും തുല്യമായി തൊഴും ശക്തിയും നീയല്ലോ എങ്ങുമെങ്ങും നിറയും വെളിച്ചമേ എൻ മനസ്സിൽ കൊടിയിരിക്കണമേ എൻ്റെ പാദം ഇടറാതിരിക്കുവാൻ എന്നുമെന്നിൽ പ്രഭ ചൊരിയണമേ.
Ladies and gentlemen, without further ado, let us begin the inaugural ceremony. May I invite Dr. Saju Bhasi, Additional Professor of Radiation Physics, Regional Cancer Center, Kerala, and Secretary of Association of Medical Physicists of India, Kerala chapter, to the dais. Thank you, sir. I would like to extend a warm welcome to Dr. PGG Kurb, Chairman, Association of Medical Physicists of India, Kerala chapter, to the dais. Dr. Kurb, a visionary who spearheaded remarkable initiatives throughout his career. He has been leading the association since 2016. Thank you, sir. Joining us today to inaugurate the event is a trailblazer in medical oncology, Dr. Narayanan Kuttivarya. Dr. Warrior is the Medical Director and Senior Consultant of Medical Oncology, MVR Cancer Center and Research Institute. It is my privilege to welcome Dr. Narayanan Kuttivarya to the dais. Thank you, sir. Dr. Rebecca John is an expert in family medicine and has been leading MVR Cancer Center and Research Institute since May 2023 as its Chief Operating Officer. I am delighted to invite Dr. Rebecca John to the dais. We have amongst us Dr. Vijay Gopal KS, Senior Consultant and Head of Radiation Oncology, MVR Cancer Center and Research Institute, who has been consistently demonstrated outstanding commitment to the field of radiation oncology. May I have the honor to invite Dr. Vijay Gopal KS to the dais. Ladies and gentlemen, please join me in giving a resounding round of applause as we welcome our esteemed dignitaries to this stage. To begin the ceremony, may I call upon Dr. Saju Kasi, Secretary, AMPI Kerala Chapter, to deliver the welcome address.
Thank you, Amalu. Respected dignitaries on the dais, teachers, colleagues, and dear students, good morning to all. It's with great pleasure and immense honor that I welcome you all to this annual meeting of Kerala Chapter of Association of Medical Physicists of India. You all know Kerala Chapter AMPI was constituted in 2016 under the parent body of Association of Medical Physicists of India to disseminate scientific knowledge related to radiation and its safe use in the field of medicine. In the realm of radiotherapy, the power to heal lies not only in the radiation beam, but also in the unwavering commitment to the entire healthcare team to address the various issues faced on day-to-day basis. Large field radiotherapy, like the TZ and the TBI, this is total skin electron therapy and total body therapy radiation, is in practice worldwide. However, the effective use of these techniques require a thorough knowledge of physics behind them and also the technology that assists in their implementation. The theme of this conference, Breaking Barriers with Large Field Radiotherapy, was chosen by the organizing committee to address the challenges that one faces while implementing and using these techniques in the clinic. First, let me welcome Dr. PGT Kurup, Chairman of AMPI Kerala Chapter. The knowledge and experience of Dr. Kurup has always been a source of guidance for all of these years. Welcome to the meet, sir. As Secretary of Kerala Chapter, it's my honor to welcome Dr. Narayanan Kuttivarya, Medical Director, MVR Cancer Center and Research Institute, to this meeting. Dr. Varya has left an indelible mark in the field of medical oncology with his clinical and research experience. Welcome, sir. I take this opportunity to welcome Dr. Rebecca John, Chief Operating Officer, MVRCCRI, to this program. Dr. Rebecca is an expert in family medicine who has been working in the field of medical administration and operations since several years. Welcome to the event, ma'am. Dr. Vijay Gopal KS is the head of Department of Radiation Oncology at MVR Cancer Center and Research Institute and has been serving cancer patients since the past 20 years plus. Welcome to the event, sir. A hearty welcome to students, to my colleagues and friends who has come from all parts of Kerala to this event in spite of such heavy rains. Your zeal encourages us to organize this meet every time. Before I conclude, I would like to dedicate today's scientific program to two eminent physicists who has left us this year for their heavenly abode. Dr. P.S. Iyer, who was a founder member of AMPI and who retired as head of the Radiological Physics Division, BS in Mumbai, and Dr. Ponnunikatha, who was the first medical physicist from Kerala. Together, let us seize this opportunity to learn, to challenge, and to create a bright future. On behalf of the organizing committee, I once again extend a warm welcome to all of you. May this conference be a resounding success and it may serve as a catalyst for further education and research in medical physics. Thank you.
Thank you, sir. I request Dr. P.G.G. Kuru, Chairman, AMPI-Kerala Chapter, to deliver his presidential address.
Good morning to you all. Respected Dr. Vaidya, Dr. Rebecca, and Dr. Venugopal who are on the dais, and Dr. Dinesh, who is one of my best friend and colleague here in this stage, in this auditorium, and all the students and my colleague physicists who are assembled here for this meeting. Now, I have the responsibility of giving the presidential address. I'll give a few words about the origin or starting up of the medical physics in Kerala. Of course, we started medical physics in India sometime in 70s, I think. In 76, we started the Medical Physics Association. Before that, physics was involved in the Radiological Society. Even radiation oncology was part of that. So there was only one association, Radiological Association, and the physics and the now radiation oncology divisions, they were all part of the radiology. Subsequently, in 76, the medical physics started, and I think in 78 or 80, that time, Radiation Oncology Association also separately started. Till that time, they were all one association, Radiological Association. Now, since the departments or divisions are improved and expanded, each division went on their own ways of development. So medical physics started with the radiation departments, diagnostic and radiotherapy, and giving assistance for these departments in the radiation safety, education, and treatment facilities and diagnostic aspects. In Kerala, the Medical Physics Association started as the Kerala Association of Medical Physics, that is called CAMP. At that time, there was no chapters of AMPI in different states. So we had started CAMP, I think in 1990 or so, and it was continuing with their annual meetings every year. Subsequently, only in the past 5 years, we have started a chapter of medical physics in Kerala. Though other states have started their own chapters earlier, we started a little late because we were organized with the CAMP. Now, CAMP is almost not very well functioning because the same members are working with the AMPI-Kerala chapter. So we are holding more of the medical physics chapters in all the states, including Kerala. There were only few physicists who could be counted on fingers in the earlier days. 5 or 6 physicists were there only there in the state. Now I don't know how many numbers they have improved. Even 10 or more physicists are in each hospital. So the numbers have improved. Their education has been substantially increased, and their knowledge has been very much utilized in the treatment of radiation, especially in cancer treatments. And there are quite a few physicists who are supporting the diagnostic facilities in the state. So medical physics is now uh, very much come a part of the medical support. Now today we are holding the, I think the second chapter meeting of AMPI Kerala, because we started recently. The past few years we couldn't conduct meetings because of one is 2 times we have organized meetings, but we couldn't conduct because of the calamities that has happened in the state due to flood and other things. And subsequently the virus has affected us also. So we couldn't conduct meetings in the past few years. That's how it has become the second meeting, though it is almost 5 or 6 years we have started the association as a chapter. So these are the developments that we have gone through in Kerala. I think the rest of the things we will be discussing in the panel discussions and also in the meetings. So I'm not going in detail about that. I wish this meeting all the success and wish everyone a good stay in this beautiful campus. Thank you very much.
Thank you, sir. Ladies and gentlemen, it is the time for the inauguration. May I have the privilege of inviting Dr. Narayanan Kottivariyar to light the lamp and deliver the inaugural address. I request all dignitaries on the dais to accompany Dr. Variyar.
Saji. A very good morning to one and all. Respected Professor Kuruk, Dr. Saju Basi, Dr. Rebecca, Dr. Vijay Gopal, and other dignitaries and other faculty members assembled here. Thank you so much for giving us this opportunity to host the Kerala chapter of Association of Medical Physicists of India, the annual meet. A warm welcome to MBR Cancer Center campus. MBR Cancer Center has been in the forefront to promote wherever possible any kind of educational activity that will benefit patients. We are proud and privileged to host this meeting as well. Some of you would have attended our regularly conducted international conference, MBR CanCon. It's basically a large platform which provides a good opportunity to share their knowledge from different parts of the world. There are several foreign faculties as well as faculties from other parts of the country have attended in the past, and that has been a big success, and that has really helped in the patient care, patient management of this part of Kerala. At MBR, we are having one of the best radiation oncology department in the country, and needless to say, supported by one of the best radiation physics department as well, headed by Dr. Niaz Purkar. We have almost delivered more than 1 lakh fractions of radiation with the most accurate manner, as well as maintaining the safety as well as quality of radiation. This was made possible because of the knowledge and the dedication of our physics department. The morning I was talking to Professor Kurup and Dr. Dinesh. So that Dr. Dinesh was telling that the physics for us, especially the medical side, the physics was always tough to crack. And one of the reasons why I became a doctor was I don't want to study engineering or any other subject because of the fear of maths and physics. So when I was doing DM in medical oncology, one of the premier institutes of India, Radiotherapy Cancer Institute, vaguely I know that there is a department working in the department also in association with the radiation department. And the radiation physicists, because of the pressure of the work, I never had the chance to interact with them. Then until I was personally involved in the erection and commissioning of one of the first dedicated comprehensive cancer center in Manila, in my previous institution. I was really involved in their work, and I came to know their work very closely. It was very fascinating, how to calibrate the machine and how to check the quality and how vigilant are the various regulations which help us in delivering the safe quality radiation to our patients. That was the beginning. Then thereafter, even in this institute as well, I was closely involved with radiation physics. And the importance of radiation physics department, as well as the knowledge they should acquire, as well as updating this knowledge, how crucial is updating, I came to know throughout this year, because this is something which is developing very fast, especially with the new introduction of the 4D motion, as well as the particulate imaging and the protons. And one of our radiation physicists, I think two of them,
got selected there was a national call for radiation physicists to join the government program. So that itself shows that the quality of the department here. And so much advances like the proton therapy as well as the MR associate MR linked radiation machines. So that's always been a challenge. So this challenge, if if you have suppose you want to take up these challenges, so the one has to acquire all this knowledge. So this should be a continuing process, and so this is probably the today's. If you go through the topics, you can see that the topics have been chosen in such a way that that's why to help all our stakeholders to understand the various developments taking place in this field. This center is one of the few centers who are capable of delivering total body radiation. Similarly, I believe that molecular imaging also is coming to the radiation planning, and so much knowledge, and one has to keep updated himself facing this new techniques. I hope that today's discussion will be very fruitful. And one thing I forgotten to mention is about the artificial intelligence, the role of artificial intelligence in this radiation planning. I don't know, it's not fitting into this today's discussion. Or I thought that this is coming up in a very big way, and there is always a chance for improving the radiation planning by the help of artificial intelligence. And I am one of the few persons who believe that artificial intelligence will not make you lose the job opportunities, but will definitely help in the better patient care. So I'm sure today's discussion will be very fruitful, and you will learn something significantly from these discussions. And all the faculties are very eminent in the field, and enjoy, as Professor Kurup rightly said, we are proud to have such a nice campus, and the weather also is very I don't know whether to call it as bad weather or a good weather to have some good feeling here in the campus. So I wish you all the best, and enjoy, and return with full of knowledge about the large field radiotherapy. Thank you once again.
Thank you, sir, for your great words. May I request Dr. Rebecca John, Chief Operating Officer of the NVR Cancer Center and Research Institute, to speak a few words on the occasion.
Good morning to everyone. On behalf of MBR Cancer Center and Research Institute, it's my honor and privilege to extend a warm welcome to each one of you, to all the respected guests on the dais, to all the dignitaries who are present here as speakers, and to all the delegates. We are indeed privileged to have very senior and expert speakers with us for the day, and I'm actually amazed to see the hall full. I didn't know that there were so many medical physicists and people involved in radiation oncology even in this place. So I'm actually happy to see this hall full and people who are willing and want to learn. So, and you all are coming from very diverse institutes, organizations, and you are bringing in your own perspectives. So, throughout this day, we wish that you have a fruitful time of engaging in discussions, knowledge sharing, learning from each other's experiences. Like Sir said, the field of medicine itself, the applied medicine itself, is changing, ever evolving. And every time we procure a machine, in 1 or 2 years, there is already another treatment modality in place and another new machine coming up. So that's so fast. So the only way that we all can keep updated, keep up to our knowledge, is through these collaborative meetings and knowledge exchange that we can have with each other. So we wish that throughout this day you'll have a fruitful learning experience. And I also want to take this opportunity to congratulate and to appreciate the organizing committee of the AMPI for organizing this. I know it's their tireless efforts, a lot of their time that has made this day a reality. So wishing you a good day ahead. Thank you.
Thank you, ma'am. I invite Dr. Vijay Gopal KS, Senior Consultant and Head, Department of Radiation Oncology, MBR Cancer Center and Research Institute, to grace us with his thoughts.
A very good morning to the dignitaries in the dais and of the dais. First of all, I thank the AMPI-KC chapter to giving this opportunity and putting up a theme like extended field or large field radiotherapy, just concentrating only on TBA and T-cells. A very beautiful topic. Apart from the technologies, execution of TBA is a very good teamwork. So all the technology we will learn today. So the execution of the treatment probably you may not learn from here. That needs very coordination from the ground staff, that even the cleaning staff in the radiation department to the bone marrow transplant unit. A well coordinated effort is needed. So that's what I learned from my alma mater, CMC Vellore, where I had the opportunity to learn the conventional TBA, probably 20 to 30 TBAs every year, and I had the opportunity to see how it is evolved in the hands of Dr. Niaz with the VMAT-based TBA. So probably, as Vajra said, we are the first institute to begin with the VMAT-based TBA. So I take this opportunity to thank Dr. Niaz and Dr. Dinesh for their great effort to begin this program. As well as there is another thought block in the TBA is that it or a notion that it should be done within the same unit, same institute, where they do the TBI and bone marrow transplant. So we have break that notion also. We have helped one of our esteemed institute in Kerala to begin with their TBA bone marrow transplant program, with doing TBA in our institute with the help of our bone marrow transplant unit, and thanks to Vajra sir for that. So probably when you learn these technologies and go back and start practicing, there are a lot of hospitals without having radiation therapy and may not be using TBA for their conditioning regimes. Probably we can look into that and extend our expertise to for a better patient care. Thank you everyone. Let's have a good day.
Thank you, sir. With that, we come to the end of the inaugural ceremony. Thank you all for joining us on this momentous occasion. May I request you to kindly join the audience for the remaining sessions. Moving on, let us begin the first scientific session of the day.
Best meetings we ever had on last week, right? And be grateful to the AMPI Kerala chapter for setting the platform for this wonderful topic, breaking the barriers in last week. And it's good to see a large number of students also here. Currently, I work in Mangalore AMPI Hospital, and I believe a lot of students have joined from Mangalore University also. I just want to see how many of you have turned up for this, because you have a large crowd. Because we teach Mangalore University students who are posted in our center, and we are having good collaborative work. I'm sure this will be a good knowledge experience for you. I also would like to thank my first guru in radiation physics, Professor BGG Group Sir. And if you look at my initial days of training in RCC Toronto, the first teacher we had was Professor T.P. Ramanandra sir. And I always remember Guru sir and T.P. Sir giving us the fundamentals of radiation physics in our class, especially the first classes were joint collaborative classes with the radiologist also. Those days we joined together, and the Meredith and Massey book was our guide to begin with. And we all started with the most difficult, the interaction of radiation matter. And with all the coherence to be learned from this exercise, but I am really happy to see that TPR sir's talk is being arranged here, and that was supposed to be the first talk, and I think Professor Thayal will be doing it next. Okay. So it's a wonderful moment for me also to be with my old teacher and bring back memories of my first initial, So let's learn together, because total body radiation or large field radiation is a topic which is new to everyone in the field, and we are all learning on the job, because only very few cases have been initiated in the various centers of the past. I think MVR has done close to 12 PBI in the last 3-4 years, and we also had a fortune to do the first allogeneic transplant in Mangalore last month, and that was the first transplant in Mangalore. So we are just beginning in this journey, and this conference will be an ideal platform for us to pick up those nuggets of wisdom and help us grow better in this field. So, can I make this prediction? Right. So, large field radiation therapy began its origin when we were student days. The evolution started with all of us using total body radiation in the form of upper body and lower body for palliation. So that was the initiation into large field radiation therapy, because those days systemic chemotherapy was not very strong, and we were using more of these upper and lower body radiation. Upper body, if you remember, used to give around close to 800 centigrade, and upper body was around 600 centigrade because of the lung, and lower body used to give around 800 centigrade. So that was how we evolved into large scale radiation therapy. We also would discuss a bit about radiobiology of TBI, and something about the clinical toxicities also, and the measures to make TBI safe and effective. And we also will have a joint discussion on probably in the talks to come, how we can take the science forward. So, what is the power of TBI? Why TBI has got a place in bone marrow transplant, in leukemias and lymphomas is its strength, because unlike systemic chemotherapy, it has got a lot of its own strength. We know the sanctuary sites in the brain where the leukemic cells are protected from the effects of chemotherapeutic agents. The most important sanctuary sites are the testes and the brain, where the chemotherapeutic drugs will not reach in adequate concentration. So radiation doesn't have this kind of limitations. It can, pervade into all the spaces with equal efficacy and competency. And it gives a good dose of homogeneity regardless of the blood supply, less chance of cross resistance with CT, no problems with excretion or detoxification. It's a very, if you ask me, radiation is so divine, it cannot be adulterated unless you have a very, 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 poor physics team in the quality assurance program. So, unlike other treatment modalities, radiation has got a lot of strength in its efficacies, and purely because it's very pure in nature. No problem with excretion or detoxing. Dose tailoring by boosting specific sites. This is also another important thing, because as you can see, many of the centers are migrating from the conventional techniques of extended SST to TBI with VBAT techniques, with the new machines. I think as a new generation, we'll be using more of conventional the intensity modulated techniques in your practice. So we can actually boost this, residual sites. If you have a situation where you have a testicular labs or you have a residual disease following chemotherapy which has not fully responded in the PET scan, you can actually boost the sites with radiation. So that's an added advantage with radiation therapy practice. So, looking at the history, the clinical evolution in a slightly interesting perspective, I was just trying to read this history of TBI, and you would notice that the TBI, actual TBI started with Friedrich Desor, which actually is a Jewish scientist, and it's very interesting to note that he was more of a political person than a scientist, because he had all his energy trained against the cruelties of Hitler, and Hitler was so distressed by him that he decided to, he had two choices, either to put him in a jail or send him somewhere. Luckily, the Turkish government invited him as a professor in University of Istanbul, and he escaped prison and later gave his service to Turkey. So very interesting to see that the whole TBI evolved from his unique concept of, as you can see in the picture, this history speaks volumes about his dedication and the kind of struggle he had, both as a scientist and as a political person. So it's a wonderful way to eradicate the residual malignant cells out of the immune system. That is also a very important point. It's not just eradicating the cancer cells, it has an effect on the immune system also, especially when you're using a low dose TBI. The effect is more on the immune system than killing the cells, and can uniform biological effect on the scientific sites. Okay. So coming to the radiobiology, and the lymphocytes are extremely sensitive to radiation therapy because they have this unique property of apoptosis. We call the process of apoptosis, programmed cell death. The cells dies within the contents of the cells which are destroyed stays within the cell and they're not extruded out of the cell. So it's very, very sensitive to radiation, and the D0 of lymphocyte is oscillated to be around 0.5 grade to 1.4 grade. If you use a hyperfractionated TBI, the effective D0 will be around 3.8 grade. So hyperfractionation is also one way of delivering radiation therapy to reduce the toxicity, and some of the schedules use multiple fractions per day. So if you extrapolate hyperfractionation in the TBA program, you can have an effective D0 of 3.8 grade. So suffice to understand that we are dealing with a cell which is very, very sensitive to low dose of radiation therapy by virtue of a low D0 level. So probably one of the very sensitive mammalian cell in the body. So a bit more about radiology for the students. A very small shoulder on the radiation survival curve has been noticed, suggesting little repair between fractions. Clinical data has revealed similar findings in patients undergoing hyperfractionated TBI, where the lymphocyte survival has an effective D0 of 3.8 as mentioned. Radiologically relevant levels of hypoxia are unlikely in the hematopoietic compartment. Repopulation is not likely to influence hematopoietic cells. So all the 4 hours of radiology, if you take, repopulation has got little relevance in this, and redistribution also will it may have some significance because of the time scale of TBA, because that needs to be factored in. So the repair, redistribution, and repopulation. And if you look at these principles of radiology, redistribution could have a role, and repair would be slightly less of a concern, and hypoxia will have very little bearing. So again, you would wonder whether this would be the same for a leukemic cell also compared to a normal lymphocyte. So leukemic cells are thought to have a cell survival curve with a minimal shoulder and varies across cell types. That's very important because it's not the same for all the types of leukemia. As one of the papers by Kostek has shown, AML demonstrates little repair, whereas CML demonstrates repair. Most of the cell lines, ALL, myeloma, and lymphomas, have not been well studied, and but they appear to demonstrate a wide range of repair capacity. Probably as students, as you experiment with cell lines, you would probably look into this in finer detail. So, as I mentioned, when we were students, the magna field was essentially an upper and lower TBI. those days, the systemic chemotherapy was not very evolved, unlike in the present times, where you have wonderful systemic chemotherapy. We hardly get a chance to treat a bone metastasis from a breast or a prostate these days with upper or any body weight. It's been a long time since we had a reference, because we don't need that, because we have got effective chemotherapeutic agents. And you must remember, I think you would remember that the concept of oligometastasis come up very strongly now. And with PET scan imaging and better delineation of your targets, you don't have to deplete the entire bone marrow with such large fields like upper body or lower body to achieve a dilation. You can do that with very focused radiation therapy. You also have a wonderful opportunity to combine extreme hypofractionation for oligometastasis with immunotherapeutic agents. So the whole concept of TBI and upper and lower body radiation is paled into insignificance these days. But total nodal irradiation is also a large field. That also is very used in very less manner, because again, for lymphomas, you've got effective chemotherapeutic agents, the targeted therapies, the immunological therapies have come out so strongly, and we hardly get a chance to use that. I think the last time we used it was during our RCC days, when we have the upper and lower, the mantle and the inverted pie feeds. The first case of Lermy syndrome I ever saw was those days, when there was a mismatch in the upper and the mantle and the inverted Y, and this patient had a Lermy syndrome, which was self-limiting. So there are some problems when you actually use this as treatments, but not in modern era where these treatments are not done. But there is a role for TNI in transplantations also, where we can actually minimize the use of cyclosporine and other drugs, but those are not being used much these days. The mantle fields have died down, a slow death, unlike earlier days. We hardly get a chance, because the whole philosophy of managing Hodgkin disease revolves around chemotherapy and involves site radiation of various particles. So no need for. But sometimes we do get a chance in a clinically specific situations. So whole abdominal radiation, coming to that, it was popular for some time, especially in CA ovary, where in refractory cases we use whole abdominal radiation, especially with VMAT techniques, where you can spare the kidney, the liver very effectively, unlike the moving strip techniques or the Martinez technique of whole abdominal radiation, where you actually shield these organs. With the modern VMAT planning, we can optimize the dose to the abdominal organ so effectively we can deliver it. But this practice is also getting slowly downgraded because of the evolving concepts of the surgical techniques, especially the intraperitoneal chemotherapy with the high-PEC and the P-PEC treatment. So technological changes also gives a challenge to this time-tested nighttime field treatments. T-cell is very important. Still, it is still a strong forte in mycosis fungoides and T-cell lymphomas, cutaneous T-cell lymphomas. And it's a very interesting topic. I won't be touching on this because Dr. Sajju Bhaskar will be dealing with it extensively in the next lecture. But we had an opportunity to treat around 15 patients at Amrita Institute of Medical Science, where I worked for almost 12 years. And Professor Bhaskar sir was extremely helpful in putting the T-cell programs there. So it's a wonderful way to treat the skin, because the largest organ in the body, the skin can be treated effectively with electrons. So I also learned an important thing during those days: when you order the electron, you should have high dose electrons included upfront, otherwise you won't get it later. So whenever you buy a VINAC, make sure that you have an HDRA incorporated, otherwise you will now be able to do a reset. And after you buy the machines, you will never get this later. So that's one lesson I learned those days. Okay, so evolution of TBI, total body radiation, the preparation is very important, and you can use a single fraction schedules or multiple fraction schedules. Here at MVR, the most common schedule we use is 12 grain 6 fractions, and that is, I think, we are complete around 12 patients here. So that's very safe and effective. Unlike single fractions, the fractionated schedules are very, very safe, and you don't have to really worry too much about the lung toxicities. We'll come to that subsequently. Evolution of TBI, if you look at, you can have a myeloablative or non-myeloablative regimes depending upon the patient's physical condition and the relevance of the treatment programs. So single fractions, low dose 200 centigrade is also in the theme. The NCA has got this wonderful low dose. It's very, very easy to use, less toxic, and you can combine with chemotherapy regimes. What you should understand is when you evaluate the stem cell transplant programs, it's a very heterogeneous cohort because different centers will be following different intensities of chemotherapy, and you cannot standardize the whole thing and come to a conclusion. So when you look at the literature, it's a huge jungle out there because you have got various chemo schedules, the various radiation protocols, the timing of the treatment. So all those things, interplay with the evaluation of toxicities. So one cannot be very judgmental by looking at these papers. So you have to carefully read the schedule, the intensity of chemotherapy being used, and the type of dose fractionations before you come to a conclusions. So single large fractions or large fractionated dose, extended SST, and we also have moved over to VMAT planning in majority of the centers because very, very easy because unlike the implementation of the TBA program is difficult because if you want to buy all this, the extended SST, you need to buy the stand, the sideboard, the blocks. So all those things are expensive. So if you have a LINAC which should help you have a TBA program with multiple fields, that would be the best way to go about it. And I think centers are moving slowly into that. And we'll learn about that more in this process. I think we have a wonderful talk on chemotherapy also in this session. Okay. Use in children, that is one of the distressing things, and I was just looking at the literature because I was worried whether we can use it safely, whether chemotherapy alone is sufficient for children. But the recent trials have shown that there is a 20% benefit if you use TBI in the transplant program. So I think in pediatric age group also, TBI plays a good role. So hematological response to TBI is something which you all know would be highly variable with varying dose rate, dose prescriptions, and the kind of fractionation schedules we use. The immediate toxicity when you manage TBI is extremely important. And these are some of the papers which actually looked into the immediate toxicity because when you use such intensive chemotherapy and radiation, one has to really put up with the challenges of immediate toxicities, the toxicities that occur at the time of treatment. And that is very closely related to the intensity of chemotherapy use, the type of radiation used, the single fraction or a fraction use, the dose rates also is very, very critical. So we'll delve deep into that in the subsequent sessions. The most important toxicity which we have to put up with is the pulmonary toxicities. The lung toxicity is one of the most critical thing, and we would highlight that only in this present talk. And the major dose-limiting toxicity TBA is pneumonopathy, and which can be restrictive or obstructive lung disease. In the settings of HSCT, radiation pneumonopathy can be very difficult to distinguish because you have the effects of chemotherapy drugs also on the lung, the pneumonitis caused by the chemotherapy, in a drug like in a lymphoma case, a drug like bleomycin or busulfan, everything has cyclophosphamide. All these drugs have got lung toxicities, and to separate toxicities from radiation and chemotherapy is extremely difficult. To add to this challenge, you have the process of infection in the lung also causing the same radiological changes. So evaluating pneumonopathy is a huge challenge in stem cell transplant programs, and that makes it very, very difficult and challenging. So late pneumonopathy can occur in 10 to 26% of the patients, especially in chronic GVHD patients who are elderly, immunocompromised, and they have higher stages, and they are also having some genetic predisposition. All these would add to the complexities in evaluating pneumonitis. TBI has also shown to be a risk factor for idiopathic pneumonia syndromes. Rare rates of pneumopathy in patients receiving TBI vary widely from 10% to 84%. That's a literature variation. that really shows how much interplay of various treatment modalities have got a role to play in inducing pneumonia. Okay. So in the modern era, with appropriate TDA techniques, if you follow the same schedules which we follow here, the risk of pneumopathy in patients has not increased at all. It's very, very manageable, and it's not of a major concern. The significance of the problem is clear because once you have a major pneumopathy, the mortality rates goes up significantly. So that's very, very important because you must realize that the lung is a very, very critical organ in the body, and if you really, assault it, it is going to be a real problem. So there are two RCTs that demonstrate fractionated TBA can reduce pneumonitis compared to single fraction TBA, and so fractionated TBA is the way to go. And if you can restrict the dose to below 9 gray to the lung, the risk of pneumonitis will be very, very less. So these are the various dose response models, and you can see a safer dose of less than 9 gray would result in very little risk of pneumonitis. Dose modeling has been done with various dose modeling schedules for pneumonitis, and you can see that it's very variable. 7% to 41% is the IPS rates, and the dose rates which are very safe would be fall around 4.8 centigrade per minute to 17.5 centigrade per minute. That would be the trade-off dose for making your pneumonitis problems less intense. So dose rates, lung sheaths, and pneumonitis has been a very interesting theme in evaluating pneumonitis rates, and that is something which can be done with more precision, with better data, and probably with good collaborative data and good data from major centers. One can come to better conclusions. So there is an abundance of retrospective clinical data suggesting that lowering the dose rate to less than 0.025 to 0.09 gray per minute does decrease the likelihood of pulmonary complications, especially if TBA is delivered in a single fraction. So fractionated TBA, as I mentioned, is very, very safe when it comes to the risk of pneumonitis. Cardiac toxicity is also a very interesting challenge, and especially when you use anthracycline, the adriamycin, drugs like adriamycin are cardiac toxic. So again, a problem to separate the effect of radiation from the effect of the drugs. So mostly the cardiac toxicities are caused by chemotherapy agents like anthracyclines, than primarily due to radiation therapy. It's prudent to screen the patients undergoing stem cell transplant for the cardiovascular risk factors so that you can minimize the risk of subsequent cardiac toxicities, liver toxicities like veno-occlusive disease. So fractionated TBA again reduces the incidence of veno-occlusive disease compared to single dose fractionation. So again, one more point in favor of fractionated. Visual toxicities. Cataract is always the most common complication of TBA. And delivering TBA in a single fraction is the single biggest risk factor for cataract loss. So again, high dose rate more than 0.035 to 0.048 gray per minute TBA appears to increase the risk of cataract formation. So dose rates and delivering in single fraction increase the visual toxicity. Renal toxicity is also another important challenge. Endocrine toxicities is also a major, especially like in head and neck cancer patients. We have to follow up these patients lifelong for hypothyroidism, elective use of L-toxin supplements. So we need to follow up these patients for hypothyroidism also in the stem cell treatment programs. There is no dose threshold effect, so you need to monitor these patients quite stringently for hypothyroidism. Okay. Up to 15% of patients with TBA to 15 gray can develop endocrine toxicities. So coming to another major problem, because most of the adolescent patients who develop, how much time I have? 5 minutes, okay. Okay. So suffice to say that you need to use sperm banking and oocyte banking in these patients, because all these patients will become sterile, infertile if they use intensive chemotherapy. But in males, the Leydig cell function is typically preserved in the given dose of radiation delivered for TBA. So we need to look at the hypothalamic pituitary function of these patients during follow-up.
Bone toxicity is also important, so you can improve the bone health, do DEXA scans to look for osteoporosis, and supplementing with calcium and vitamin D are good options. Nervous system, again, the neurocognitive impairment is a challenge, and you need to monitor these patients for neurocognitive side effects also. So in young children, TDA-based regimens appear to exert more of a negative effect than non-TDA-based regimens. So this is one area where we need to be careful in using the right dose and fractionation to minimize the neurotoxins. Another important challenge we have is second cancers, and post-transplant lymphoma diseases are always a challenge. Second injection of leukemias, solid tumors, second cancers like non-Hodgkin's lymphoma, Hodgkin disease can also come up in this patient. So all these patients need to be followed up. We call this cancer survivorship issues. So the second cancers can also be a real challenge. So to make our TBA policies more effective, what is the role of radiation oncologists? Where we need to have a good consultation and decision making, a coordination of the patient's care with the transplantation services, participation in the treatment planning process, right from immobilization techniques, simulation, block design, prescriptions, dosimetry, physics review of treatment, verification images, clinical assessment of tolerance. All these needs to be combined to make the program very efficient. And we need to work in tandem with the strongest member of our team, the medical physics team. And they would establish the dosimetric measurements, the calculations, and the shielding requirements, establish a system for beam spawning designed to adjust the dose at the beam entry surface. Because you must remember that the skin dose needs to be, skin is also an important target, and one should not compromise the skin dose. And you need to cover at least 95% of your prescription dose in your skin volumes. So initiate good QA programs, act as a technical resource for planning immobilization devices, generation of good dose calculations and dosimetry measurements. These are very, very important, and we'll be discussing more in the subsequent session. So this is our picture. We used the first allergenic TBA we did in our new workplace. Last month, we had a 200 centigrade total body radiation as part of the NCA protocol, and this diamond-shaped field extended SST of 3.5 meters was used, and this was a patient positioning, and we did a CT-based extended SST TBA plan, and our physics chief, Dr. Jayapal, used some subfields to improve the skin doses, and it is easy to plan extended SST CT-based planning more easily in the AAA algorithms. And I don't know, modern physics, people use a lot of subfields to sort of feather out all the dose irregularities, and that's something which is interesting. And you can see the subfields used liberally to make sure that the dose is quite homogeneous. And interestingly, we did a TLD measurement also, and that came out so beautifully. We have a PhD reader in Bangalore University, since we are having a lot of students from there. Professor Karnagan is a very resourceful person to help us do the TLD reading, and we put a TLD material in a phantom, and did a phantom measurements. And if you look at the glow counts at the normal SST and extended SST, it's almost matching, and the counts are quite good. So this is the blood counts. You can see how the lymphocytes counts drop down, and reaches 0 levels, and the platelet counts also get dropped. So you have to monitor these patients, and very often we don't see these patients. They'll be in a bone marrow suit, and we'll be looking at the counts in the electronic medical records and looking at the temperatures. It's more of a virtual review than a real-time review, because they'll be quite isolated with less access to most of the caregivers. So to conclude, addition of TBA in HSCT is safe and effective if it is well deliberated to achieve an optimal therapeutic. So you need to work as a team and evolve a department protocol. Enforce good clinical efficacy in balancing the toxicities. As I mentioned, you have seen the list of toxicities, and you need to really be careful to see that you address them correctly. And reduce the therapeutic sequence. That's very, very important. Because, patients should not survive to bear the cost of your treatment. So you need to really balance the dose to the various organs and see that you don't cross the boundaries for added toxicities. ensure good quality control with the initial team. So that's also very, very important. So thank you very much for your very patient listening. And I don't know whether I did justice to a very complex topic, because I'm also learning in this whole area. It's been an eye opener for me also to see the complexities in the literature, how still we are in the learning process in our understanding of TBA. And I'm sure this, as we go down this day with all the talks and by eminent teachers here, we learn better. So if you have any questions, I would be glad to answer if you have the time, or we can take it during the subsequent sessions also.
Thank you, sir, for a very excellent presentation on clinical requirements. I think most of the physics students may not be knowing the clinical background and how complex is the and challenging is the maintenance of PDA program. So any question, take a couple of questions.
I'll have one question.
Okay.
So you're talking about our aim is to eradicate the whole body. So is there something like missing the target in TBA? Like you miss a particular region that will lead to failure?
Okay, that's a very interesting question. In fact, if you look at the TBA program, this question is addressed in total marrow irradiation. Whether TMI, total marrow irradiation, can be a substitute for a TBA, because people have people who are very old or very sick, who cannot have a very intensive TBA program. In fact, literature is divided. In fact, the risk of failure from missing is not very high, because the intensity of chemotherapy being used also is so high. So it's not statistically significant, but you can, from the physics point of view, you can argue that you are delivering a less dose and you are inviting a failure. But in practical terms, I think we should deliver the uniform dose. That's very, very important. And it's very difficult to get a data attributing the failure to the inadequate dose. That data will be very difficult to get from practice, because you need large numbers, you need a uniform schedule. So the total marrow irradiation is something very complex, and I still don't understand in which situation you can really use it very safely. But as physicists and as clinicians, with the kind of uncertainty, I think it's better to, with the modern technology, I think it's not a big challenge to deliver a uniform dose. I think I think we should stick to it. I think we should not make that as a variable for uncertainties, which can happen. I looked into this specific problem, but I couldn't get an answer from whatever I could read. But any suggestions from other groups?
As a correlation to that, like when you do the total marrow irradiation, we'll not be irradiating the skin. So, but in the presentation you told that the skin dose is also important.
Correct. It's but you must remember that the transplants programs without TB is also equally effective. So that's a whole point of contention, because TBA is not really seen as a a must-have situation, because you have non-TBA based ability programs also being equally effective. In fact, this is contested in the medical oncology field. Some of the it all depends upon the confidence of the meta-oncologist in your team to absorb this idea. You will have a very reluctant person also, because you would attribute all the bad effects to the radiation, whatever happened. So that would be a kind of a mismatch.
Why skin is so important? Why the skin dose is important?
It's a circulating. So when you miss an organ, it's always a systemic. You're missing the cells. So because at some point of time, you're looking cell to be coursing through the skin also. So or there will be some stem cells remaining in the skin. So the stem cell, eradication of stem cell is one of the major challenges. That's why we fail in cancer treatments, because very often when we have a good local treatment, we always see some stem cells which are outside your treatment fields progressing after many years. So in a metabolic stem cell transplant program, it's all the more pertinent that we don't miss out this quiescent stem cells lingering in any part of the body or circulating cancer cells. So from these two contexts, we need to give uniform treatment.
Okay. Thank you, sir.
So we will move on to the next session. Thank you. Thank you very much.
Mr. Monson, as a token of our appreciation, I request Dr. Rebecca John, CEO of MBR Cancer Center, to present a memento to Dinesh sir. Thank you, sir. Thank you, ma'am. The next talk of the day is large field electron therapy, research by Dr. Saju Basi, additional professor, RCC Trivandrum.
Good morning, all. So, the total skin electron therapy. So, this is also a part of the large field treatment that we regularly deliver in a clinic. So, what is total skin electron therapy? So, as the name says, we are irradiating the whole skin with an electron beam. And here, our target is the skin. So, the best way to treat skin is by using a radiation beam which doesn't penetrate much into the body. So, as the name says, total skin electron therapy is a radiotherapy technique wherein we want to deliver a prescription dose to the skin, which is our target, and reduce the dose to the critical organ underneath the skin. So there are, if you go to the literature, there are many terms that are used to describe total skin electron therapy as the high dose rate electron therapy or the total skin electron irradiation or total skin irradiation. So there are a number of names that have been coined for this particular delivery technique. So why total skin electron therapy? So it was introduced as a treatment for the T-cell lymphoma. And as I said, our aim was to irradiate the whole skin with a prescribed dose. And as in any radiotherapy process, when you want to deliver the dose to the target, you should always have a aim to deliver or protect the organs or the critical organs. So we need to have it to reduce the toxicity. So that is the main aim. As well as we don't have to miss our target. Now, whenever we want to have a procedure done, especially when it is an unknown area, we should look for guidelines. So there are basically two guidelines that guide us in implementing or practicing total skin electron therapy. One is the European guideline and the other one is the AMPI-KC guideline. So when you go through the guidelines, there are main sections in the guidelines that you should be looking for. One is the prescription. What type of prescription are you going to deliver? So there are basically two courses of radiation. One is the standard course, where we go up to a dose of up to 36 gray over a period of 6 to 10 weeks. And there is a short course duration that is being recently practiced. So with a 12 gray dose in a period of 3 weeks. Now, looking at the field parameters, what type of radiation beams are you going to use when you want to use T-cell? So the energy can be between 3 to 7 MeV at the patient level. So when you say that, okay, you want to bring the energy in the range of 3 to 7, you should have at least 1 to 2 MeV higher at the beam exit level. So your machine will have an energy in the range of 4 to 10 MeV. And what will be the SSD? Definitely your field is going to be large. So if you want to treat large field, you should have a large SSD. So 3 to 8 meters is the recommended SSD. Then the field size. Definitely you need to cover the whole body. So you need to have a large field in the order of 200 centimeter and 80 centimeter. Then what about the homogeneity of dose that you're going to deliver to the patient? Again, the European guideline says that the European guideline says that the dose uniformity has to be within 10%, whereas the TG says that it can be plus or minus 8% in the vertical direction. But when you go in the horizontal direction, it should be within plus or minus 4%. What about penetration? How deep you want to treat for total skin electron therapy? So again, the European guideline says that 80% of the isodose must be at least 4 mm from the skin surface. So 4 to 5 or 5 to 10 mm is our target depth that we intend to treat. Again, how should be the fall-off be? Because we don't want to treat the underlying normal structures or the normal tissue. So again, there's recommendation on how sharply the dose has to fall. So again, the TG says that 50% of isodose line should be within 15 mm. So that should be the kind of dose fall-off that is required as per the guideline. What about the maximum dose? So earlier in the TG, there was no much mention about the maximum dose, but these days the European guidelines, which is the much younger one, says that 120% has to be the we have to keep the maximum dose to less than 120%. Now the main important thing is the photon contamination. See, when we treat with electrons, there's going to be some amount of photons, that unnecessary photons that come in along with the beam. So that contamination, we call that as a contamination because it's the unwanted part of the beam. So that has again to be restricted, and there is again guidelines on that because of the importance of it. So this is the guideline as in total. So I'll just go through it. Now, what is the main difference between when you treat with a photon and an electron? So when you use a photon beam in our regular treatment, we are always targeting tumors which are deep-seated, and our interest is to spare the skin. And the total dose is always split between the beams that you use to deliver the particular dose. Whereas when you use electron, the whole picture is changed. Here we are targeting shallow tumors which are very close to the skin or the skin itself with no skin sparing, and the target is covered by each beam with each individual dose. It's not like you're splitting the dose to different beams. Now, what are the different techniques that are there? So we have the guidelines. Whatever technique you follow, you have to meet the guidelines. So from some of the practice techniques are the patient shift techniques or the rotational technique and the large field technique. We'll just go through one of each of these techniques. So this is the patient slide technique, called the Christie technique, wherein we have the radiation beam and the patient is slided along the radiation beam from one end to the other. So it may seem that the process is very simple, but the dosimetry is a bit complex, and the patient has to be moved at a constant rate. And if you change the prescription dose, then again you need to retune the couch movement. Okay, so in theory the process is simple, but in practice it brings in a lot of complication. So most of the centers, instead of having a translational technique, an automatic couch movement, they fix the couch position and give stationary beams. So this is again, we are treating the patient with multiple stationary beam instead of moving the couch. Now, if you don't want to have multiple beams, another method is you treat the patient with multiple angulated beams. So here, this is a 6-field technique wherein you treat the patient from 6 directions: anterior, posterior, and 2 anterior obliques and 2 posterior obliques. So again, the patient will be lying in the couch. So this is the 6-field technique as practice. But the main difficulty over here is the positioning time. You need to position the patient from left side of the couch to the right side. So the positioning of the patient takes a lot of time. Now again, if you don't want to have a patient treated at a short SSD, then increase the SSD by placing the patient on the floor. So again, you use a beam spoiler also, so that you can have maximum scatter and increase the dose uniformity. Now this is one of the most popular technique, which is called the rotational technique. And again, there are 2 methods by which we can do this rotational technique. One is, if you have a very large room, you can have a very large SSD. You can have the patient placed at a distance of at the maximum distance available, which is in the order of around 7 meters. So if you have a very large room, you can use a single beam to cover the patient, and the patient will be placed on a stand which will be rotating. And the patient rotation again is controlled by how much dose you want to deliver. So there is a lot of dosimetry that has to go into this technique. Now again, if you have a very short room, like instead of 7 meters you have a 3-meter room, then still you can practice the rotational technique, but here you need to introduce additional scatter in the path of the beam, so that again you spread out the beam to cover the whole body. So if you don't want to have any scatter in the path of the beam, Another technique that is followed is again you have the patient rotating on a platform, but instead of a single beam, you can have a dual beam, dual angulated beam. So thereby, still you can use this technique on a normal Linac bunker with short SSD. Short SSD means at around 3 meters, which is usually available in most of the bunkers. But you can have the rotational techniques practiced. The most popular technique, the Stanford technique. So Stanford technique again is a 6-field technique in which we have the patient standing at a large SSD of in the order of 2 to 6 meters, again depending upon what is the SSD that can be set up on your Linac bunker. So how do you do the standing 6-field technique? So you open up the field to 40 by 40. That is the largest field that is available on the Linac. Then the SSD, the maximum SSD that can be set up, 3 to 4 meters. So what happens if the SSD is less? If the SSD is too less, your field will not be adequate to cover the patient body. But what if you put a large SSD? Again, the problem of inverse square law comes in there. You will lose the dose rate. So you use multiple angulated beam, and another important thing that you should be careful is you should angulate the beam such that the center of the beam is directed away from the patient, because you know that when you have an electron beam, you have a tail region which is nothing but the X-ray contamination. Now you don't want this X-ray to fall onto the patient body, because as I said, we are going to treat the patient with 6 fields. So when you irradiate the patient from 6 direction, and if you have an X-ray contamination in it, this X-ray dose is going to penetrate deep into the patient, and it's going to be a cumulative one. Okay, so if you want to avoid the patient from getting this X-ray dose, what do you have to do? You have to direct the center of the beam away from the patient, because most of the X-ray contamination happens along the center of the beam. If you see this profile, you can see that the X-ray contamination is along the beam center. Okay, so another thing that we have to use is how we can produce maximum scatter, and thereby increase the uniformity of dose. For that, we use something called the beam degrader or beam spoiler in front of the patient. So there's nothing but a low Z material which is kept at around 20 to 30 centimeter from the skin of the patient. So usually it's made up of 1 centimeter PMMA polymethyl acrylate, and it reduces the mean energy of the incident electron beams, and it produces scatter. So it produces a dose uniformity for the whole patient. How will you combine the two fields? What will be the angulation that you have to use for having a uniform dose? So from the literature, you can see that usually the angulation that gives a uniform dose is anywhere between 15 degree plus or minus 15 degree to 20 degree. And again, it depends upon what is the XSD that you are going to use in your clinical practice. Now, as I said, we are going to treat the patient with 6 fields, or treat the patient from 6 directions. So on day 1, we will be treating the patient with an anterior field and 2 posterior obliques. And day 2, we are going to treat the patient with a posterior field and 2 anterior obliques. So these are the 6 fields that you are going to treat. Now, if your machine is able to deliver a field that will cover the patient's skin in a single with a single field, for example, if your beam is so divergent enough to cover the anterior field, you can use a single field. But most of the SSD setups will not have a field to cover the whole body. So each field has to be again divided into 2 diverging fields. So the anterior part of the patient will be treated, or the anterior field will be treated with again 2 diverging fields, and upper part and the lower part. And those areas which doesn't receive the adequate dose, for example, the sole, when the patient is standing, the sole of the patient will not get adequate prescription dose. So those areas, the scalp, those areas has to be boosted. So mostly the regions that need boost will be scalp, the perineum, infrafemoral mole for obese patients. Obese patients, there will be folds of the fat. So all those regions has to be again boosted for adequate dose. Again, there is another issue. We need to shield or protect certain regions from radiation. So mostly we want the areas to be protected are eyes, lip and nail. So we need to have adequate shielding materials to protect these regions. Now, as Sir was saying, we should be using the high dose rate. So why high dose rate electron? So what is the difference between the high dose rate electron and a conventional electron beam? It's basically both are electron beams. But since we are using a large SSD, as you know, when you go further away from the isocenter, your dose rate is going to decrease. When the dose rate decreases, what happens? Your output is decreased, your treatment time will go up. So in order to compensate for that, if you are able to produce more radiation or more, you are able to increase the dose rate, you can keep the time factor under control. So you should have a high dose rate mode for when you want to practice TBI. So what is the difference between the high dose rate electron and the conventional? Mainly on the dose rate. Then in your conventional treatments, always you need an electron applicator to define your field. Here you don't need an applicator. You want to just open up the field to the maximum value. So you can still fire the beam without an applicator. So that is the main difference. Now, if you want to start TBI in your department, so what are the techniques that you're going to do? So you have a number of techniques available from the literature. So you review a literature and then visit and discuss the techniques with your colleagues, because there will be a lot of hospitals in the surrounding who will be practicing TBI for a long time. Their experience is always a useful thing for you to start with. So always have a discussion with your colleagues on whatever practice they do, then come back and check whether those practice is feasible in your department. Check your room dimensions. Am I capable of implementing that particular technique in my hospital? Is my equipment having those features to do that particular technique? Then have a group discussion, because it's always a teamwork between the oncologist, physicist, and the technologist to have a good TBA program, sorry, TSET program. Now let's have a look at how we did our TSET program. So we went in for the modified Stanford technique. Why? Because our room dimension was only 3 meters, so we couldn't practice the any other of the techniques. So we went in for the modified Stanford technique, and we even looked at how we can implement the rotational technique. Again, it was a bit complicated on the rotating platform, so we didn't go in for that. We decided to go in for the Stanford technique. Again, the first thing what we did is we visited the centers which was doing it. So at that time, Amrita was doing it, and Soumya was helpful to explain to me how we can do the procedure. Now we have to find out what are the dual angles that we have to use when you want to treat the patient. So how can you do that? First, you need to measure the profile. You need to see what angles will give me a uniform dose in the patient plane in the vertical direction. So for that, again, we don't have any customized tool for, a commercial tool for that. We have to customize that. So again, okay. So we had to use this particular method. We used a aluminum rod and positioned the parallel plate chamber along the rod to make a profile. So we kept this we did this trial and error, and finally arrived at what is the angle that will give us the uniform dose. So we found that plus or minus 19.5 degree gives us a uniform dose. And what is the uniformity? It's plus or minus 7%. So within 7%, I have a uniform dose of up to 160 centimeter. And again, one other thing that I found was my uniform dose starts at a distance of 45 centimeter from the floor surface. So that is the position where I have to position my patient. Now, the similar measurement was done across the field to see whether the patient will be totally covered with the horizontal direction. Now, the second step was how do you calibrate the beam, because you have a totally different beam, which is the high dose rate electron beam. So you need to calibrate that. So if you are having a Clinac IX machine, you need to calibrate it at 160 centimeter, whereas if you have a TrueBeam or an Electa machine, you can very well calibrate it at 100 centimeter. Again, you can use the same protocol, TRS 398 protocol, to do the beam calibration. But that is only the calibration part. But are you going to treat the patient at a lower SSD? No, you are going to calibrate. We are going to treat the patient at an extended SSD. So again, you need to know what is the penetration or what is the PDD at the treatment distance. So you need to again do the PDD measurements. Along with that, from the PDD measurements, so this was the PDD data that I got. So that gives me a lot of information. One is what is the depth of penetration. So my 80 dose goes up to 7 mm. And what is the dose follow? My 20% dose follow is at 13.4. So all those data shows me that I am very well within the European guidelines. Now, the PDT measurements was done. Again, since I have, as Vanessa was saying, I didn't know that there are different electron energies that comes with the machine. Like we have only 6 MeV. Later on, when I visited Amrita, then only I came to know that certain when the vendors even give the 9 MeV electrons. Again, we have to ask for that. Otherwise, they don't give. So what we thought is, since we have only 6, if we have a patient with a deep or thicker lesions, maybe we will have to have a energy higher than 6, because in Amrita they were practicing even 9 MeV at that time, I think. So what instead of that, the alternate solution was, instead of a 10 mm beam spoiler, I measured did the measurements again for the 5 mm beam spoiler. So now I have two set of values. So the 10 mm beam spoiler gave me a energy of 3.3 at the patient level, whereas the 5 mm gave a slightly higher energy of 4.1. Then we have to measure what is the dose that reaches the patient plane. So again, we use 398 as our protocol and measure the dose at the particular patient plane where you're going to treat, which is now only 0.17. So the output is very low at this last SSD. So to reduce the treatment time, definitely you need to have a high dose rate B. Now another important factor is the B factor. So as I said, we are going to treat the whole patient with 6 beams. So if you just give one beam, it's going to contribute some amount of dose to the adjacent angles. So we need to account for that, and that particular factor is called the B factor. So the B factor also has to be measured. So initially we started off with a bucket, and then we fabricated a custom fandom, wax fandom, a circular fandom, and did the B factor measurements, and it came to around 2.4. It means that you have to reduce your dose delivery by a factor of 2.4, because you have contributions coming from other beams also to that particular point. So again, this is the standard formula in literature. So we use this formula to calculate the mu that has to be delivered for 200 centigrade prescription, which came up to 519 mu per field. Now comes to where you're going to position the patient. So you need to have a stand and a support mechanism. So we build a stand at a distance of more than 45 centimeter from the floor, because that is the height at which I have the uniform dose for the patient to stand in. So I have a wooden platform and a supporting frame with PVC pipe. Now definitely we should have shielding, because we need to shield the nails, we need to shield eye and leg. So depending upon the patient's shielding requirement, we need to choose the shielding options. Now coming to the in vivo dosimeter, there are different in vivo options available: TLD, OSLD, or diode detectors. Since we have the OSLD the in vivo detectors, we use them for our measurements. So we can see that we have almost a good uniformity dose when you do the measurements. Now recently there are different detectors that are available. One is the Sirongo imaging mechanism, wherein we can live monitor the dose uniformity on the patient surface during a T-set treatment. Now people have again started using alternative methods. Now there is a paper which says that you can use Tomo for as an alternative for total skin electron therapy, wherein the patient is asked to wear a swimming suit, rubber swimming suit as a bolus material, and TBA treatment, tomotherapy treatment was planned. So T-set versus TBA, we're going to hear a lot about TBA. So what will be the main difference? So here our target is the skin. So in TBA, you're going to either irradiate the whole body, or you're going to concentrate on the marrow, which is deep inside the patient. And here we are going to use electron beam, and in TBI you're going to use photon beam. In electron also, for T-set also, you're going to have multiple electron beams. There you're going to have either multiple photon beams or arc. Thank you.
Thank you, Dr. Saju, for the wonderful presentation on T-set. Quickly, I didn't have any clarification from Saju. Okay. Two questions.
Thank you, Professor, for the excellent slides and presentation. I think it was really a great rewarding exercise for us also to learn the AMP protocol is something we also follow. I'm not very sure about the URTC. Comparing these two, is there any salient differences apart from this thing? Any major or
It's all the same. The European guidelines came later part. I think somewhere in the 90s or 2000, early 2000. The other one was somewhere in the 80s. So the dose constraints and the dose uniformity slightly they have improved on that.
So whenever we get a clearance B cell lymphoma, the first prayer we have is they should not have lesions on the face or on the scalp.
Yes.
The main reason is if they have a lesion on the face or the scalp, we need to use internal
shielding.
Otherwise, it will be very easy to use shields over the eyelid. So that is the first thing we used to see is whether they have got lesions. Regarding your can you elaborate on the B factor? I think many students do not have. Do you have an X-ray picture of that showing the uniformity with the B factor factored in?
I had, but I removed it to reduce the number of slides.
But I think the students would not have understood that particular part.
Yeah.
That is something which we learned the hard way. How the two the oblique fields merge together and they get a uniform field. And I think we should explain that.
So basically, B factor is understood in this way. So if we take the red line as our beam, okay. So if you consider this as your anterior beam, so when you deliver your anterior beam, you can see that some amount of radiation dose goes into your anterior oblique sides. Okay. So for example, you are delivering 200 centigrade from your anterior beam. Do you need to deliver again 200 centigrade for your anterior obliques, anterior left oblique and the right oblique? No, because already some amount of dose has been delivered by the anterior beam to these other 2 points. So whenever you deliver the next beam to the next anterior oblique beam, you need to compensate for what is being delivered. The same thing goes in for the other beam also. So when you deliver one beam, that contributes dose to the adjacent areas. So that has to be understood and that has to be compensated. So this correction has to be taken into account when you do the dose calculation.
Probably something like we don't do exact matching. That's why the reason is there.
Yeah, exact matching as well as because of the shape of our body, circular shape of our body. If it was just flat, then it would have been matching here. So here, like we need to account for what that particular point gets from the other beams. So that is the factor.
So, do we need to make custom sheets for each and every patient, like all the sheets you were telling, no?
No, we have this same set of shields. Only thing is we clean them and we use them. Nail shields, eye shield.
Those are lead sheets with wax.
Yeah, we use lead for the nails. We use lead with paint on them.
So if you want to implement along with the frame and all those things, we need to buy the lead sheets.
No, we can custom make them. You just get 1 mm lead this thing and cut it and make it. So of different shapes, like a smaller one for your small nails, and for the thumb we should have a slightly bigger one.
Okay, like if they are not exactly matching, will we miss it? Will we miss them?
No, you don't miss it.
You can cut it to the shapes you want.
Yes.
It's a very cheap way of doing it.
Yes.
One interesting thing we did was for the eye sheet, we actually coated the red sheet with the wax, so they won't irritate. And we put the contact lens. There are the plain contact lens available, so we can first the patient gets the contact lens, then on top of it you wear the lead sheet coated with wax.
That is for the internal shield. For the external shield, what we did is we got the swimming goggles and put lead and covered it with wax. So and even we made for one of our younger patients, we made a total shield. So we bought the sports guard and put lead sheet in that and made a total shield. So there are a lot of customization has to be there. Yeah.
So any more questions from the audience?
You have thick lesions on the skin. How do you manage?
Usually we give boost for that particular region. We initially treat the whole the whole TVA dose and then boost for the regions where the lesions are big. So again, the challenge over there is when you after completing your course of the electron beam, most of the things disappear. So you need to identify where you want to deliver boost initially and keep that as a record, take some photographs, record it somewhere. Otherwise, it'll disappear when you want to deliver books.
Sir, we have done a measurement for the B factor. B factor actually, Sajju was showing a B factor 2.4, which means that at a given point, if you treat the patient with all the 6 P's, at a given point you will be getting 2.4 times higher. So in order to reduce that, you have to divide this B factor into the dose. So Sajju was showing one equation here. The first on the top, it is the dose prescribed, dose prescription, whatever you are prescribing, that will be around 2 weight. So divide by C, 6 DF divided by DF, dual field, 6 dual field divided by single dual field. So if you are treating the patient with the 6 dual field altogether, when compared to a single dual field, how much dose is being increased? It is 2.4 times increase. So while doing the monitor unit calculation, you will be putting dose per fraction on the top divided by the output of the machine, that is around 0.19 centigrade. And C is another factor which is actually accounting for the output variation when you direct the beam or horizontal beam with respect to the angulated. So actually it should come an exact value of 1, but there will be a slight difference. So that slight difference you have to account here in the monitor unit calculation. So this is the total monitor unit which is required for the implementation per field, implementation of T set per field. So anterior oblique field you will be giving with this monitor unit, and again anterior downward field you will be giving with the same monitor unit.
So in a day you will be delivering 590 mu 6 times.
And this B factor is actually a function of the IFT application. As thickness increases, the B factor is going to be reduced. If the thickness is less, we have done a study on one of our PG students was doing one experiment on this, the variation of B factor with the thickness of the patient. So as the thickness of the patient increases, the B factor is going to increase. So thickness increases, the B factor is going to decrease. That was the observation. So with that introduction, we will any questions? Yeah, please.
It was a very nice presentation, sir. In fact, you only helped us to implement the T-set in our institution. Now I have a very basic question, sir. Just now, Raghu sir have mentioned about the variation of D factor with the diameter of the factor. Like when we implement the treatment, we are considering the body as a uniform diameter around 30 centimeter diameter. So how to correct the dose to the extremities like feet and the arm? How can we correct the dose? We cannot deliver the same mu in each field.
No, I mean initially I was worried. Like when you deliver the whole, I mean the conventional dose of 36 gray, you will be more worried about that since. Yeah, definitely dose will be there, but
we don't have to correct it, right, sir?
There's no way to correct it.
Okay. Otherwise, do you think that we need to correct the dose? We need to include the variation of D factor?
But how will you implement it across the field?
Okay, thank you.
Yes.
We had a problem that we didn't use the pedestal for a few patients. It was missed out in the diagram. Suddenly I noticed that the AMPI picture has got a pedestal, and patients were getting a lot of blisters on the sole because the scatter from the balls. So okay. After we used the 30 centimeter pedestal, that was gone.
Yeah, again we went for the wooden pedestal because to reduce the scatter.
Okay, with this we will wind up this session.
Thank you so much, sir, for this informative talk. I request Dr. Sushma P. Associate Professor, Medical College, Connecticut, to present a memento to Sajju sir. Thank you, sir. Thank you, ma'am. Next is the TPR Memorial Oration. I request Dr. PGG Guru, Chairman, AMPI-KC Chapter, to introduce the speaker.
I'm very happy and honored to invite Dr. Dayalan, who is a very close friend of mine, to this TPR Memorial Oration. Now, Dr. Dayalan is known as Dayalan, but his full name is Kubusami Dayalan. He is one of the earlier physicists in Bhutan Institute of Radiology, and he did his DPARB from BARC in 1985. He acquired PhD in biomedical science from MGR Medical University, Tamil Nadu, in 2003. He has served as faculty in the Madras Medical College, now known as Rajiv Gandhi Government Medical College and Hospital. He worked from 1982 to 2012 and retired from the government service in 2012. Subsequently, he was invited to the Kamashi Memorial Hospital, where he was organizing the department and supporting the medical physics activities in Kamashi Memorial Hospital, and head of physics till 2022, where from he also retired, taking a good leisure time and going through his career. He had 37 publications and over 160 invited talks given in different platforms. He is a well-known writer of scientific books. He has published 10 books, which is even now used by the physicists and technologists, nurses, and other disciplinaries using physics. Dr. Dayalan is a recipient of several awards and fellowships. He received the Best Fellowship Award at the World Congress of Radiotherapy, conducted in Stanford in 2016. He is Fellow of Indian College of Radiation Oncology. He is an International Academy of Medical Sciences, Ultrasonic Society of India, and International Union Against Cancer. So these are the fellowships he could acquired during his tenure, and he has held several publications positions, including that of the President of Indian Radiotherapy Society. He is one of the founder member of the Indian Radiotherapy Society. He started sometime in 2005. Yes. He is a founder secretary of AMPI, Tamil Nadu and Pondicherry chapter. He is, of course, a member of AMPI and many other scientific associations. With this, I invite Dr. Dayalan to give his TP Ramchandran Memorial Oration.
Thank you, Dr. Guru, for the kind words. I am happy to be here to give Dr. T.P. Ramachandran Memorial Oration. I am very glad for the invitation and also thank the Cancer Center as well as the AMPI Kerala chapter for making this event so that I am presenting here. After hearing the two lectures with stalwarts, I thought better to move away from the clinical to give some relaxation to the audience. So hence I suggest I have taken a topic, something talk about to cherish the medical physics history instead of the day-to-day activities what we are facing in the hospital setup. Going through this T.P. Ramachandran Memorial Oration, I am very happy because personally I know him. When I was a student of DRP in 84-85, he used to come many times to meet Dr. Madhavan and other people regarding some project and other things. Sometimes he also took some classes, special classes there in BRC itself. So going through this brief history of Dr. D.P. Ramachandran, just I borrowed from here. He born in near Tiruchur, Kattur village, and graduated from Kerala University in 1964 and did his diploma in radiological physics and hospital physics from BRC and later joined as a research assistant. Then he took a leave and studied MSc Physics from Kerala University 1968 and became a full-fledged faculty in 1969. He did his PhD in Banaras Hindu University, maybe Agarwal, MS Agarwal, his grade. Yeah, at Varanasi, 1982, and became actually the professor head, the newly formed physics, radiation physics division at Regional Cancer Center. He is one of the founder member of AMPI, around 1976, I believe. Yeah. And during his death, he was a vice president during the tenure of AMPI. And he was the motivator for formation of Directorate of Radiation Safety in Kerala. And he conducted many workshops, lot of presentations, and a DAE project like environmental science. I remember environmental radiations. He actually took some studies. He's an excellent teacher, I mean, eminent scientist, soft-spoken gentleman, and actually he's expired on 1994 due to some illness. Actually, this his wife and the daughter is left with, and I am very honored to give this lecture as a part of the memorial oration, since he is my senior as well as one of the mentor for not only these people here, around the whole medical physics community in India. So just to go through the title of the talk, just I am going to give some information where from we came from. Something like knowing our father and grandfather, it gives a lot of confidence and boost our moral. Similarly, medical physics community, we must know what is our actually grandfather and father, what is their contributions, and with this, so that what happened, what we can do as a medical physics in our lifetime. That is a question, actually the answer comes in the talk. Now everybody knows medical physics is nothing but application of theories and methods for diagnosing the disease as well as offering a treatment to disease. It's a basically subfield of biophysics. Of course, the relation between the medicine and physics is very, very old. I try to make it how actually the physics and medicine is connected. It actually we can divide into 4 categories like antiquity period, and then 17th century, 19th century, and 20th century. Maybe 20th century everybody is aware of what is happened like that. Now what will happen is the Edwin Smith, this is actually you see there before Christ, they started treating the breast abscesses with a fire drill. This was starting of actually the application of physics there. And then Hippocrates, actually they studied the measurement of body temperature, how it is possible. Take a mud, put mud on the fever patient. The dryness, no, how quick it dries, that is indicator of the temperature. This is what actually they made in the initial days. So just made the paste of mud put on the patient, how quick it dries. So that indicates the temperature. This is what actually the paper says like that. And then people used the magnetic rings to treat arthritis. Then this is the first person, scientist, Algason. He came with the idea that how vision is coming. He said light is responsible. Probably he thought that we believe that he is the first scientist to give scientific explanation how vision is actually formed like that. And Leonardo da Vinci, well known actually for physiology people, actually he studied the mechanism of the human body and painted human anatomical in palm leaves. Suppose I am moving the hand, this movement he put in the palm leaves, the joint, this joint, how it works, without undergoing any regular studies. Actually, that many sometimes they put in the walls also. Another lesser time he put in the walls also. That painting they collected, they found that actually locomotion. Now physiology, we teach actually physics of physiology. So that actually came as a paint in the form of paint. And also today we are talking about the contact lens. Actually, the principle of the contact lens arises from him. Actually, that is the reason why Leonardo da Vinci is considered as father of medical physics by American Association of Physicists in Medicine. If you go on the website, you can see it. And 17th century, what will happen? It is actually a hydrophysics. That means they started thinking how they function, human body function, and how it is related to natural life. So that's why actually this Borley came with biomechanics, and Anton invention of microscopes, and then Santario, he measured the temperature, pulse rate, and body mass, everything like that. 18th century, electrophysiology by the two people, Galvani and this Volta, electrophysiology. That means electricity generated from the muscular activity. Electricity generate muscular activity like that. And sometimes hypnotism is used to anesthetize patient, because when a patient is undergoing surgery, they want to anesthetize nowadays. The same thing is given by informed hypnotism. They talk to people eye to eye, and people go actually sleep. Then surgery goes. This actually happened actually some time back. And in the 19th century, it's a physics-based medical technology, invention of stethoscope, and investigation of mechanical, thermal, optical, and acoustic process in the body. It is connected to the human body. And this Adolf Fick, he measured this, he came with the physiological measurement technique, of course, the physics of lung, application of thermodynamics to the heat economic of the body, how actually the temperature is maintained within the body. And of course, this everybody knows that plus 2 is young modulus. He is actually basically physician cum physicist. So this young, lot of work he had done is like this. He studied capillary action, interference and wave theory of light, physiology of vision, effect of eye accommodation, and theory of color vision. And then in addition, he did surface tension, molecular size measurement, and elasticity, young modulus of elasticity. All plus 2 students actually never miss. There are 3 modulus of elasticity. One is young modulus experiments is there. And the Hermann Ludwig, he actually Helmholtz, he is a physician, physiologist and physicist. He is the founder of ophthalmology. So he did work on physiology, optics, electrodynamics, mathematics and biophysics. And physiology of vision, hearing, and rate of hearing means now today we are using audiometers. Actually the seed goes actually in these days, in those days. Invention of ophthalmoscope, ophthalmometer, etc. Of course, 19th century, everybody knows that actually William Conrad Röntgen, discovery of X-rays, and the first medical X-ray taken, this is also known to everybody. This is the tube they use. The X-ray tube, what we see today is not the same. They used what is called Crookes tube. Later it was modified as a Coolidge tube. Then later modification what we use today. It's not the original X-ray tube we use as Röntgen used. Of course, this is followed by Henry Becquerel, radioactivity, and then Pierre Curie and Marie Curie, discovery of polonium, discovery of radium, and then isolation of radium, that is spontaneous radioactivity discovery, and then discovery of radium and polonium, and then isolation like that. And then daughters, they came with actually induced radioactivity. So that I have not mentioned here. So the whole family did a lot of work on it. So multiple Nobel Prize they got it. So coming to this our point, maybe a lot of dispute is there in the literature, where the first X-ray was used in the world. So really I want to try to give answer. Maybe some mismatch is there because every literature quotes some letters. Probably as per available data, it is 1896, February 3rd. This is the first X-ray taken at the United States. They used around 50 kV with the low MA process. Probably that is a picture. It is maybe some more data also they may be available. You have to check. And coming to this journal, 1896, first medical imaging journal was introduced. Archives of Clinical Skiography. Skiography is a name for radiography. And then what happened? First Radiological Society, Röntgen Society. Presently it is called British Institute of Radiology. That's called BAR. Still it is there. BAR London. So this society was in. And then what happened? To analyze the skin injuries, a committee for X-ray injuries were made in London. Later, it is made as a Radium and X-ray Protection Committee. Then it is made as International X-ray and Radium Protection Committee, 1928. Later, it was transferred as International Commission on Radiological Protection, 1950. The name change is only 1928. It started doing the work. So this is actually you see the evolution, how people are concerned about the protecting the people as well as the recording the documentation. This all started very early. And when is the birth of brachytherapy? That is actually the question comes. Henry Becquerel reported some injury in his hands. He showed it to the people. Then finally, the radium has the impact on damage in the skin cells. So that is the birth of brachytherapy. It started from the physics part. It is not from the clinical side. So then what will happen? Use of radium and radon gas started in the hospitals. So radium implant, you can see the radium implant. This picture you can see the net. They implanted the radium needle like we do nowadays with the radium needles. Yes, sorry, radium seeds. So radium implant were used, and also they devised radium teletherapy machine. It existed for some time only because of the cost concern. So radium teletherapy machine is cost is so high. So actually it was abandoned. It was not used in many hospitals, but it was there. Now coming to the radiobiology, Thomas Alva Edison known for discovery of electric bulb, but he is the one person who did lot of research after Röntgen. Röntgen actually discovered only the X-ray. The application of X-ray in what is called crystals like cadmium tungstate. He did lot of work using the X-rays. So that's why the intensifying screen came into picture. So a lot of intensifying screen used today in the cassette are benefited from the discovery of Thomas Alva Edison. He has a assistant, that is actually Clarence Daly. He used to assist during the X-ray measurement. All the crystal he put the X-rays and then paper has been made. This fellow died actually 37 years. He died because of the mediastinal cancer. Thomas Alva Edison decided no more X-ray research. He put a big lock in the laboratory. So that's why Thomas Alva Edison closed the entire research area because he lost his assistant with the illness. This is eye opener for the biological effect of radiation into the workers. Maybe he is not a hospital worker, he is R&D, but it made it that you must use it actually very controlled exposure, radiation safety program, all these things, regulation now we are talking about. This is a birth point for radiation safety. Of course, Röntgen used gas tubes. He had 3 electrodes. Inside there will be a gas. One electrode, current will be passed. The air get ionized. Electrons are produced. That the electrons are pushed towards the target, X-rays are produced. This is called gas tube. We call it Röntgen X-ray tubes. Now what happened? There is a problem. Suppose morning if you use the X-ray tube, by the evening there won't be gas. All the electrons are exhausted. So evening you have to pump the gas to the tube, X-ray tube. Actually, we had a pump man in our Bernard Institute. He comes with a pump, a cycle pump. He put the and then note for every X-ray machine. He write what is the pressure in cage like that. And now it is abandoned. So that's why what happened. The X-ray tube cannot be used for throughout the day. Or what output you get in the morning may not get in the evening. The Coolidge gave the answer. Don't use actually the gas tube. We go thermionic emission method. So 1910, he came with the idea of Coolidge X-ray tubes. That means it works on thermionic emission. So cathode is filament is heated, electrons are liberated, the electrons are accelerated towards the target where it is stopped and X-rays are produced. This is called thermionic emission. He also coined how much distance you must keep. This is anode, this is cathode. If you keep close, spark will come. So he also suggested how much distance should be kept for a particular voltage between the cathode and the anode. That is called the spark avoidance. So that's also he suggested some 4 inches, 6 inches like that depending upon the kV you apply. So this method is actually it's a better information than the discovery of X-rays. Otherwise you would have not used it. And this X-ray tube still we are using with the modified versions from the different companies are making their own X-ray tube like a variant like that. That's also interesting. And then 1934, iodine 131, thyroid investigation and treatment of hyperthyroidism. We nowadays even still we do it. And we talk about proton therapy. The person is actually Robert Wilson. Came with actually this heavy charge therapy, but actually it was discovered there, but we are now only using in the clinical setup of late. And then ultrasound medical application. In 1940 itself, ultrasound used in army, World War, sonar, sound navigation and ranging. They used in army to detect actually submarines, but it came to medicine very late. So use of ultrasound is very old actually. They used it in army for Second World War, they used it to detect the submarines. They send the ultrasound, the reflection ultrasound comes, velocity they calculate, distance they calculate, put the bomb. And actually that is the method they used. But of course it came to medicine very late and still actually it is going strong. It became an independent department like that. and then positron annihilation. This positron annihilation and then PET-CT arrival. And coming to the cobalt emission, it is from Canada. This actually H.E. Jones, everybody knows, is one of the father of medical physics. So it came from Canada, this cobalt 60 unit, and then subsequently in 1960, gamma camera, Anger camera comes from Hall Anger. Of course, the technetium 19 functional imaging techniques were started. This is the photograph from cobalt 60 1951. The first cobalt maybe Picker, I think. Picker company adopted this later. So LINAC. The LINAC came from London, not from US first. So I also had a contribution during my studies. So UK, one of the contributions is the first LINAC. They have given the British Ministry of Health. They funded the project. So actually they devised a 3-meter long waveguided 8 MeV mission. Of course, it is not continued after that. Though they treated the first patient in 1953. Of course, subsequently Henry Kaplan, they started actually 6 MeV medical linear accelerator in USA. Probably that is now the present form of Varian group. Probably that is the origin actually, that now it is continued. Of course, the MRI, Lauterbach and Peter Mansfield, and the discovery of CT scan by Godfrey Hounsfield. Godfrey Hounsfield is not a physicist, he is a biomedical engineer worked in UK. And PET-CT invented by Ron Nelt and David Dowdson. So these are all some of the things. This is Hounsfield image with his original phantom. Actually, because the curvature of the head is not uniform, no? Here it is less, here is bigger. So what he did, he put a phantom, like we use a phantom, water phantom. He put the entire head inside the water to make the path length equal. So then it was taken, that is the phantom here, they used to here like that. So coming to this, keeping this as an insight, now coming to this, our role in India, how actually there. In 1900, you know, the discovery is 1895. Within 5 years, X-ray machine came to India. 2 X-ray machines came. One is actually Calcutta, one is Chennai. The British allowed 2 X-ray machines. Takapukur Hospital, if you remember correct. The Takapukur Hospital received another machine. First, Chennai also received, but what happened? Without the man for installation, it was kept in the, as usual, no expertise. So it was kept in the box for the first installation did actually Chennai. So Captain Bernard came, were assigned to go to and install it. He came all the way to Bombay. The Bombay Navy were using the X-ray first initially. He learned the technique how they are using the X-ray machine in the Navy. After spending some time, he moved to Chennai and he installed the machine. That was there. He actually became the X-ray man of India, the Bernard. He only taught the X-rays for all the people. And he started treating the cancer 1924. This history also recently we take it from the, so the Madras Medical College, the department has completed 100th years next year. So actually they themselves not aware of this because records are not available anywhere. We took it from Arai journal, we take it, and that is actually very interesting. Then who is the first medical physicist employed? Arthur Ponnaya was employed as Bernard Institute of Radiology and Cancer, Chennai, is the first physicist. Of course, Ramaya Naidu, chief physicist, Tata Memorial Hospital, little bit 2 years gap. And Cyril Jayachandran, Christian Medical College, 1955. He joined and left for MSc. Again, he come back and joined like that. So, of course, these all know that first medical physics department started at Cancer Institute. The physicist name is Chandrasekhar K.S. Before Dr. A.V. Lakshmanan, Chandrasekhar was the physicist at Cancer Institute. We are not aware of that, but only heard the names like that. Probably Cancer Institute goes with the credit, the first cobalt emission, as well the first linear accelerator like that. So coming to this, yesterday I went some literature review. We are talking here in the Kerala audience. We must maybe I may not be correct or not. I do not know. You are the judge. Then what happened? London Mission Hospital, Nayur given the credit. There is one person called Dr. Somerville. He is a surgeon. So he was serving in Nayur. Nayur was actually Travangur dynasty at the time. So therefore what happened, he used all the people go and get experience from him only. One person is Kesavan Nair. He later became the superintendent of the hospital, Trivandrum Hospital, custodian of the radium needle. He only bought radium 1933. This I got it from literature, I have the reference. Kesavan Nair actually bought the radium needle and he used to give to the Nayur. The needle goes to Nayur and actually implanted by Somerville. Somerville. So he treated a lot of radiums, even in the Nayur hospital history also they made it like that. So this is the history connected. So without, we cannot write physics without this because radium is there. So that's why I made. Of course, everybody knows later the group joined, the Matthew, Dr. Krishna Iyer, T.P. Ramathan joined the radiology department, started the radiotherapy, that way it functioned like that. Then I studied, actually maybe I am not correct or not, who is the first physics in Kerala? So that literature says actually Ponnuni Karta, maybe before T.P. Ramachandran. He is the first physicist, and maybe T.P. Ramachandran, the followers now sitting here, I need not put like this. So this is the journal you can refer something if anybody want. History of Cancer Care in Kerala. Dr. Babu Matthew et al. They have written an article. It is there. Now it is interesting to at least to take it, keep it in the department. So any annual function in the department, you can talk about your history like that. So I searched what is the first mission purchased in Kerala. Eldorado A cobalt mission. Same thing actually what they did Chennai. So this actually Medical College Hospital purchased 1957 as per the record I am saying. And subsequently they purchased 2 TKV X-ray unit 1960. Of course, after that the Medical College Hospital became actually Medical College and then Regional Cancer Center separate, and that we never talk about like this. Now, as a medical physicist, what is a cherishing moment like that? Just to see the figures and see how the contribution came. First Nobel Prize, Ranjan. First Physics Nobel Prize, Ranjan. Okay, and then Curie radioactivity, Nobel Prize, and then same group actually, first Nobel Prize for 3 people, second Nobel Prize for Marie Curie for isolation of radium in chemistry. Anderson, who discovered positron. See what is very interesting, I just go through the history. Anderson discovered positron. But later, 30 years back only, positron annihilation used for patient imaging, PET CT came. Before that, if you go back to Paul Dirac, 1924, he is a theoretical physicist. He assumed that there is a particle against the electron. He never said positron. Antiparticle he says. Paul Dirac, he is a theoretical physicist, going on writing in theory, all the atoms theory. He suggested there should be a particle as antiparticle to electron with the same mass and charge. Then only the equation satisfied. He wrote like that. He never actually made it. Paul Dirac, his name is 1924. Now you see that this is 1936. So after 16 years only, they identified the positron as a particle. Now actually we are enjoying the positron annihilation as a PET CT concept. And then this is induced radioactivity as suggested actually previously. NMR. We talk about actually this magnetic resonance imaging. Nobel Prize was given in 2003 for Paul Lauterbach and Peter Mansfield. But the prelude goes to NMR, nuclear magnetic resonance. It is there 1952 itself. But you cannot put the patient sample. You can put only powder liquids. You can study the NMR. You can samples only the cell only, like blood. You can go 2 ml, 3 ml powder. You can put. You can study the nuclear magnetic resonance. It is there in physics chemistry lab. Even today it is there. So this extension only to the human body made us magnetic resonance imaging. Later they also given the Nobel Prize. And then radioimmunoassay, Tolson yellow, and computer tomography, again Alan Cormack and Fred jointly given actually the Nobel Prize. Now what it shows all these things? See, I don't think that any science contribution like physics rewarded much to the medicine. So all these physics people never thought, positron discovered people never thought it would be used for patient like that. So therefore innovations and experiments conducted at the college, hospitals or research institutions, universities made actually the science popular, and it's serving the people in a better way. That's the information we must take in. Now coming to this, concluding this one, this is my own, not from taken anywhere. What is the best science which we think of? We have physics and biology, botany, zoology, and everything. Mathematics also the best science. So like that, medicine, engineering, like that. If you ask like that, which science gives direct relief to the patient? That means a science which relieves the pain of others is the best science. Probably medicine is the best science because it directly linked with the patient. All other things only second route, third route only it comes. But medicine actually does it. But how to ensure that you have delivered the correct? For example, now chemotherapy we were giving. Everybody believed that chemotherapy worked. Now you take the PET CT, you can see that chemotherapy worked or not. Then we can abandon the chemotherapy, go for another regime like that. Like that, medicine doing it, but to ensure you need medical physical. So that is the way I am proud that we say that to ensure the delivery of treatment, success of treatment, you must need actually medical physics concept. Otherwise, it is very difficult. He always assume that everything is like sir is telling that what is the skin dose. It's fine to give the radiation. How to ensure that skin is getting this much, node is getting this much, then that concept actually comes from physics group. So we are understanding should be very, very important. What is actually the future is individualized patient care. Individualized patient care, they say most of the journals. And say, now all what happened actually these physics-based techniques comes from biology. Understanding biology is more important. I do not know how much importance we are giving to biology. Automatically we are working in a hospital setup. How much biology we understood, anatomy, physiology, even the radiobiology by the medical physics is actually a very important issue. Actually that should be strengthened. To work in a hospital, understanding biology is much more important. Like fluorescence imaging, emerging topics, optical coherence imaging, using white light they are using for tomography. So how much understand we have on this? Probably CMC Vellore, they are having some optical tomography like that. Intraoperative optical imaging, MR PET fusion imaging. Of course, we have actually this PET CT, PET MRI, SPECT CT, and also future what type of fusion comes we do not know. We must prepare to learn this technique. Maybe ultrasound CT comes, that is excellent. There are some areas like that, it is emerging like this. So we must prepare ourselves to learn all these things. So instead of getting trained for equipment, we must trained for concept, physics concept. We must have high strength in physics concept so that we can tackle any type of situation like that. As somebody said, physics is one entity, fundamental. It is perfect to say that physics applied to medicine rather than medical physics. We are not justifying the medical physics because radiation physics only we are practicing. Cardiology physics we are not doing, physiology physics we are not doing, ENT physics we are not doing, anesthesia physics we are not doing, but we say medical physics. It is something like only radiology physics, radiotherapy physics we are doing. Radiology physics, radiology physics is more actually optimum. That's why people say that this word is quoted by Maynard, effector, probably you know radiotherapy, the effect of Maynard. He quoted that physics applied to medicine is more actually meaningful than medical physics like that. This is for information only, not for debate. So with this, I stop this lecture. Thank you very much for silent hearing.
Thank you very much, sir, for that. I guess a lot of information is there to take home from your talk. I request Dr. Geeta M., Professor and Head, Department of Radiation Oncology, Malabar Cancer Center, to hand over a token of our appreciation to Dayanand sir. Please give a big round of applause. Thank you, sir. Thank you, ma'am. We are giving a short break now. For tea is served outside the hall. We have a dearth of time, and so please make sure that you reassemble at the earliest, maybe within 15 minutes or 10 if possible.
AlignRT Advance enables greater patient comfort, safety, and accuracy for SRS treatments. AlignRT Advance delivers an SRS solution with proven outcomes and documented sub-half millimetric monitoring accuracy. The AlignRT Advance SRS solution utilizes an open face mask combined with real-time monitoring that enables high positional accuracy, safety, faster treatment times, and enhanced patient comfort with proven results to give patients peace of mind. Prior to bringing the patient into the treatment room, prepare the table by placing patient accessories such as a knee sponge, custom headrest, and headboard in the proper position. If your Linac does not have a 6 degrees of freedom robotic couch, the Vision RT 3 degrees of freedom head adjuster allows the user to make fine adjustments to pitch, roll, and yaw prior to imaging. Your Vision RT regional sales manager can provide additional information about the head adjuster upon request. Once ready for treatment, align the patient to the general location of treatment ISO center. Next, use AlignRT Advance SGRT technology to begin monitoring and manually apply any gross corrections before placing the open-faced mask on the patient. To facilitate positioning, the user can utilize the AlignRT Advance Postural Video subscription feature. Postural Video provides an outline of the reference surface superimposed onto a live video stream of the patient, showing a real-time view of the patient's overall alignment relative to the reference position. This is a great tool to resolve any gross misalignments of the head, chin, or shoulder position. The user can see a camera eye view from all 3 camera pods to ensure the best setup possible. Once gross misalignments have been resolved, place the open face mask on the patient. With the mask in place, use AlignRT Advance to fine-tune the patient setup using the real-time deltas, which demonstrate where the patient currently is and where they should be in real time. The real-time deltas generated are based on the selected ROI. Adjust rotational deltas first, either manually or by using the adjustment knobs on the 3 degrees of freedom head adjuster. Then adjust translations by free-floating the couch or using the couch controls until all deltas read as close to 0 as possible. With the patient properly aligned, the user can then perform internal imaging according to department protocols and apply corrections if needed. After corrections have been made, the user can then take a new reference capture which zeroes out the deltas at the corrected position to monitor the patient throughout treatment delivery. Once a new reference surface is captured, the user can then review the regions of interest from which all deltas are derived with the help of the 3D photorealistic reference. The 3D photo license provides a photorealistic reference of the patient's surface, providing enhanced visualization to ensure proper drawing of a region of interest. The user is now ready to begin treatment. AlignRT Advance monitors the patient even during couch rotations, providing continuous feedback to ensure there is no unacceptable motion during radiation delivery. AlignRT Advance monitors 6 degrees of freedom in real time and with the proper configuration and licensing has the ability to hold beam if the patient moves outside of tolerance, thereby safeguarding the patient from inaccurate treatment delivery. AlignRT Advance provides the ability to deliver treatment as planned, safely, accurately, and efficiently, giving your patients a comfortable experience and peace of mind. The intuitive interface and efficient workflow means you can provide these benefits for every patient, every fraction. AlignRT Advance, advancing the science of surface-guided radiation therapy.
Over the next few minutes, we'll prepare you for your treatment. We use the latest generation surface imaging guided system to treat your cancer. Our C-RAD Catalyst cameras are constantly looking at your body position to deliver your radiation therapy in the safest and most effective means possible.
And when you're ready, take in that deep breath.
And to provide the highest quality of care, our team of healthcare professionals are specifically trained to use this system. A series of lights will visually coach you during your treatment. while 3 cameras actively measure the exact position of your body with sub-millimeter accuracy. And all the while giving your medical team a 360-degree view of your body during treatment. This system keeps you safe by constantly evaluating the position of your body, and if your body gets out of alignment, it will immediately stop the treatment. Because it's so safe and effective, our CRAD system is trusted by some of the most respected brands in healthcare. Brands like MD Anderson, Northwestern, Mayo Clinic, and many others. The system also allows you to play an active role in your own treatment. Breast cancer patient Mary Beth Grassi had this to say about her experience. I really liked the setup of the CRAD, Grassi said. From the deep inspirational breathing to the visual cues, from the different colored lights, I felt like I was an active participant in my treatment and had some control over my care. While we can treat any cancer our cameras can see, the CRAD system was primarily designed to safely deliver radiation therapy for treatment areas that change with your breaths, like cancers found in the breasts, lungs, and abdominal regions. In this video, we'll focus on breast cancer treatments used in conjunction with a specific breathing technique. However, the same principles also apply to other types of cancer treatments as well. Before your treatment can begin, we need to do some initial planning. We call it a simulation. Your physician has determined that the type and location of your cancer will benefit from a specific method of treatment, DIBH, or Deep Inspiration Breath Hold. The purpose of the DIBH technique is to minimize the amount of radiation exposure to your heart. For your simulation, we'll take 2 scans to analyze your body position and pinpoint the area of treatment. The first scan is free breathing, where you breathe normally. For the second scan, we'll use the DIBH technique, or breath hold scan. As the name implies, you'll take a breath and hold it for 10 seconds.
Wherever life plants us, bloom with grace. Life is a wonder. Every day in our life matters, and what makes it count is a simple smile of happiness. Welcome to MVR Cancer Center and Research Institute. We believe in eternal happiness. One of the finest cancer centers and research institutes, MVR-CCRI, is named after Kerala's renowned veteran leader, M.V. Raghavan, in recognition of his contribution to the cooperative sector in the state of Kerala. A milestone in India's cooperative sector, MVR-CCRI connects international experience and healthcare services with a world-class facility.
MBR Cancer Center and Research Institute is the first multidisciplinary standalone cancer center. Came up 3 years ago in Kerala. In 2012, some of us like-minded people under the leadership of Mr. Vijay Krishnan formed this Care Foundation with an aim of delivering world-class cancer treatment at an affordable cost to the people of this area. This hospital has 35 different cancer-related subspecialties and 35 departments working. And also we have about 60 odd very well trained expert doctors in the for the management of cancer are working in this hospital. So we have a facility for all cancer treatments like surgery, radiation, chemotherapy, immunotherapy, and any other form of treatment currently practiced in the world. We have about 8 surgeons surgical oncologist working in this hospital, and about 8 modular theatres, state-of-the-art theatres for the surgical management of cancer. We also have 2 linear accelerators, very latest equipments, and it can take about 100 to 150 patients for radiation per day. And all these latest radiation equipments can give radiation with a very accurate dose. We have a large 80-bedded daycare chemotherapy unit, as well as 12 world-class BMT suites under medical oncology. When the cancer is progressing with all the standard treatment, and when bone marrow transplant is the only cure for them, we have facility for taking up 12 patients at a time. We also have a well-equipped pathology department, transfusion medicine department, a microbiology department, and an infection control team, as well as we have other supportive departments like medical nutrition and well-equipped physiotherapy department as well. This hospital so far has treated about 30,000 patients for a period of 2.5 to 3 years, and we have performed almost 6,000 to 7,000 surgeries with a complication rate of less than 5%, which is a remarkable achievement. And we have delivered radiation for more than 20,000 patients. Also, we have facilities for clinical trial. Clinical trial is a department which offers a new treatment which is not in practice, but it is available as part of trial, which is available as part of multi-centric, multinational trials, whereby patients can experiment treatments which are not at the clinical use. By this method, even patients can have treatment which is going to come 15 years later. So this hospital is well equipped, and the team of doctors are having good experience and experts in the field, in the different subfields of cancer treatment, as well as we have a very good team of paramedics which deliver the treatment without any complication or without any failure. So our aim is to get the best results out of our treatment, and I'm sure with this type of team and the equipments, we can deliver the best, and we aim at achieving the status of the best hospital in the world by 2020.
The hospital's state-of-art design, functionality, and technology makes us one of the most modern hospitals in the subcontinent. Our passionate team of professionals and their patient care helps us provide accurate diagnostics round the clock during any emergency.
I am Dr. Prashant Parameshwaran. I am consultant in Department of Medical Oncology and Hematology at MVR Cancer Center, Calicut. I am in charge of hemato-oncology and bone marrow transplant program in MVR. We are offering a complete hemato-oncological program, state-of-art leukemia induction unit. We take care of lymphomas, multiple myeloma. We have well-equipped blood bank, an apheresis unit, and a state-of-art hematopathology, which includes 10-color flow cytometry and all immunohistochemical markers. We are having a bone marrow transplant unit, which is a kind or one of the biggest in Kerala, with around 11 transplant beds. We have done autologous bone marrow transplants for myelomas, lymphoma, and allogenic bone marrow transplant for acute myeloid leukemias. Aim is to make it as a state-of-art unit, and we have already started postgraduate training programs We are planning for more and more training programs in the field of hemato-oncology and transplant.
Our surgeries are conducted in a world-class, fully integrated operation theatre complex with 8 operation theatres and a high-end cath lab within the complex.
Department of Surgical Oncology at MVR Cancer Center and Research Institute has 10 consultants which work in a site-specific and organ-specific manner. Each consultants have got exemplary vertical skills apart from good horizontal skills, and they take care of certain areas of interest pertaining to their areas of expertise. The department has got 8 state-of-art theatres, and we do around 200 to 250 surgical oncology procedures every month. Few procedures are specific to our institute, like we have got a department of peritoneal surface oncology where we do cytoreductive surgery and HIPEC, and we do around
against bone marrow and tumor cells, and to immunosuppress the patient sufficiently to avoid the rejection of the donor bone marrow transplant. So it's used as a part of condition regimen of BMT, leukemia, aplastic anemia, lymphoma, multiple myeloma, and autoimmune diseases. So the first question is that with what accuracy must the dose be delivered? So we know that ICRB recommend the overall dosimetry accuracy within plus or minus 5%. But as you know, TBA is entirely different from the conventional modality treatments, because we are expecting so many uncertainties and patient position difference, and when you come to extent SSC, there are other scatter parameters will change. So the best possible way we have to try. So we can call it as APARA. APARA means as precise as readily achievable. It's actually a para. So we are expecting a uniformity of plus or minus 10%. That's what we expecting from the extended SSC technique. And we follow TG17, that is a recommended protocol from AABM. So first question is the choice of technique. So which technique we have to choose? So it depends on different parameters. So which equipment you are having. So the available equipment. So you may have cobalt 60 or linear accelerator. So depends on that you can design your TBS system. And next thing is that photon energy. If the energy is changing, obviously you can expect a change in the dose distribution. So that you have to take care. The maximum possible field size, that depends on if you're working on telecobalt or if you're working on LINAC, it will be different. And of course the treatment distance, because that is a design limitation. If you have a adequate size bunker, you can take maximum distance. And dose rate. Dose rate means we are expecting lesser dose rate at the extended SST, and also most of our clinical data is based on the lower dose rate. And patient dimensions, because it depends on the bunker and the size of the bunker and field size. There we have a limitation in treating the size of patient. So why extended SST? That's a question, because we have different modalities, and why we are going for extended SST. So I think this graph will explain on that. So before that, we will talk about the patient thickness. So here you can see that there are two regions here. You can see this is A and this is B. So EA represents the patient thickness is up to 26 centimeter. That means 18 to 26 centimeter. That we are expecting when we are irradiating the patient in the APPA. So because the patient thickness will be very less. But when we are talking about bilateral method, obviously the patient thickness will be more. So that can be represented in B, that is 38 to 50 centimeter. So here you can see that this graph, this is showing the 15% of dose difference. That means that is a peak dose to the mid dose. So that's 15%. So if you see the energy or extended SST, the first line you can see this, we are talking about cobalt 60 at 80 centimeter. You can expect the dose difference or dose uniformity of 15% at 26 centimeter. But if you are talking 26 centimeter dose difference, we are expecting cobalt 60. But when we are treating extended SST, you can treat, here you can see, you can treat up to 34 centimeter patient thickness with the same dose variation. That means extended SST will help you to reduce the dose variation inside the patient. And when we are talking about LINAC, 6 ml LINAC, you can see that you can treat a patient of up to 30 centimeter with 15% of dose variation when you are firing at 100 centimeter. And when you fire at 300 centimeter, you can treat up to 42 centimeter of patient thickness with a dose variation of less than 15%. So that's how one of the advantage of eccentricity. And the other parameter we already know, because if we treat at maximum distance, you can cover the entire part of the body. So that will help you a lot. So it's better to go with eccentricity because of these two advantages. Next question is which energy we should choose. So this also can be explained with the graph. Here you can see that when the energy is less, obviously you can get lesser uniform dose. And if this curve will also help you for that. So here you can see that we are treating an eccentricity, the cobalt 60, the dose variation of 15% you can expect for 34 centimeter. But when you are going for 6 MV, you can go up to 39 centimeter. And when you go for 25 MV, you can treat patient up to 50 centimeter of patient thickness. That means if you increase the energy, you can deliver more uniform dose. But there is a problem, because when you are increasing the energy, there will be a skin sparing. That means you will miss the tissue. So you have to use beam spoilers and alternate arrangement. That will discuss in the coming slides. The next question is that which position we should choose, because there are literature showing that different patient positions are available. So first we could talk about APPA. So that this is a simple technique as physics point of view, because there are no much difference in the patient thickness. So this is very preferable because of a dosimetry point of view, and also you can shield the critical organs like lung. You can make a dedicated block for that. So that is a very simple point of view. But unfortunately, the thing is that when the patient is undergoing for BMT or chemotherapy, after some fraction, the patient will be very weak, and sometimes they may not be able to stand for the entire treatment. The treatment may last for 1 hour, so sometimes the patient may not be able to stand for such a long time. So next thing is that for the patient comfort, we can go for lying down technique. So this is one of the technique, lying down. So this patient is lying in the decubitus position, right or left. So here also we can shield the lung, and also the patient will be very comfortable because they are lying down. But reproducibility is an issue, because the patient may not be able to lie down with a single side for 1 hour. It will be very difficult. That's why another two modality position like supine position we are trying. So this is the supine position. So this Ms. Ashwati will be talking about this position. So here also we can the patient will be very comfortable, and also you have to use compensators. So here they use rice bags for compensator, and this modality we use in our center. This is also bilateral technique, and as compared to APPA technique, the disadvantage of bilateral technique is that the tissue difference is more, because when you especially come to neck and shoulder region, the difference is more. So if any slight misplacement in the patient position may increase the dose up to 30 to 40%. So that's a challenge in bilateral method. Even we have the advantage of patient position, reproducibility, and comfort. So you have to select the radiation method by considering these factors. So the uniformity is better for APPA, but the patient comfort is more for bilateral method. So when we are designing a TBI, when you want to implement TBI, the first thing you have to think about your room size. So we personally think that the room size should at least 4 meters to a single side of the wall. So generally we install the machine to a side. It should not be at the center of the room. So we off center the isocenter. So it should be at least 4 meter distance, because if we have 4 meter distance, you can treat a patient up to 160 centimeter. So if you are firing a cross line profile, and if you are rotating the collimator, obviously you can multiply by 1.4. So that much distance you can treat. And use maximum field size. If it is called telecopal, you can use 35-30 and 35, and linear you can go for 40-40. Energy 6 MV, because you can't go for higher energy also. We practice 6 MV, and beam spoilers you should use, because you know that there is a skin sparing even for 6 MV. So to increase the skin dose up to 90%, if you want to escalate, you should use at least 1 centimeter of thick acrylic. If you are using higher energy, appropriately you have to use increase the thickness of the acrylic sheet. And for bilateral technique, you obviously have to use compensators, because we already discussed there is a tissue thickness difference. So that you have to compensate. So that also be made of acrylic. And inverted dosimetry is very mandatory, because you are expecting so many uncertainties in the delivery of TBI. So you have to verify that whatever you are delivering is correct or not. So you can go for diode offset TLD or OSLD. So it is recommended to use at least initial 25 patients with this in vivo dosimetry. And when you are getting confident, obviously you can omit that. So coming to dose prescription, there are different dose prescriptions are available. So Dr. Dinesh sir has already discussed on the prescription doses. So we have treated only single patient, that is of 13.2 in 6 fractions. And the prescribed dose is for the umbilicus level. So why we prefer umbilicus? Because when you are treating a bilateral method, the advantage of bilateral method one is that when you are going for standing technique, you have to cover the entire body. So if the patient is 160 centimeter, you have to take 5 centimeter up and down. That means 170 centimeter should cover the patient. But when you're going for bilateral method, you have an option of folding their legs. So you can ultimately reduce the field size. So if your bunker size is small, you can go for bilateral method. So that's the advantage. So when you're folding your lung, the umbilicus will come almost middle of the body. So there you can prescribe. The next question is what dosage we should deliver. All the clinical data what we are having is from telecombat and all, so that deliver lower dosage. So we also want to go with that dosage because our hemato-oncologists and radiation oncologists are comfortable with their previous data. So we also follow the same. So we follow that dosage. And dose to OIR is also a concern because we are talking about lung because that even we are delivering 13.2, the lung dose is restricted to 9 grade. So the dose rate what we are getting at our XST is 380 centimeter, and the dose rate what we are getting at 380 centimeter is almost 15.6 centigrade per minute. And when you go to the prescription dose, it will come down to 7 centigrade per minute. So this graph will tell you when you are delivering APPA or bilateral method, how much will be the dose difference. Here you can see that when we are delivering APPA, that the dose variation is almost within 10%. But when you are delivering bilateral method, you can see that the neck and shoulder region, mouth and neck region, you can expect a dose difference of almost 40%. So this you have to compensate. So what we follow in our center is that the patient, we prioritize the patient comfort because they have to lie down for a long time. So the patient comfort, stability, and reproducibility setup is very important. So this is not the first one is not our setup because our setup is this. So this completely covered with blanket. So for that demonstration purpose, I took this image. So this is legs are folded, and the hand you can keep to cover the lung because this arm will act as a lung shielding. And special attention should be made for the head, the neck and shoulder region because if there is any misposition or any small error will create so much dose. And while implementing the TBA, one of the thing is that the isocenter should come at the umbilicus level. So when you are using normal bed, it will rise only up to 1.5 centimeter, but we have to increase up to 130 centimeter. So what we made that we have made some change in the couch. So that will now we add some thickness because most of our TBA setups is our in-house development. So we added this length so we could rise up to 130 centimeter. And the dose, we are talking about dosimetry. So the recommended material is water, but unfortunately it's not practically possible to measure the extended SST measurement with water. So by applying TG21, we can use for water equivalent phantom like PMMA or plastic acrylic phantom. So this is the acrylic phantom what we use. The dimension is at least 30 by 30 by 30. And the thing is that here this image will tell you, this is taken from TG17. You can see that this is the measurement what we are doing, and this is what we are expecting, like the full scatter contribution. So you have to correct for this thing because if you are taking a larger phantom, you are expecting more scatter. That is almost 2 to 3% higher dose you can, because ultimately when you are measuring with this, you are underestimating dose by 2%. So ideally you should use this. So we applied this 2% correction also in our MU calculation. Also the back scatter, because when you are keeping the patient very near to the wall, you can expect some scatter from the wall also. So that also should be taken care. So these are the correction factor for both these, like I discussed. One is for the first one is for the phantom, full phantom scatter correction, and second one is for the back scatter correction factor. This is also taken from TG17. The next choice is the choice of detector. So the detector response should be energy independent. Why we are saying this? Because when we are doing conventional distance, we are expecting only whichever energy is measured. But when you go into extended SST, you can expect lot of energy spectrum that will change widely. So you can expect low energy spectrum also. So that also should be taken care of the TBA measurement. So the detector should be energy independent. And also stem and cable effects will be there, because when you are extending SST, the entire cable will expose to the field. So you have to take care of that. So there is a study shows that there is a 2% of difference when a 1 meter of cable is exposed to the external SST field. That means 1% additional radiation-induced current to the ionization current. So that has to be taken care. So what you can do, that you can put some build-up materials just in front of the cables. And also the FC65 cylindrical ion chamber we use for the measurements. But when you are talking about surface current, surface dose, you have to use parallel plate chambers. So this is dose calibration we implemented. So here you can see that this is the surface dose measurement. We have taken parallel plate chamber, and we inserted these chambers to different depth, and we provided adequate backscatter. And to avoid the backscatter from the wall, we put some air equivalent material. So this distance we are maintaining for patients also. So in-air measurement should be avoided, because why we are avoiding, because you can expect so many scattered radiation from wall, floor and all. So that should be avoided. So you can go for water measurements. And also all measurements should be done at the treatment distance. So when you are planning at 400 centimeter distance, your all measurement should be done at that particular distance. Why that? Because when you are increasing, when you are follow the inverse square law, almost there is a 2% difference when you are expecting the inverse square law, because of this scattered contribution. And larger phantom is recommended, that already discussed. And the use of beam spoilers during beam calibration, because when you are measuring also, you have to reproduce the same position whatever you are going to deliver for the patient. So our maximum field size is 40 by 40 centimeter, and our dose rate is 20 by 20. That's the dose rate we are getting, around 7 centigrade per minute. We are getting, if you are firing, 200 mV per minute. And the treatment distance we are having 380 centimeter. And the other thing is that the constancy of MU over long radiation hours to be verified, because when you are firing at lower dose rate, so you should ensure that the constancy of MU you are getting correct or not. The central axis measurement. So you can do PDD, TPR or TMR should be determined, but unlike the conventional modality, the TPR and TMR is normally independent of SST. But when you are talking about extended SST, there is a dependency. So that also you have to take care. And also cylindrical chambers we use for depth, and parallel plated chambers we are using the build-up region. So this is the central axis measurement what we got. So this difference because of the change in the detectors. So actually we are measured the directly output. Why? The thing is that then our all treatment scenario will be for 40 by 40 field size and the same SST. So we are not measuring at different depth or at different field size or a different distance. All the measurements are at 380 centimeter with maximum field size open. So we are directly measuring the output. So this is an output measurement rather than PDD or TMR. So inverse square test and output factor test are not required, because we are directly measuring the output. Then obviously we have to take care of the beam profiles also. So the first question is that whether we have to go for diagonal profile or cross-line profile. So if you are going for telecobalt machine, you can go for both, because diagonal profile will give you a larger field size. But when you come to a linear accelerator, you know that because of the shape of the flattening filter, when you go to the diagonal profile, the edge you can see there is a difference in the flatness. So you if you're going with that diagonal profile, you can put some filters to flatten the beam. So this is the profile what we received, that we measured at different thickness. You can the surface 5 centimeter, 10 centimeter, and 15 centimeter, and you can expect a difference of almost 7%. So that should be near to 6%. That should be corrected when you are doing the compensators. So the missing tissue compensators, how we calculated that, based on the simple calculation, I could isolate rho minus mu bt. So B is the broad beam linear accretion constant, not the narrow beam, because there is a significant difference when you are calculating for narrow beam. So this is the typical thickness we may go to use for correcting the missing tissue. And this is the compensator attenuation what we measured, because we each and every, we added one by one compensator, and we got this graph. So with this graph, you can identify how much you want to attenuate. You can put appropriate thickness of compensators. So when a patient comes to department, we measure these things like for different sides: head, neck, shoulder, chest, umbilicus, hip, knee, ankle, and arm. And the first measurement is the lateral body thickness. So you have to measure each lateral body, and also SST to each and every side. So it is to ensure that the patient is lying down exactly at that position. Because if there is any tilt in the position, we can identify by measuring the SST. And also distance from vertex, that also to ensure the position of the patient, and also the compensators we made on based on that. And the compensated thickness you have to calculate by the calculation what we had shown last slide. And this is the factors used for MU calculation. This is a typical protocol what we follow. But here, most of the parameters we already taken care at the time of measurement. Like we are measuring the direct output, so you need not use the PDD, the phantom scatter correction we introduced, but the output factor correction not required. So our point comes like output and the phantom scatter correction and off-axis correction factors. So this only will come into our calculation. So you have to calculate the compensator thickness also accordingly. So when you come to lung, so because there are some critical organs, so if you are talking about APPA, you have the option of shielding the lung. But when you come to bilateral method, you have a problem. So the arm will help you much, but still, if you want to reduce to 9 gray, you have to add additional compensator thickness. So how we can calculate? So there are different methods. One first thing is that we can calculate, take the CT data, and you can based on the pixel data you can identify the thickness. But we don't follow that. We follow single point calculation. Assume that there is a uniform or average density. So the thing is that you have only one option. You can add constant thickness compensators, because if there is a slight difference in the CT pixel data, we don't have the option to correct that. So we follow like considering the average density, we put constant thickness of compensators, and we try to reduce less than 9 gray. But the problem is that when you're using constant thickness compensators, you can expect some smaller dose or lower dose at the mediastinum. So it depends on the clinician, we can boost it whenever it's required. So these are the compensator we made in our center. So there are different dimensions of the different thickness and also different width. So this you can use appropriately for a patient. So this is the patient we treated. So here you can see that the head disc have a compensator, and neck we have added more shielding, and also this is for lung, and also this is for the knee, and this is for an ankle. So this also we made to ensure that the compensators. And next thing is that we have to ensure that whatever we are delivering correct or not. So we should go for the in vivo measurements. The in vivo measurements required for because of these uncertainties. So there are different methods or different detectors are available. So we went for diode detectors because now this is isorad, so this doesn't have much angular dependency, and also it has in-house build-up of 1.6 mm of molybdenum. And also the advantage of diode is that it will give immediate response. When you go for film or any other method, you have a TLD, you need some time to get the result. So what we follow that Dr. Finlay helped us a lot on doing the TBI. So he also suggested that you can measure, suppose we are delivering 100 centigrade, you can measure the initial 25 centigrade first and ensure that the reading is correct. If there is any small difference, you can adjust the compensator, then you continue the measurement. So this will help us to reduce any uncertainties for the entire course of time. So we also follow the same. And we bought the isorad by Sanoplea, that's for 6 MV, because the diode is available for different energies. So you can go. These are the associated components along with the diode detectors. And overall we measure the dose. So we primarily focus on head, neck, lung, and umbilicus. So most of the treatment we have put the detectors in all these areas. But when we get a confidence after 2-3 fractions, when we are getting the results are very in the expected results, then we try to put at different other positions also, even exit or hip or knee or ankle. So we tried that version also, and we could deliver the dose within 6%. The maximum deviation what we got for the PBI is almost 6%, and for she is now doing her post graduation. So this is about the bilateral technique. If you have any questions, I think after the other two sessions, right? Okay, thank you.
Thank you, sir. Now I request Dr. Praveen Kumar Adi, Associate Professor at RSO, Medical College, Thrissur, to present a memento to Mr. Jaydevan, sir. Thank you, sir. Here we have Mr. John Bose R. Canister, Chief Medical Physicist and RSO, Aster Medicity, Kochi, to share his institutional experience on TBI.
Good afternoon, everyone, all my teachers and seniors. So I'll be speaking mainly about our experience at Aster Medicity, Kochi on the APPA techniques that extend SSC that we have started with. So I'm mainly focusing on the implementation that we have done. So the workflow is, this is the workflow, simulation. This can be used. Simulation, in this first step, we have in the simulation part, we have the first patient parameters measurement, compensators, and shielding requirements. This is done at the simulation step. And the next step is the shielding preparation and immediate operation, and then determining the additional compensators required. That is done in the immediate operation part. And then pre-treatment shielding verification and checklist and dose verification. This is the setup that we have. We have two linear accelerators, one TrueBeam and second is unique performance by VM. And the frame that we have is supplied by electronics. This is the setup with the spoiler, and along with this frame we had two additional compensators of perspex and one wooden tray which was indigenously made by us. So let's come to the simulation part. Simulation part, these are the measurements. First, we make the patient to stand in this frame and do measurements of these parameters. So that includes the separation, APPA separation in the head, neck, chest, abdomen, thigh, knee, and calf. And then we also measure the distance from the umbilicus to these regions. And that is so that we can account for off-axis ratios. Okay. And also we note down the compensator requirements. So what position these compensators are to be placed. And we have marking on this frame, so those markings are noted down where these compensators are to be placed for that patient. That's also noted down in this. And then the tray also, the tray where the lung shield is placed. This is the wooden tray that we had to make indigenously. The reason is that the prospect we had is there was a risk of breaking if you put holes in there. So that's why we found this one, and this holes were put by us, and then we measured the output for this also, tray factors. And position of this is also noted down that for a given patient where this tray is to be placed, and on the left and right side you can see markings, that markings are noted down in this simulation form. Also, in this position, it's also important that where does the umbilicus lie with respect to the isocenter? Is it above the isocenter or is it below isocenter? That is also noted down in the simulation sheet, so that at the prescription level also, if you have to apply for off-axis ratio, we are applying that. Okay. Now, how do we make the lung shields? So this is the tray used. In that, You can see in the back side there is a cassette. Above this cassette we can place a DR cassette, and then we make the patient stand, and we put two reference boards. You can see these are the metal boards. So this is visible in the X-ray radiograph. Okay, and then we take the X-rays, and we have a system, DRX Evolution mobile X-rays, that has a DR system which is Wi-Fi connected to the iPad. Sorry, a pad. So that pad will give you image directly then and there itself. So then we take the print of the X-ray radiograph, applying a demagnifying factor that can be found out by distance between these two boards. Okay. And what you have on the print, you demagnify again by printing with a demagnification factor. And that print is then given to radiation oncology. They mark the lungs, and then that print is given to technologists who prepare seroquine blocks. Again, this reference board is a reference, then we paste that sheet back onto this tray, aligned with these screws. Okay. And you can note that for the cassette also there are markings. You can see C7, C8, C9. That position is also noted down for a patient where the cassette has to be placed for identification. Next step, once the simulation is over, is the MV calculation and the compensator requirements, additional compensators. Beyond the existing compensators, if we require compensators for the neck or head region, then that can be decided from here. So in this, you can see the entire, all parameters we have. So in our machine, we are able to get, the machine is asymmetrically placed. In one dimension, we can get 410 centimeter. So our setup is commissioned at 410 centimeter, and the spotter is 12 mm, and the machine parameters is again 90, 45 degree to get the maximum coverage over the entire length of patient. And the dose rate used is 300 ml per minute, not exceeding 300 ml per minute, because for this dose rate, the dose rate that we get at the extended SSD is within the acceptable levels of clinical dosage. So you can see here all anatomical landmarks. We note down the separation, and then from that we get the mid-plane depth, and then output for all the regions are taken from the beam data, which Jason already spoken about. And then for the given sites, you can see the distance from the umbilicus. Based on that distance, we interpolate the off-axis ratio and put that here. The OIRs are the off-axis ratios based on the distance from the umbilicus level. So you can see here for umbilicus level, this is the value is 1 here. That means the umbilicus is very much close to the isocenter. And then we apply for the tray factors wherever the compensators are placed. So you can see here we had a neck and chest had one tray compensator. The output factor for that was 0.972. And then for thigh, knee, and calf, we had another perspex to be placed for this patient. The tray factor for this was 0.929. And now, based on this, we from the umbilical is the prescription level, and we get the total MU by the MU calculation formula already generally spoken about. And once we get that MU, we calculate the dose in different regions based on these values and based on the death dose information, and we check if that lies within the plus minus 10% or not. If it is not within that range, then we apply additional compensators. Okay, that is the form of wax. Okay. So sometimes in the neck region, you can see here the minus is umbilicus is at minus 10%, which is at 90%, and then head is at minus 1%, and then calf is at 9% plus. So if it is more than 10% there, then we get additional compensators. So this is how we determine the additional compensator requirements in each calculation sheet. This is done manually in an Excel sheet based on the beam data. Now, parallelly, we created a plan in the treatment planning system which has all the beam parameters that we have here, again, peak volumeter and all the field size openings, and dose rate also. Ensure that it is not exceeding 300 ml per minute. That you have to determine for your institution how much it should be for your extended SSD. And then that plan will contain all this information that also parallelly created and approved and verified by senior physicists. So these are the compensators we have. We have two compensators. The visible one is at the head level, and the other one is at the thigh and knee level. And this the tray on the other side is one used for lung shields. So we have the shields prepared and verification part, pre-treatment shielding verification. The lung shields are placed back on the tray with reference to the reference bolts, and then we use the same X-ray or DR cassette and we get this. This is how we get the image. If it is clinically approved, you can see the lung is directly between the given margins from the edges of lungs. Then comes the pre-treatment checklist. So this is the pre-treatment checklist we follow to ensure that machine has the treatment plan, has all the parameters of the ME calculation, and also there are parameters which the machine plan will not have. For example, spoiler placement, and if you place additional wax in the proper place or not. So that's all checked by the treating physicist and the technology in presence of the doctor. You can see here the in-board dosimetric film placed or not, and beam spoiler in its place or not, tray whether it's used as per the initial simulation or not. And once it is verified, then we proceed with treatment. This is a case we treated. In this case, this is a single fraction. So there are no lung shading here. So first, what we do is we start with APP only. That's the first preference because the dose homogeneity will be better with APP than lateral. So this is what we start with first. If patient is not able to stand, then only we go for the next option, that is lying down position. So recently we had two patients who could not stand for second or third fraction. So we have to convert them into lying down position. So this is the first preference. If this works and if they are able to stand in the simulation procedure and verification procedure, then this is how we start with. Also, in case sometimes this is also happening in the English native, even for one fraction, some patients are not able to stand. Then we have also devised the technique of doing it on couch, APPA only, but not lateral, APPA only, but by matching junctions by feathering technique. So that using the Femcan's technique of matching parallel opposed beams, but with the feathering junction more than the separation at the skin level to get uniform curves. That in case this doesn't work out, but this is the first preference we start with. Yeah, that's all from my part. Any questions?
Thank you, sir. Questions, if any, will be discussed at the end of the session.
Okay.
Now I call upon Ms. Ashwati Raj, Chief Physicist and also Master MIMS Calicut, to deliver her institutional experience on GBA. Rest.
Good afternoon, everyone. I'm here to share our experience with TBI. So I'll be going through the clinical indications, radiation techniques, basic dosimetry we have performed and our experience. The intent of TBI is immunosuppression for non-malignant diseases and myeloablation for malignant diseases. So for that immunosuppression, we give 2 gray or 4 gray in single fraction, and for myeloablation we give 12 gray in 8 fraction for 4 days. That means per day 2 fractions, 6 hours apart. So if the CNS involvement is found, we used to give cranial boost 6 gray in 3 fractions. Regarding the technical aspects, we are having 2 linear accelerator, Radiant Unique, which have single energy, and TrueBeam, which have multiple energies. So how we are deciding in which unit we want to take. So if the patient thickness is less than shoulder to shoulder distance is less than 40, we go for unit 6 MV beams, and if it is more than that, we go for true beam with higher energies. And the SSD which we are getting with our unit is 380 if we are treating 40 centimeter separation patients, and we keep the collimator angle 45 degree. And we are using lateral parallel opposed stationary beam, and the treatment dose rate we are keeping it is 100 mU per minute, so that it can deliver 5.75 cg per minute in the mid of the plane, and the patient position is supine. So before starting, we did the commissioning of T-bed, which includes beam profiles, PDD, absolute dose, and off-axis ratios, which Jayadevan has already mentioned. So this is our TBI box, which we made. So the this it's not. So this is the ordinary ICU bed which we used, and we have extended the height of that, and above that we have placed the TBI box. This box is made of perspex. All sides are made of perspex only, and 3 sides were fixed, and only 1 side we can move according to the separation of the patient. So in this technique we are using rise compensators. So approximately in our setup we have made we have used almost 270 kg of rice for this setup. Rice along with boric powder we have used. So this is the setup of our first patient. He was 13 years old, around 80 kg. So and as we don't have in vivo dosimetry, we have used our pharma chamber for the dosimetry purpose. So we used to keep the chamber between the legs so that we can measure the mid-plane dose. So before every treatment, we used to measure the output. Then we'll calculate the MU, and then again we'll deliver that MU and measure the midpoint dose. So since August 2021, we have treated almost 16 patients with a male-female ratio 11:5, and we have treated almost 8 cases of malignant cases. So regarding this clinical findings, every treatment has the success of every treatment is less less side effects and higher outcomes. So we have measured our side effects also. So most of the patient had mild diarrhea, and 7% has parotitis, 14% had pneumonitis, and 43% had grade 1 dermatitis. And regarding the success, we are measuring the chimerism level. This is the engraftment level. That means how many cells, donor cells are there in the recipient or patient body. So the ideal value of this chimerism is greater than 99%. And in some journals, they are telling 90 to 95% is acceptable. But in our case, we have almost 100% have got greater than 97% chimerism. And the advantages and disadvantages regarding the setup is simple patient positioning and less setup duration. It will take hardly 15 minutes if the patient is cooperative and without anesthesia, and it's comfortable for patients. The only thing is the shielding of organs. We can shield only lung with the patient arms only. So that's all. Thanks to this is our team.
Thank you, ma'am, for sharing your institutional experience to us.
Now it's time for the questions. Thank you very much. There is a very good talk about the topic about the different institutional experience on TBI by Jaydev and John and Ashwini. I think the audience can ask questions to these people. Also, we are behind our scheduled time, so number of questions should be.
Actually, I have a question. So, when you use rice bag as your compensator, how do you measure the attenuation for that? Like for a MU calculation, that has to be accounted, right? No.
Because earlier we had a doubt, like we are measuring all the data in the Slack panel and we are using rice for treatment. So we corrected the density once. So at that time, for one patient, the chimerism level went to 97%. So the hematologist told that there is that patient is not getting enough dose. So after that, we have removed the density correction. So after that, we have received all the chimerism levels greater than 99. So those corrections.
You don't apply any correction. And regarding the imaging that, so when you do when you do the imaging, do the imaging even during treatment
Yes, sir.
on every fraction?
Yes, sir, every fraction we do it, and if corrections are required, then we mark that position and then try them. And that we do for if patient is very sick for last few fractions, so we avoid it. Otherwise, at least till the third day we do it.
Thank you for the presentation, actually. It actually gave what you say a wide aspect of how a person can start this TBI because we have so many illustrations here. So out of these, I have a question regarding the use of compensator. I'm asking from a point of view where we can start this type of treatment. So my question actually goes to Jaydevan. That is, that is you have used this acrylic plates as compensators. So is there any option that we can try an alternative by using these aluminum blocks, which we earlier used in the cobalt 60 rays as compensators at the level of gantry rather than near the patient surface?
Yeah, we also thought about that. But the thing is that when you are talking about the neck and shoulder region, a slight misposition at the gantry side will create a lot of difference in the patient. So the compensated position is very crucial when you are doing at the gantry side. But when you're going to near to the patient, you have an option to play 1 or 2 mm. You have the option for that. Otherwise, that will severely underdose or overdose when there is a slight misposition in the gantry position.
You don't see any shadow. The main thing is you don't see any shadow when you place the compensator on the cancer set. It will be very big. Even when you hang it on the compensator on the plate itself, it's bit difficult to identify the shadow. So, what is the position of the compensator with respect to the patient? That's the challenge over here. There's no way to verify it.
So this will be transparent, so we can see that.
Then another question is whether it can be perform this TPS based planning for this APPA based TBA.
The challenge part we face is that when you are talking about the correction, the minor correction factor, if you apply, there is a difference of 2 to 6%. And also when you are putting the perspex sheet at extended SST, I don't know how you can put at the perspex also in the TPS. So that also probably contributes some difference.
Because I've seen somewhere they place some kind of block at a particular distance, that is maybe air, and then they account for that. I'm not exactly sure what is the actual dosimetric aspect regarding that, but they have placed one what to say small piece of block in the airstream, and it accounts for the scatter or the beam spoiler that is being placed. Is there any?
No, why we are not going to discuss, because the inverse Bernoulli correction factor has a 2% uncertainty, and also the minor correction factor have uncertainty of 2 to 6%. That's why we are not trying that.
But as you said, even you can calculate SNSSD in Eclipse. If you put even 4 meters distance, Eclipse will calculate for that. You can even put, even there are people who are trying MLC compensators. But again, the doubt is like, how will you verify that? How can you exactly verify the patient position when you place the position patient at 3 meters? Whether the MLCs will again come and fit as They then told, if there is a miss, then there is a miss.
To all the team, while doing dosimetry, a lot of cable is coming in the radiation field. So, have you done any correction for that cable irradiation and not?
Definitely, so we could see that there is a difference of 1 to 2%. So we tried to prevent most of the cable leakage. That's only what we could do. And also, this is not practically possible when we are doing IVD measurements. The in vivo dose measurements, obviously the cable will expose. That unfortunately we have to neglect it. We could not find any other alternate options. We could not put any built-up material before patient.
So why can't we think of measuring that cable exposure induced a dark current or the leakage current to adding a terminator into that PLC, the end of the detector connection part?
In the measurement, we are measuring with the ion chamber, and when we are doing the IVD, we are following the diode. So the radiation induced current will be different for both.
Yeah, in each case, without the detector, the cable, how much the leakage coming because of the exposing the cable or the changing the capacitance, dynamic capacitance of the cable, that can be measured with a terminator followed by biasing.
Normally, the stem leakage measurement, what we do that we will keep without stem and with stem. That's a method of measurement.
Because your one end is open, that gives an infinite resistance, infinite impedance. That will not work. Put a terminator there, then it will work.
No, I don't know I don't understand the language what you're talking about. I'm not exposed with that.
That's what that detector physicists, nuclear physicists are doing usually. So we can try that.
Yeah. And also the thing is that the in-vivo dosimetry what we are talking about is it is reckoned only up to 250 centimeter SSD, but we are measuring a 380 centimeter. So obviously there is a difference will come in that one also. So that's a right called APARA, as precisely as readily achievable. It's not, we cannot measure exactly what the patient is getting. It's practically not possible.
Thank you, Jaydevan, John Bose, and Ashwati. I request Mr. Vishnu R, Assistant Professor, Government Medical College, Trivandrum, to come and present the memento to John Bose. And
Thank you, sir. Now I request Dr. Senia Gopalakrishnan, Associate Professor, RCC Trivandrum, to present a memento to Ms. Ashwati Raj. Thank you, ma'am. For the next section, we have Dr. Niyaz Purakkal, Chief Medical Physicist and RSO, MBR Cancer Care Center.
Good afternoon. I don't know what is your mind after hearing this much of physics and experimental part. Anyway, once again, I would like to thank you all for being here in this remote location. So we are very delighted to see all of you here. I just go through some aspects of VMAT-based TBA. This is purely from our institutional data, whatever we are practicing, whatever we have done so far. Just neglecting the introduction, you know what is TBA and all, how it comes and all. This means low dose TBA, high dose TBA, probably high dose TBA. The most common practice nowadays is 12 gray in 6 fractions or 8 fractions. If it goes for 8 fractions, that is 1.5 gray per fraction, or we practice here 12 gray in 6 fractions, BAD, twice daily. So we can finish the treatment within 3 days. Usually what we do, we start it on Thursday morning, evening, Friday morning, evening, and Saturday morning, evening. Then next week onwards, do the transplantation and other chemo things. That is our practice. Coming to delivery technique, again, that has been discussed. Generally, if you want to divide it, you can divide it into three ways. One is for dedicated irradiators. There were some machines, modified machines for giving translation, being shifting through the couch or opening whole the collimator of the machines. Nowadays, nobody is not practicing. Then modified conventional radiotherapy machines was there. And coming to the third category, that is the how we can do TBA by using modern existing linear accelerator or tomotherapy or whatever. Because everybody have linear accelerator or advanced machine, how can we perform TBA by using the existing machine? So in this, you have two options. One is you have to go for an extended SST. Why extended SST? As we know, the human height, the patient or the body height, the total height is around 1.7, 1.8 or 2 meter. So to cover the whole body with the two beams, you need to have an extended SST. That is the prime reason for going extended SST, in which you may have different techniques like APPA, lateral, or other positions that what we have seen just before this presentation. Now, the second option in the current scenario is the advanced technique like BMAT or IMRT. Can we implement BMAT or IMRT for TBA? So this is what we have done, the BMAT based TBA here. Our TBA experience started in 2021 in September. We had one patient, so we wanted to start. There was no other way. Physicist and additional oncologist, we sit together. Dinesh was there, was leading as a leading here. So we thought of which technique we will go, whether it is extended technique or VMAT based. Every technique, I would say, really, every technique has its own advantages, disadvantages. So extended SST, if it comes, it is actually one advantage or one good thing is it is a time-tested technique. So far, people are doing this, so it's really a time-tested technique. And it is more acceptable at initial point, especially clinician, they will accept it very well because they have a lot of experience with extended SST. PMAT or IMAT is a newer technique in this scenario. But thinking about extended SST, we thought we wanted to see what is the difficulty or challenges that we are going to face if we go for an assistant SST. Just like setting up of the techniques and commissioning of a TBA beam. Even though we are talking about a 6 MV beam for TBA, it's not a 6 MV, it's a new beam because at this much of 3 meter or 4 meter distance, the photon energy, everything spectrum has been changed. So it's a TBA beam. You have to commission the beam like whatever Jaydev or the study, you have to measure TMR, PDT, everything because everything will be different. And there are some inherent limitation of this technique. One inherent limitation is this is a 2D technique, not even a 3D technique, like the extended SST technique. You know how the 2D became 3D, AMRT, BMAT nowadays. So these are the different concepts or thought that really led us to in this area. Major challenges of extended technique. Even though I am telling this, I really appreciate the team, those who have implemented the extended SST technique because it's a labor. Lot of process has to be done. You have seen the compensator, the red blocks, what is the difficulty, measurements, everything. So what are the challenges they face? See, nominal PD TMR cannot work it because of this much of uncertainty, like distance factor or the scattering contributions of to this. So need to do the beam output calibration, PDD, TMR, everything. And the challenges of dosimetry again. In that previous question sessions, we were talking about some phantom size or the cable irradiation. These can do something uncertainty in the dosimetry, or these are some challenges. Definitely, you need to overcome that phantom size, large field scattering. See, so far we have been discussing several times about small field dosimetry. We know the difficulty of small field dosimetry. There is something like a large field dosimetry problem. Large field dosimetry is also its own limitation. We need to overcome by somehow of large field dosimetry. And cable irradiation is something like a factor in there because in this large field, the entire length of the cable is irradiated, and there will be, we know what is the current that we are going to collect during a dosimetry time, some nano ampere, right? So if the stem current comes in a large amount, then that is going to be something maybe considerable, I don't know. And non-application of inverse curve law and output. See, we are using some this thing. What is that? Shielding things, some cutouts and all. So what is the output factor? Whether we have measured or whether it is going to significantly change the total thing. So these are challenges in the dosimetry. Coming to the planning side, again, beam energy is an important factor. You know, suppose I want to treat my pelvis, what energy you will prefer? You prefer 15 MV, correct? If I want to treat neck and other regions, 6 MV is preferable one. Now for the TBA in extended SST, we are treating the whole body with the same energy. Even though energy variation is there, but what we can do, we don't have any other option because only two beams. I cannot change the beam. There are some field techniques are there like that. Dinesh have mentioned in the morning, but normally we go for a single energy, and this is a tissue lateral effect. Tissue lateral effect is not only for TBA. Whenever if you treat a heavy body part with a smaller lower energy, a parallel opposite beam, subcutaneous tissue will get more dose. That's called tissue lateral effect. So that's what you can see if there is a lateral TBA. Especially this will happen in the case of a lateral entry of TBA. There are some compensators, other things are used for that, but that is a challenge for commissioning. And non-uniformity is coming because of all this. Coming to the treatment room, treatment position again, standing, lying, patient sickness, other things, etc. I'm saying it can overcome, but it's a challenge. Dedicated TBA stand, box, or couch, etc. Fabrication and placement of customized tissue compensator, etc. being spoiled. So these are the challenges that we have to overcome. That is why we thought, not why VMAT, why not VMAT? Why not we go for an VMAT? So high quality treatment plan, better target uniformity in OS planning, treatment at supine position, comfortable, in the standard couch patient timeline, no need of extra beam commissioning, no need of additional patient setup system, good setup reproducibility and verification system. If you have a good verification system and good technologies and other protocols, then definitely you are going to get a good reproducibility in the setup, provided the patient also should cooperate. And apart from all this, I would say the best thing is, or the most important thing is the standardization of VMAT in your center. Tomorrow, I am going to start a VMAT in my hospital and I am going to start TBA. That is not at all recommended. You should treat VMAT or IMRT to other sites and you just get a confidence in your reproducibility of the setup, efficiency of the system. Now you are confident with the 2-3 years of your experience in delivering VMAT in a good way, then you can think about TBA with VMAT. And we, MBR CCRA, we have started in 2017, and right now we do treat around 600 cases of VMAT every year, almost approximately. So this is the TBA patient spectrum that we have done here in the hospital. So far we have treated 12 cases of TBA using VMAT technology. All patients were prescribed of 12 gray dose in 6 fractions and with different almost these diagnoses. In the month-wise, we had around 20% in the last April and almost 1 or 2 cases in other months. And this is the spectrum with respect to the diagnosis phase in subgroups of ALL or aplastic anemia. What is the workflow? As usual, other technique, simulation, contouring, planning, verification, and the treatment. That's the workflow. CT simulation. How do we do the CT simulation in this VMAT-based TBA? CT simulator, you have to take 2 sets of CT. One is in the HFS position, head first supine, and the second is feet first position. And just merge it or fuse it to see the whole dose. Immobilization device that we use, one is VAC thermoplastic cast for head and neck immobilization, then footrest that we use. Positioning or supine, arms straight, it should be like this, and no side gaps, as close as possible, and just close fingers. Then you will get good distribution of dose during this optimization. So we usually keep 4 fiducials, one at head level, thoracic level, abdomen, pelvis, 3 or 4, and probably in the lower part you will keep 1 or 2 fiducials in the leg region. Take 2 steady sets of scan length. For the head first steady set, you will take from vertex to mid of thigh, and the feet first position you will take from pelvic to the entire body, full leg. So this is how we do the simulation. Contouring, we do contour lungs, kidney, liver, lungs, and PTV. PTV crop 3 mm from the skin surface, and we give some 2 to 3 mm of overlap to the lung and kidney to get. I don't want to lose the coverage in the ribs. If you just cut it down with the PTV with the lung, probably you are going to lose some coverage in the ribs area. So just give some 2 to 3 additional margin towards the line. So this is the PTV. PTV head total PTV is the total sum of the all PTVs. Treatment planning 12 gray and 6 fraction. Upper is VMAT, lower is 3D CRT, and we do not give. We always give a single shift like a Y shift, longitudinal shift. X and Z keep in the same shift like. So the patient during the treatment, we just keep set it on the head IC, treat it, and just move the couch longitudinally. No X or Y, Z directions changes. It should be in the same way. This is how the arcs or 3D CRT plans are. Lower leg we treat with the 3D CRT plan. I mean the lower part of the body, and this one is VMAT. Planning parameters, we do the treatment plan in Monaco planning system. Photon of 6 MV is being used. Gantry increments 24 and field size, that is very important. You need to fix your collimator during the VMAT. We just keep it a fixed collimator optimization. 30 by 30, that is the total field that we give. I mean for all VMAT fields, arcs. And 4 to 6 centimeter overlap between two arcs. Definitely one there will be one IC, one arc will go up to here, then there will be another arc here, another arc here. So there will be some overlap between these two arcs, 2 to 4 centimeter. So minimum segment with grid spacing calculation matrix 4 mm we give. Otherwise, if you give 3 mm or 2 mm, system will take a lot of time for optimization. 4 mm calculation we do, optimization we will do, then it will convert to 3 mm as grid size for final calculation. Statistical uncertainty is 1% per plan we give for in Monaco planning system. Minimum segment width is 1 centimeter. We don't go for a very tiny segments too, because we know the treatment time the patient has to lie on. So uncertainty, we just reduce the potential uncertainty. Just give 1 centimeter segment width. Maximum 150 control points per arc, and the points is medium. These are the planning parameters. 3D CRT plan is very simple. What we do is keep 2 or 3 isocenter depending upon the patient length. Simply APPA fields. APPA fields. So if there are 2 fields in the 3D CRT plans, definitely there will be a junction. I don't want to rotate gantry or couch or nothing, because this is an APPA. Even if I rotate and match the PA field, AP is going to abut and give the dose. Now, one good thing is the APPA is coming in the leg region. I am not doing 3D CRT in the lung or abdominal or pelvic region where I have a more tissue separation. Leg region, the beam has to travel only this much of distance. So whatever the cold spot or hot spot, it is going to be in a smaller tissues, like bundle of tissue is less. And again, we give a feathering in the 3D CRT plan. This is how we do the feathering. You can see here, somewhere like 5 mm gaps in between, and we do the feathering between 3D CRT fields. And this is how the distribution looks like. 90% is given in the green color. Red is 110%. This is how 3D and VMAT plans looks like. If you fuse the total, then you will get a distribution, a fairly good distribution of 90% of those to the whole body. With that red you are seeing is 110%. 110% is the hotspot that we are looking. We make it less than 5% or whatever, like as minimum as possible. Plan evaluation, we have done. We do the plan evaluation in terms of various quantitative metrics. This is the total. All our 12 patients are these patients. 90% dose. The volume of 90% dose is 95. 95% we are getting. 95, 92, and 100%. 12 gray is prescribed. 12 gray is getting to 83 or 84% of the total volume. And regarding the hotspot, 110%, it's around average value is 2.7. We in between 3-4%. It is the 110%. Absolute value is also calculated. Homogeneity index, we get around 0.897. That is the average homogeneity index that we are looking for a plus or minus 10%. That means 0.9. So we are almost at 0.897. Coming to the OIR dose constraints, the figures, the scores are this one. Mean length dose 8 to 9 gray. We try to be within below 9, 8 to 9. So we are at almost in the same 8.7 between lung and kidney. Liver 10.4. These are the actual data of our 12 patients. In another important thing, the QA in TBA, especially for the VMAT based TBA. So we have this being a complex treatment modality, it requires an institution protocol for simulation, planning and treatment. Accurate localization of the organs and setup reproducibility is very, very important, especially if you go for a PMAT plan. Strict adherence to the QA protocol. QA protocol include a basic QA protocol that will tell you your machine output, profile constancy, the constancy during the arc check, isocenter accuracy, everything. Then we will have some patient-specific pre-treatment QA. Pre-treatment QA, what we have done, point dose measurements at each VMAT IC, point dose in abutting field to check the hotspot or cold spot are coming in the abutting region, fluence measurement in individual arcs. We can measure it by 2-dimensional detector and 3-dimensional detector, whatever we have. We did it both way. Dose reconstruction in the junctions just to see what is happening really in the abutting region, and dose rate independence, because we give the treatment in a low dose rate mode, so we just want to ensure if I change the dose rate in the machine, whether it is the exact plan is going to deliver, exact fluency is going to deliver in the low dose rate also. These are the detectors that we use, iMatrix or Dolphin and solid water finder. This is the results of our isocenter measurements by using FC65 chamber. So we are within 5% in all 12 patients. So these are 12 patients you can see, and series 1 to 4 represent IC, because one patient will have VMAT 3 or 4 ICs. That's the every IC we have checked the dosimetry. Coming to the fluence comparison, we did with the iMatrix with all ICs, IC1, IC2, IC3 for all patients, and we found a very fairly good gamma, 98.1 for 3 mm 3%, and 2 mm 3% is 96.19 for IC1, and the respective values are given. So, there is no much variation as we expected, like any other VMAT plans that we execute in the clinic. This is the matrix results. You can see the upper one is the TPS value, fluence, and the lower one is the measured value. You can see the difference, how it is matching. This is another patient in which the first IC is covering the head as well as some part of the lung region. So almost agreement is here also, it's very good. This is the second IC of another patient where the lung is being treated with a good agreement. You can see gamma passing rates. If you plot, we are within 90% within 3 mm 3% gamma, and 2 mm 3%, which is also the least value is 85. That is being acceptable in this thing. Any worry about junctions? I don't want to worry about to hit my car on another car, because this junction is not a true junction. Because abutting region, I'm just giving you some overlapping. One car go to just kiss another car, nothing to worry. So still, I just want to confirm what is it going out of plus 10% or minus 10%. That is what I just want to ensure. So these are the abutting fields. You can see the first VMAT. This is first IC, second IC, third IC, fourth IC. This is the abutting between. So whatever the fluence modulation taken care, this area will be taken by this arc and this arc. So that is why it is just like an abutting. So still we measured we just put the chambers in any points, random points between these, and we measured the dose and find what is the variation of this dose with the actual TPS dose. So that is the result here for all patients we have. For IC means 3 junctions. So junction 1, 2, 3 we did. Some patients will not have third junction, that is why it is not applicable. So everything is within, I would say 8% or 10% is maximum we get. This is the junction dosimetry of these abutting fields in graph. So we just measured or checked this with the Dolphin detector also, because this ionization chamber measurement is only a point just for the 2D. With some patients we measured the Dolphin. So we are getting, this is an absolute centigrade value. So we are in a satisfied result. So this is not the actual TPS fluence. This is the fluence measured by the detector. So you just see how it's going to be like. It is not going to be much variation in the junction. Whatever slight difference in gamma that you are observing, that is something where in the lung or the ribs regions where you feel some inhomogeneities in the tissues, not for the junctions. My calculation software has some deviation from the Monaco TPS. Monaco exactly maybe a better gold standard model for this junction or from this inhomogeneity calculation. Treatment delivery coming to the LINAC, we give the all shifts and this shift will be treated from longitudinal directions. And for us, we have two linear accelerator from Electra, Versa HD Synergy. Both machines are beam matched. I can take my patient any machines because it's a beam matched. If one day I can read first machine or second day. Imaging, KV imaging we use. Treatment time approximately, that's the question, how much time it will take for executing all 3-4 hours. Depending upon the patient length and the modulation things. Setup time we found is 20 to 30 minutes, and treatment beam on time is around 50 to 70 minutes. For that's the range of the value that we have for our 12 patients. So total, I would say 70 to 100 minutes, 1.5 hours for one patient for the actual in time time in the machine. Treatment slot, we give first patient treatment at 7:30 morning and the second fraction 6:30 in the evening. This is the MU chart. For this patient, only 3 IC. First IC will have 1 hour, second IC will have 2 hours, third IC will have 2 hours, and total of 2,500 MU is being delivered for this GPR. Dose rate. I know what we struggled initially. Do we need to go back to dose rate in conventional technique? Of course. Dinesh has pointed in the first section. See, conventional, how we get a low dose rate, that is again an interesting thing. See, conventional SST technique, I have a 600 MU per minute in the LINAC, for example, the dose rate. I am going to treat the patient on 4 meter distance from the source. So 4 meter distance inverse square law is 1 by 16. So 1 by 16, 600 by 1 by 16 is around 300, 150, or that is going to be 75 centigrade per minute. That is the low dose rate that is inherently we are getting. Even we can reduce it. Now for BMAT still, I don't know whether, see, discussion comes, then radiobiology comes. We don't have a definite answer whether we have to accept or we have to reject. I don't have a confidence to accept a high dose rate. I don't have to have a confidence of taking, like, I mean, the clinician, everybody is something like, because every data, whatever the data that we have with the extended SST technique, that is being delivered in the low dose. So we thought of giving the low dose rate initially for all hours. For example, 200 centigrade I am delivering with 1200 MU in the thorax region. So the MU centigrade per MU is 0.17 centigrade per MU. We can deliver the arc with 100 MU per minute in the LINAC. That I can change it in LINAC. So this is going to be 17 centigrade per minute. So that is almost close to the conventional dose rate. That is how we are doing right now. So still, I can even increase. Now what we do in the current practice, initially we have done all the arcs with the low dose rate, but it will take long time for the treatment. Definitely, if the machine is giving 100 MU per minute, it is going to be, the patient has to spend long time in the machine. Now, head, pelvis, and leg we give normal dose rate, and thorax and abdomen, where we see importance for lung dose and these things, we pneumonitis and all, we just give for a low dose rate of 17 centigrade per minute approximately. Now, with the dose rate, whether the fluency is going to change, we checked it and we found without the dose rate, the QA is passed, nothing to be worried. Are we satisfied with the result? Yes, of course, with good treatment plan, dose map in all planes, organ dose, DVS, more patient comfort, that is very important in supine position. And in our institutional experience, we got a good reproducibility. I would like to thank our technology team. They are very brilliant. We are making a very good setup for every TBA patient. But I would say women is very sensitive to setup shift. So we recorded the imaging shift. We asked to record what is the actual shifts that we are getting from the patient position. Mostly we get in longitudinal direction, maximum 2 to 3 mm. Sometimes we get 5 mm, 6 mm shift. Then we go and reset the patient. Then we get 2 to 3 mm shift. Then what we have done, we just checked the given, we gave the detector that shift and we measured the fluorescence. So what is the event, what is the thing happening because of this shift? So longitudinal IC shift, IC1, IC2, IC3, we have given that deliberately this shift and measured the gamma value in 3 mm and 2 mm. So we don't find much of variation with 2, 3 mm. You can see here, this is no shift, 1 mm, 2 mm, 3 mm, 4 mm. Up to 3 mm, 2%, 2 mm, 3% gamma is okay, satisfactory, even though you are seeing this one. But I'm sure if I have a shift of 2 mm plus in IC1 and 2 mm minus in ICM to IC2, that is going to be very difficult in the junctions or this region, hotspot or hotspot. But if there is a shift, it should happen in the same direction. So we should be very, very judicious while setting the patient. And if there is a like more shifts obtained, that is, then we have to reset the patient. That's why I told we should have a good VMAT experience in our center before we start TBA. This is the shift that we can see here. You can see that edge shift because of 4 mm. This is the maximum 4 mm we have given and done the measurement. Just lateral, I don't find much of variation. Only 4 mm is getting a bit of difference up to 3 mm. This is a 2 mm gamma, not 3 mm gamma. This is again fine. Vertical almost not much difficult with the shift. Just 2 slides. Anything to be added? Of course, we should have some rotational immobilization system lacking currently to change the patient setup from head first to feet first. That's what we are looking for now. And what about the skin dose? Again, debatable. See, as a BMAT, as I'm practicing BMAT, this is something like the other BMAT because we already have the BMAT optimization and we are okay with our patient. But still, I'm excited to see what actually is getting to the skin. I should have it on in vivo dosimetry. We're just looking for that also. This is what I need to conclude here. Purely institutional study, BMAT based TPA, planning and execution. The data is for last 3 years. Accurate treatment planning and positioning. We have treated 12 patients since 2021 and good agreement in QA that increases our level of confidence to move forward, especially for boosting our TMLA or whatever. And I should acknowledge our team physicians and this is not our present team, those who are involved in this TBA, right from Dinesh sir and Johal sir and all other physicists. I should appreciate my physics team. They do QA regularly of TBA and getting very good results, and that is wonderful work. And therapists, of course, they are doing a lot of work from morning and evening for setting up the patients and getting good reproducibility in the setup, and other assisting supporting staffs. Thank you all. This is our team.
Thank you. Any questions? I have one question. I think it will be more to Dinesh sir. So when we have our parallel opposed cases, we were restricting the dose rate because there was not much of shielding that we give to our critical organs. So when we do BMAT, there is a provision for us to save our critical organs. Then should we worry about the dose rate again?
I don't have the competence to answer it, but I think if you look at the literature, I think all these dose rate issues fail to with insignificance once you're able to restrict the doses to the critical levels. Because you're sure it's a three-dimensional planning you're seeing. You're able to ensure very clearly the doses. A lot of uncertainty in the 2D plan, so we are not able to take that kind of liberty in our normal tissue dose evaluations. But in this case, I think in a fractionated PBA, I think these are all not very relevant. I don't have the competence to say that, but I feel we should not be very worried about he has what he correct on. These are old time and a lot of answers. Now we are able to evaluate, we are going to do the dosimetry, the number of values, everything is there to give you the confidence. But my question to you would be, I mean, given the different technology, how easy to implement in Electa has got a very good MLCs, which other machines are not able to replicate, and with the limitations in a protein variant MLC, is it possible to replicate easily? Because the number of isocenters you need to have will be tremendous with the limitation of the Y jobs. I need your take on both.
No, like when you have Electa with a complete MLC, we have the large speed with both complete 5 mm MLC. We can do the optimization much better when compared to the Electa machine. So Electa definitely, baking machine definitely will be a challenge. So we have a talk on Halcyon, how Halcyon is going to do that. So we'll discuss on that.
So again, with respect to the dosage, even though we set 600 mU per minute, if you actually see the delivery time, it will be around 50 mU per minute. Right. So that is significantly reduced when you do VMAT based. Okay.
So the machine itself will reduce it because the total dose delivered per fraction is less because of that?
No. that is very important. Actually, 600 MB, if I give 3D CRT plan, the machine will give 600 MB per minute fully. But VMAT is actually modulation of dose rate, arc, everything. So even if the maximum dose rate is 600 MB per minute, but it won't deliver 600 MB per minute. That is why the treatment time is going to be. So sometimes I will get 300, 200, 150, even if I am not giving 100 also. For this particular one, I can give 100 MB per minute in the Ejecta mosaic, so that it will take only 100 MB per minute. It won't go beyond, should be on that. That's what we do. Any questions?
VMAT technique seems to be simpler than other conventional techniques. Then why do you feel that it's not much popular?
The answer is I have given you in one of my slides. Conventional technique is a time-tested technique. Suppose if you want to buy a car, which one do you prefer? I mean, I am going for an SUV. I would first thing is coming a Creta or something like time-tested car. I know that Creta is a good car, and there are some more cars in the market, but I'm not like this is not a it doesn't have that much of experience in the field. And another second thing is VMAT is a good technique, easy to implement, but if there is a patient positioning difficulty, if there is a 5 mm, 6 mm shift, I'm not confident in the setup reproducibility, you are going to lose everything. Conventional technique, you are still in the field. That is an APPA field. You are still in the field. You are not going to miss drastically. There may be some variation in the lung region because of the block. The patient moves some bit, the blocking area must be changed, but still you are in the field. So you should have enough confidence. You should have some good setup of VMAT, institutional experience of VMAT. Then now the people are moving. I think people may move maybe in the future. Yes, yes, please.
Adding to that is that when we are doing with VMAT, it requires significant time. I will also share in my slides. It will take a week to complete one good plan to execute. Whereas in the conventional technique, we can just do the calculation on the previous day and we can start, which is not possible because for contouring itself, it will take significant amount of time to contour the pole, especially when we are moving to TMI or TMLI.
Yes.
Regarding this ISO center, is it actually possible to achieve just using three ISO centers, right? But maybe because the variant machines, it may not be possible.
Suppose in the variant machine, you may have to do some lateral shift also. I think you can.
It is possible if you rotate the collimator to negative. I will also share in my next presentation. I will share those slides.
What about the respiratory motion? How do you manage there?
Okay. Sorry. Yes, respiratory motion. Actually, we do not do any tracking or anything else. Like whatever we do for our abdominal or thoracic VMAT, the same thing only. We use a backlog for mobilization system and head rest. Nothing.
One more question. Thank you for the superb presentation.
Thank you.
You were talking about some overlap distance. So, you mentioned it is about 4 to 6 centimeters. So, how did you conclude that?
Actually, 4 to 6 centimeter is nothing you don't find from journal. To be very honest, that I got from my own experience. It is written some that you have to give some overlap. Again, that 4 to 6 is not a constant, depending upon the patient width. If the patient is too obese, thick patient, you have to go for a 6 centimeter. Sometimes patient is lean, you can give it 2 centimeter. The concept is, if I make it zero, like what is that matching field. During the whole rotation, there will be some missing tissues. So in that part, we are giving those constraints to the system. The system will try to push those without field or field deads. Then you are going to have some hotspots in some other areas of the plant. You will have some cold spot. Your MU will be going to shoot up. We got 2,500 MU here. That may go to 4,000, 5,000 something. And you will get a very bad quality plant. So that is why it is advisable to use some overlap. The overlap length that you can decide, you will get an idea whilst you do the plan. with the different.
With different overlaps, you'll plan and finalize, or
4 to 6 actually. 4 centimeter we use as a minimum, 3 or 4. Then sometimes after 1 or 2 optimization we will understand there are some hotspot. Then you think what is the reason? What could be the reason? Just expand it or reduce it, you will find.
And one more thing, you are combining VMAT with 3D, right? 3D?
Yes.
Okay. Why did you choose that? Like, why can't you do complete VMAT?
Very good question. See, VMAT and 3D CRT. See, why VMAT? One reason is I am not having an extended SST technique. Now I also want to shield the lung or kidneys or liver, whatever. So I use a VMAT here. Now feet in position, I am going to treat the leg only. So simple APPA can work it. I don't want to do any optimization. I don't want to do spare any region here. Now still I can do the VMAT, but only problem is if I do VMAT, see these are two sectors. First VMAT is HFS and second VMAT is feet first position. So you are going to rotate the patient. Now I am not sure first VMAT ending point and second VMAT ending point. I cannot fix the field border. If it is 3D, I just keep the isocenter in that end of the VMAT. Then usually we put some lead wire on the patient itself and just mark that region. We'll keep the 3D IC. So it is less complicated than going for VMAT. One thing, and second thing, I don't need any optimization because I can do it 3D. Simple.
One more question.
Please.
You were talking about that feathering. So, like, how often will you do it?
Feathering, what we practice here is 3D CRT. If there are two ICs, we do feathering every day. Just we don't shift the isocenter. We keep the same isocenter. Just overlap the jaw 5 mm first day. For example, first day 3D field, the Y1 is 5 centimeter, let us say. Then I just copy that plan, make it 5.5 centimeter. Then copy again that plan, make it 6 centimeter. Now the first day itself, then just divide the dose by 3. Okay. Then first day itself, it will radiate 5 centimeter field, 5.5 centimeter field, 6 centimeter field. Similarly, the other field will also reduce. So just like opening the jaw, no shifting the IC for feathering. So in the machine,
3D only single IC or
3D we cannot get single IC most often. We have to go for either 2 or 3 ICs. Yes. Junction between rapid arc or VMAT and 3D. At that junction, we normally keep it a lead wire on the patient. It will come in the mid of thigh region. We keep it here. This is least bothered area for us. I don't have a lung here, kidney, nothing, no organs at risk here. So even if there is a bit of higher dose, I'm not much worrying with the permission of clinician. I'm not going to much worrying in that particular region because it's a small stretch. It's there. I agree. It's there. I cannot exactly match VMAT or 3D CRT at this particular point. That is why I kept the junction at that region. So what I will make sure I am not going to underdose that particular area. If I overdose, how much dose is going to get? 12 plus 12, that is 24 grain. That is going to be some 2 mm. Definitely not 24 grain, 20% high. That is 20% is around 14 grain. That is going to be a 1 mm or 2 mm slice. 2 mm region. So that cannot be further. To reduce that hotspot, what we do, 3D CRT beam, we keep the 3D CRT first beam will be half beam. So there won't be any divergence of 3D to the VMAT. So we just keep the IC on that junction of 3D CRT. So that 3D CRT won't give any divergence to the VMAT. Of course, VMAT can give small divergence, but that is only in a segmented. So that is our practice. There can be some 10% or 20% for 2 mm.
I think we'll go.
Thank you, sir. I request Mia sir to please stay back on class. Now I call upon. Now I call upon Mr. Ukash Ahmed, Assistant Professor and RSO, Government Medical College, Kannur, to kindly deliver the memento to Mia sir. Next, we have a session on TBI by using tomotherapy. For that, I call upon Dr. Henry Finley, Lecturer, CMC Vellore, to the dais.
afternoon. I take this opportunity to thank the organizers for giving me to talk on total matter irradiation using tomotherapy. I also especially thank my teachers, Dr. Raghu Kumar and Dr. Saju Basi, for this opportunity. We all know that TB is performed for myeloablation, immunosuppression, and to provide space for stem cell engraftment and to treat the sanctuary sites where chemotherapy may not be effective. We do practice TBA since 2005 at Christian Medical College, Vellore. We treat with bilateral technique at an SSD of 385 centimeter. The dose delivered is 13.2 gray or 12 gray if it is 6 fractions, or 2 gray or 4 gray if it is a single fraction. We do with 6 MV photon beams and we use 1 centimeter beam spoiler, which is kept at a distance of 354 centimeter from the source and on which the compensators are hung. We do in vivo dosimetry either with diodes or OSLD. Here we can see these are the PDD graphs which we have obtained. We have measured in 4 different treatment units and as Dr. Dinesh highlighted that we need to treat the skin also. Here we can see that PDD where we get a higher dose at the skin region also. We have also evaluated the beam spoiler effect and we have noticed when the beam spoiler is closer by 30 centimeter to the patient where we get a maximum dose, and we have also measured the beam profile and 140 centimeter up to 140 centimeter length patient can be treated well within a uniform dose distribution. Moving from TBI to TMI, the intensity modulated beams from either from tomotherapy or a linear accelerator can significantly reduce the dose to normal tissue, and it could provide a safe dose escalation. And the newer approaches enable to generate total marrow irradiation or total marrow lymphoid irradiation. This graph highlights that when we are doing TMI, the critical organs can be spared significantly, whereas in the case of TBI, the critical organs also receives the target dose. What is the difference between TMLA and TMI? In the case of TMI, the skeletal bone and the bone marrow is taken as the target, whereas in the case of TMLA, the major lymph nodes, liver, spleen, and the sanctuary sites are also included as target. The OARs considered are lungs, heart, kidneys, lens, oral cavity, parotid, and bladder. We have treated, I will just briefly explain our experience with the VMAT technique, and we have treated 46 patients with VMAT technique where the dose given was 13.5 gray in 9 fractions initially, then we escalated to 15 gray in 10 fractions. This is the schedule which we do, and if the sibling, the donor is a sibling, then first we do the TMLA for 5 days and followed by chemo conditioning, and then bone marrow transplantation starts. Whereas in the case of haploidentical donor, first chemo conditioning takes place, followed by irradiation, and then donor infusion, stem cell infusion. This is one of our publications where clinical details are published. This is one publication which we recently published in Stalin Therapy, which gives a clear information on VMAT technique for TMLA, and this would also serve as somewhat like a guide if anyone is willing to start. So we also take 2 sets of CT images, one head first and feet first supine. In the head first supine, we cover from the vertex to the mid thigh, and in the feet first position, it is from the toes to upper thigh, and the slice thickness is 5 mm. The immobilization device used is a thermoplastic mask for the head and neck region, and a whole full body vacuum bag is used. A common isocenter is placed. We are placing the common isocenter at the level of trochanter, both for the head first CT and the feet first CT. Coming to the contouring, all bones except mandible, hand and foot were contoured. The lymph nodes include all neck nodes except the level 1. The supraclavicular, infraclavicular, axillar, mediastinum, parietic and pelvic nodes were included. Differential CTV to PTV margins were given. For head and neck, it is 3 mm. Thorax, abdomen and pelvis, it was 5 mm. And for extremities, it was 1 centimeter. We arrived these values by carrying out a positional uncertainty studies, and using Bernhardt formula, we have identified this margin will be sufficient. The planning is carried out in native TPS with Acros algorithm with 600 photon beams. We do use 3 or 4 isocenters depending upon the length of the patient, and here we can see this is a template which we use it if we are using in an if the length of the patient is more, we use 4 isocenter. We can see this is the first isocenter we have kept, and the collimator is rotated to 90 degree. Like for example, if we take the first isocenter and let us consider that this is an arc, which we consider first arc. For the first arc, the field size is placed such a way that x2 is 15 centimeter and x1 is 3 centimeter for effective modulation, and in the second arc, the field size is kept as x1 as 3 and x2 as 15, so that a region of 30 centimeter is covered. We do keep an overlapping region of 4 centimeter so that at the surface a minimum of 2 centimeter is overlapped. This is the dose distribution which we could achieve with the TMLA plan. And we have done an extensive analysis on different doses to the target with 13.5 dose regimen as well as with the 15 gray dose regimen. Also, we have reported the homogeneity index as well as the conformity index. We have analyzed the critical organ dose, and we have represented the OAR dose as a mean, median as well as the range, and the standard deviation is reported, and all the doses were found to be within the tolerance dose. We have also analyzed the monitor units for each isocenter, and we can notice here around 600 mu is required to treat a skull isocenter, whereas in the abdominal region it is around 800 mu. Also, we have reported the time, how long we take to perform this technique. For simulation, if you see, it is around 1.5 hours for an radiation oncologist, and 2 technologists who are directly involved in the simulation and image acquisition. And for contouring, we nearly take 18 hours to completely contour the OARs as well as the marrow. Now we have reduced with our experience. Initially, during our planning, we take 4 days for entire planning, but now we could achieve within 3 days, or within 3 days we could achieve it. And if you look into the treatment time, it is something around 2 hours, 1.5 to 2 hours, including the imaging. Moving on to the tomotherapy-based TMI or TMLA, Mackey et al. Introduced the concept of helical tomotherapy with the delivery of intensity modulated treatment beams, where the patient is continuously translated through an aperture. The gantry rotates continuously around the patient and delivers a fan beam, the fan beam with a maximum field size of 5 in the longitudinal direction and 40 centimeter in the lateral direction, and the helical dose delivery is possible. The source to axis distance is 85 centimeter and the diameter of the bore is 85 centimeter. The slice beam is modulated by a rapid opening and closing of the binary MLCs. There are 64 leaves, each of width 6.25 mm at isocenter. It moves much faster than the conventional MLCs. It works on pneumatic pressure system with an average open to close time of 20 milliseconds. The energy used is 6 MV triple photon beam. Coming to the isocenter part, there are 2 isocenters. There is a real isocenter which is at the center of the bore, and it has a virtual isocenter which is 70 centimeter away from the real isocenter, and there is no laser inside the bore. and hence the virtual and ISO center is generally considered as a reference point. Also, it has two laser system. One is green and a red laser. The green laser is stationary, which represents the virtual ISO center, and the machine specific QA. For all machine specific QA, green lasers are used. Whereas for the patient positioning, the red laser, which is a moving laser, that is used. There are three parameters that are very important for treatment planning, that is the field width, pitch, and modulation factor. These parameters influence the dose distribution and the delivery time. Understanding these parameters are very, very important for planning. So what is field width? Field width is defined as the full width at the half maximum of the longitudinal dose profile in the isocenter plane. Three different field widths are possible: 1 centimeter, 2.5 centimeter, and 5 centimeter. That is, for example, if you have to treat a 10 centimeter treatment area, if the field width is 5 centimeter, then the treatment area is covered with 2 gantry rotations. Suppose if you choose field width as 1 centimeter, the treatment area can be covered with 10 gantry rotations. So the treatment time depends on field width. Here you can see an example with 5 centimeter. So it took only 7 minutes, whereas with 1 centimeter it is 35 minutes. Also, we should notice the difference in the dose distribution also, so we should optimize with respect to the complexity. The next factor is the pitch. Pitch is the distance traveled by couch during one gantry rotation per field width. It again influences the speed of the couch movement as well as the gantry rotation. So rearranging the above equation, that pitch into field width will be the couch movement per gantry rotation. Suppose let us consider a pitch of 0.2 and a field width of 2.5, then the couch moves 0.5 centimeter per rotation. Now if you increase the field size to 5 centimeter, then couch moves 1 centimeter in per rotation. Again, if you reduce the pitch, let us consider from 1.5 to 1.3 to 1.6 for a particular field width, then we have more faster rotations. Here we can see in this diagram that for a particular field width, there are only 3 gantry rotations. At the same time, for the same field width, there were 6 gantry rotations. Here it is very important that we need to check the gantry period, because the tomotherapy unit has ability to have a 5 RPM, maximum of 5 RPM. So which means if it is 1 RPM, then it is 60 seconds, then 5 RPM divided by 60 is around 12 seconds. So we need to adjust the pitch such a way that the gantry speed is between 11.8 and 60. Then only the field can be delivered. Also, we should consider an effect called thread effect. This appropriate pitch causes a smooth dose profile. Otherwise, we can see a thread-like distribution where we can see a hot spot. So, Cheng et al. Has given a good table for different dose regimens and for different field width of 5 and 2.5. And this can be an initial pitch value which we can do, and we should optimize it for our clinic. Third one is the modulation factor, which is a trade-off between a plan efficiency and the freedom of the optimizer to vary the beamlet intensities to achieve planning goals. So modulation factor is defined as the longest leaf opening time divided by the average leaf opening times, and it impacts the gantry rotation speed. As we lower the modulation field, the gantry period is faster, which will affect the conformity of the plan. Again, we should keep it in mind that the thread effect. Also, they have given an idea how to match the junction, because we are planning in 2 CTs, which I will explain little later with our experience. Then this is a paper with Timothy et al. And they have compared the dose distribution between the TBA and TMI. For a 12 gray prescription dose, the median dose with the TBA to bone marrow was 12.36, and with TMA it was 12.83. And we can notice that there is a significant reduction in the OAR dose. Nearly 35 to 40% of dose can be reduced with TMI technique. Another paper by Bo et al. Has also shown the difference in TBA and TMI with 12 gray dose, and they have also shown a significant reduction in the OAR dose. Also, they have shown the treatment time around 45 to 1 hour it takes for the treatment to treating the upper region and the lower region around 20 minutes. This is another paper which highlights the impact of field width. So you can see here a 1 centimeter field width. The treatment time is around 2.45 hours. Whereas when the field width was increased to 2.5, the treatment time is around 51 minutes, and further increasing to 5 centimeter, the treatment time was significantly reduced to 29 minutes. So the Dr. Chiliburi et al. Has published paper where they have highlighted the time resources. They have also highlighted it took one with this is with the tomotherapy treatment, 1.5 hours for simulation, planning around 44 hours with an effective working hours of 12, and treatment delivery is around 1.5 hours. As usual, as it is a modulated beam, it is necessary to measure the point dose measurement. Generally, it is done with Cheese phantom and X-radian phantom. It is not necessary to carry out with the same setup. We can use the institutional phantom. The fluence verification is done with arc-check dosimetric system because the detectors are placed in a cylindrical fashion, or we can use Octavius 2 system where which can be used because we cannot use 4D system because the tomotherapy, the RPM is 5 mm. The detector is not capable to rotate in that equate with that faster movements. Generally, the preferred gamma analysis is 3% by 3 mm. Though it is easy to see that, but performing QA is quite challenge. We like for setting up for performing a QA for TMI, we need to split into multiple regions. In the case of VMAT based TMI, there are different ISO centers, so we create plan for different ISO centers. Here the target is 1, so we have to split into 3 different regions. We move the target, like for example, here you can see the phantom is moved to a region of head. So this is where our CT isocenter is. The difference is something around 75 centimeter from the isocenter. So we have to set the phantom at the virtual isocenter, then manually move the couch inside the board to 745. The important thing is that we know that if the detector, the dosimetry system, electronic components should not be exposed. So we have to see carefully and we need to interrupt the button. We cannot create a small split beams to perform the QA. So we have to interrupt it. So if we have to do the other region, again we need to move the detector or move the couch to a different position. Again it will start. Like for example, if you have to do for the thorax region, it will start from the head only, from the vertex. So it will go in here. So when the detector goes inside the board, we get the fluence. Again, we have to monitor it properly to stop the beam. So their delivery analysis has a good software which is
When performing a
provided by
DIBH treatment, the
Accurate
patient
and
takes a
which
deep
can
breath and holds.
quantitatively
Align
compare
RT
the plan
verifies
and
the patient
measure
is in
fluence
precisely the right
sinogram,
position
and
and
it
all
can
6 degrees of freedom before
quantitatively
enabling the
compare the
radiation
deep
beam.
open time sinogram also. Also, we can compare from one fraction to another fraction. It provides 2D and 3D comparison maps for evaluation. So this is again, I will share our experience. We have treated 9 patients in October 2022. And the simulation remains the same as that of VMAT technique. We take head first and feet first CT with 5 mm slice thickness with a thermoplastic mask and a full body vacuum bag. And the common isocenter is again placed at the level of trochanter. All bones and lymph nodes are contoured in Eclipse TPS, and we also give this same differential margin. The planning is done in accurate precision TPS with convolution superposition algorithm. The dose now what we prescribe is 15 gray in 10 fractions. Here it is important that though the precision TPS has the ability to do optimize patient means a target length of 135 centimeter, it is better to split into multiple targets so that we get an effective modulation or a good homogeneous dose distribution. For this, we take time in splitting these targets like PTV head and neck, and PTV thorax, pelvis, and abdomen, and this to which the constraints will be given. Also, we need to create ring structures in order to confine the 50% isodose. But the latest software they have introduced in the Volo, the normal tissue optimization, the one which we have doesn't have this normal tissue optimization. So the ring structure plays a major role in confining the 50% isodose. So again, now the matching between the upper CT and the lower CT is that we need to create a dose gradient structures. So here you can see in the upper CT, so this is the target which is delivered with 15 gray. Then we create a 2 centimeter long dose volume gradient to which we deliver. We assign during optimization 12 gray and another 9 gray, 6 gray, and 3 gray, so on. Similarly, we create a structures in the feet per CT. So when we sum up, we get a uniform dose. So this is the window where we give the modulation factors and pitch factor, and the field width is selected. And unlike the regular thing, we do no normalization in VMAT technique. We here the target is we have optimized to 80% isodose curve for the target, which we have taken it as pelvis because of the separation difference. We have noticed that if we optimize to 80% isodose at the level of pelvic, we get a good homogeneous dose distribution. So you can see this DVH, we are able to get a good DVH. So this is a isodose distribution where we could spare effectively the critical organs, kidneys, liver, and heart lungs are very well spared. Also, it is possible to deliver differential dose if you have to treat the brain. Again, it is full dose is given. Otherwise, we limit it to 12 gray. So this is what we can see that the dose gradient dose. So they have given MIM software. Using the MIM software, we can add both the head per CT and feet per CT to see the uniform dose distribution. So with our experience, this is the median dose which we have received with tomotherapy. Earlier with the VMAT technique, our dose to lung was around 8 gray, where we could limit furthermore to 6.5 gray, and all the critical organ doses are well within the limits. Also, we did a small analysis with a different field width, 2.5 centimeter and 5 centimeter width also, where we can see the difference in the beam on time. So this is a setup. We can start with positioning during the treatment delivery. For head first CT is treated first. Patient is positioned at the trochanter level, and we have multiple tattoos at different level. One at this EM level and thorax level, so that we maintain that patient is lying in the straight line, and the head first CT is treated first. So first imaging is done. So to verify the position, we can see here for the imaging, it takes around 7.2 minutes. Then the treatment, you can see it is around 30 minutes. And once we complete this, patient is rotated by 180 degree, and the feet first CT is done. Again, imaging is done. It is again a time consuming. It takes around 7.5 minutes, and the treatment is around 7 to 10 minutes. So this is the analysis for our patients. So for setup, it requires around a total of both CTs will require around 20 minutes. Imaging takes around 20 minutes for head first and feet first. Again, verification has to be done by the oncologist, and the treatment delivery is between 30 to 40 minutes for a head first CT and 8 to 12 minutes for a feet first CT. Overall, the interim time will be around 1.5 hours. Coming to the QA part, we do fluence verification with ARC check. So we create a hybrid plan in the treatment planning system, and we deliver. We make sure that electronics are not exposed, and we evaluate the fluence and with a criteria of 3% per 3 mm. Also, we did to evaluate the junction dose. We have evaluated with film measurements in a slab, and we can see this is with the head first CT, and this is with the leg first CT, and here this is a combined dose distribution. The scanning values were exported to the Excel, and this graph was plotted, and we see around 6% variation at the junction. So this is one, as I mentioned earlier, the delivery analysis one useful tool that we can analyze the gamma evaluation between the planned and the measured. For even we can measure for all fractions also. We can measure, we can analyze for pre-treatment QA as well as post-treatment analysis. It will give a trend analysis here. You can see this is for the 10 fractions, 5 days treatment. We can see the trend. The DVH can be analyzed, so it gives, we can do the pre-treatment analysis as well as the post-treatment analysis. At the end of each treatment, we can analyze the DVH also. Other thing is that leaf open time, whether the leaves are opened at the planned time or not, that can also be analyzed. Each day can be analyzed. Then we can also analyze the total leaf open time. Here you can see nearly the 2,50,000 leaf as opened at the intended planned time. We can see there's a small amount of maybe around 5,000 or so. There's a small, maybe around 10 millisecond difference. We can see the difference in the leaf opening time also. We can analyze. This can be analyzed for individual fractions as well as the cumulative fractions. There is another option to verify with a threshold dose also, whether how much dose is varying. Like if I here for this example, we are given a threshold dose of 2 CGY, and the planned as well as the delivered dose difference is highlighted in this graph. So finally, to summarize, BMAT and helical IMRT offers dose escalation to the target with lower critical organ dose and reduced toxicity and relapse rates. More clinical evidence is needed for better understanding of the total dose and fractionation schedule, dose rate influence on organ toxicity and marrow engraftment, relapse rates within the target and avoidance structures. I take this opportunity to invite you all to a hands-on workshop on TMLA, which we are planned to conduct during 22nd and 23rd of September. We invite you all. Thank you.
Thank you, Henry. Any questions?
Sir, thank you for the presentation. Sir, what was the reason to split it into different PTVs in the target objective?
Yes. Because if you give it as a whole volume and there are different OARs, so it concentrates generally for optimization, concentrates on a local area, and if you give a wide area, that dose to critical organs is not achieved very easily. Then we get more inhomogeneous dose distribution. So when we split into multiple targets, and that is considered as target, we give dose to that each target, and when we optimize, we get a very good homogeneous distribution. More than that, the OARs are very well means within the control within the tolerance.
We are using the same pitch and modulation factor.
Yes.
So
Yes.
we will be giving the same penalty for like same minimum dose, same maximum dose for all targets.
Yes, we give, but if we want to tweak in between, we tweak little bit.
So that affects the OAR dose.
Yes, depending upon the OAR and the target dose, we model means we change the importance or the overlap prior.
Regarding this planning, you have defined these fields. So many overlapping fields are being defined. So in these overlapping fields, do you practice feathering?
What we do is that first, in the case of VMAT technique, first we plan the isocenter which is placed at the pelvic region. So after achieving a good plan, then while calculating the isocenter placed at the thorax level, means abdomen level, we take this pelvic VMAT as a base plan. So there's an option of having base plan technique facility in the Eclipse planning system. So we take it as a base plan, so we get a good smooth junction dose that is not affected. So in similar way, when we go to the thorax region, we take this abdomen plan as the base plan.
There could be a small amount of setup uncertainty while positioning patient in multiple isocenters. So there may be chances for cold spots or hot spots if there is any systematic error or something.
We have extensively analyzed that positional uncertainty also, and we have measured with dosimetry, means film dosimetry, and where because we are almost getting an uniform fluence distribution as we have taken it as a base plan. There is no significant hot spot or cold spot noticed during the planning itself. So the same thing is what we have said in the film dosimetry.
Sir, for QA, you were talking about to interrupt in between. So, like, how do you define at what point you have to interrupt it? Only on time or?
Yes, like you see here. So this is the calculated dose profile. So this is the calculated fluence. So when it starts measuring, we do not get this fluence completely. So it will start from here. So it keeps adding. And when it is coming to this, let us say that is value is not here, let us say it is 4. When it reaches this distance, we interrupt it. So we are expected, our intention is to calculate the variation, to find out the variation, the fluence in this distance. So when the fluence is adding up, building up, and reaching this area, we interrupt the beam.
But in merge option, I think you can't load it first, right? Or the TPS planned one, you have to load it first, or?
Yeah, we are loading it first the TPS plan, then we are doing the measurement.
Okay, sir. Thank you.
So, which method you will suggest, like extended SSD or VMAT for a single fraction?
Actually, Dr. Nias gave a very good answer that we should have good experience. Like extended SSD, it is easy. First, you take all dosimetric data, and once you are sure your dosimetric data is well and good, then we can easily perform the treatment. Whereas in the case of VMAT, we gain experience, and then it has a multiple ISO centers. If you have time, and we should have a team for contouring, then the TMI will be better on.
For single fraction, in that VMAT and all, that feathering part and many complexities will come.
Single fraction, it is ideal to go with TBA.
And we are having HDMLC. Will you suggest, how long will you suggest?
Yeah, again, we have to rotate the collimator to 90 degree, and you may have to add one or two more ISO centers. The treatment time will be very high. The planning time will also increase.
Do you have any suggestion regarding the number of ISO centers?
I think as the width is low, we may have to keep multiple isocenters in a region itself. Like for example, if you have to treat thorax, we are now using only single isocenter for the thorax region itself. But in the case of HTMLC, we may have to keep lateral isocenters. So the number of isocenters might double in the case of 2.5 mm HTMLC.
Thank you. Okay, in the interest of time, since we are running late, we can have questions when in the next year. So we'll conclude this session.
Now I call upon Dr. G. Ramakrishnan, RSO of SMCI Medical College and former Director of DRS, to kindly hand over our token of love to Dr. Henry Finlay. Thank you, sir. Thank you, sir. I'm sure all of you are saturated for the time being. So let us break for the lunch. The lunch is arranged in a hall downstairs. There are two lifts on either side of the hall, and the organizing committee will be guiding you to the hall. So please be back by 2:30.
AlignRT Advance enables greater patient comfort, safety, and accuracy for SRS treatments. AlignRT Advance delivers an SRS solution with proven outcomes and documented sub-half millimetric monitoring accuracy. The AlignRT Advance SRS solution utilizes an open face mask combined with real-time monitoring that enables high positional accuracy, safety, faster treatment times, and enhanced patient comfort with proven results to give patients peace of mind. Prior to bringing the patient into the treatment room, prepare the table by placing patient accessories such as a knee sponge, custom headrest, and headboard in the proper position. If your Linac does not have a 6 degrees of freedom robotic couch, the Vision RT 3 degrees of freedom head adjuster allows the user to make fine adjustments to pitch, roll, and yaw prior to imaging. Your Vision RT regional sales manager can provide additional information about the head adjuster upon request. Once ready for treatment, align the patient to the general location of treatment ISO center. Next, use AlignRT Advance SGRT technology to begin monitoring and manually apply any gross corrections before placing the open-faced mask on the patient. To facilitate positioning, the user can utilize the AlignRT Advanced Postural Video subscription feature. Postural Video provides an outline of the reference surface superimposed onto a live video stream of the patient, showing a real-time view of the patient's overall alignment relative to the reference position. This is a great tool to resolve any gross misalignments of the head, chin, or shoulder position. The user can see a camera eye view from all 3 camera pods to ensure the best setup possible. Once gross misalignments have been resolved, place the open face mask on the patient. With the mask in place, use AlignRT Advanced to fine-tune the patient setup using the real-time deltas, which demonstrate where the patient currently is and where they should be in real time. The real-time deltas generated are based on the selected ROI. Adjust rotational deltas first, either manually or by using the adjustment knobs on the 3 degrees of freedom head adjuster. Then adjust translations by free-floating the couch or using the couch controls until all deltas read as close to 0 as possible. With the patient properly aligned, the user can then perform internal imaging according to department protocols and apply corrections if needed. After corrections have been made, the user can then take a new reference capture which zeroes out the deltas at the corrected position to monitor the patient throughout treatment delivery. Once a new reference surface is captured, the user can then review the regions of interest from which all deltas are derived with the help of the 3D photorealistic reference. The 3D photo license provides a photorealistic reference of the patient's surface, providing enhanced visualization to ensure proper drawing of a region of interest. The user is now ready to begin treatment. AlignRT Advanced monitors the patient even during couch rotations, providing continuous feedback to ensure there is no unacceptable motion during radiation delivery. AlignRT Advanced monitors 6 degrees of freedom in real time and with the proper configuration and licensing has the ability to hold beam if the patient moves outside of tolerance, thereby safeguarding the patient from inaccurate treatment delivery. AlignRT Advanced provides the ability to deliver treatment as planned, safely, accurately, and efficiently, giving your patients a comfortable experience and peace of mind. The intuitive interface and efficient workflow means you can provide these benefits for every patient, every fraction. AlignRT Advanced, advancing the science of surface-guided radiation therapy. AlignRT Advanced enables greater patient AlignRT Advanced enables greater patient comfort, safety, and accuracy for SRS treatments. AlignRT Advanced delivers an SRS AlignRT Advanced, advancing the science of surface-guided radiation
Over the next
therapy.
few minutes, we'll prepare you for your treatment. We use the latest generation surface imaging guided system to treat your cancer. Our CRAD Catalyst cameras are constantly
AlignRT
looking at your body
enables
position
greater patient
to deliver
comfort,
your radiation
safety,
therapy in the
accuracy for
safest
SRS
and most
treatments.
effective means
AlignRT
possible.
Advanced delivers an
When you're ready,
SRS
take
solution
that deep
with
breath.
proven outcomes and documented sub-half millimetric monitoring accuracy. The AlignRT Advanced SRS solution utilizes an open face mask combined with real-time monitoring that enables high positional accuracy, safety, faster treatment times, and enhanced patient comfort with proven results to give patients peace of mind. Prior to bringing the patient into the treatment room, prepare the table by placing patient accessories such as a knee sponge, custom headrest, and headboard in the proper position. If your Linac does not have a 6 degrees of freedom robotic couch, the Vision RT 3 degrees of freedom head.
Wherever life plants us, bloom with grace. Life is a wonder. Every day in our life matters, and what makes it count is a simple smile of happiness. Welcome to MVR Cancer Center and Research Institute. We believe in eternal happiness. One of the finest cancer centers and Research Institutes. MVRCCRI is named after Kerala's renowned veteran leader M.V. Raghavan in recognition of his contribution to the cooperative sector in the state of Kerala. A milestone in India's cooperative sector, MVRCCRI connects international experience and healthcare services with a world-class facility.
MBR Cancer Center and Research Institute is the first multidisciplinary standalone cancer center. Came up 3 years ago in Kerala. In 2012, some of us like-minded people under the leadership of Mr.
Align RT Advance enables greater patient comfort, safety, and accuracy for SRS treatments. Align RT Advance delivers an SRS solution with proven outcomes and documented sub-half millimetric monitoring accuracy. The Align RT Advance SRS solution utilizes an open face mask combined with real-time monitoring that enables high positional accuracy, safety, faster treatment times, and enhanced patient comfort with proven results to give patients peace of mind. Prior to bringing the patient into the treatment room, prepare the table by placing patient accessories such as a knee sponge, custom headrest, and headboard in the proper position. If your Linac does not have a 6 degrees of freedom robotic couch, the Vision RT 3 degrees of freedom head adjuster allows the user to make fine adjustments to pitch, roll, and yaw prior to imaging. Your Vision RT regional sales manager can provide additional information about the head adjuster upon request. Once ready for treatment, align the patient to the general location of treatment ISO center. Next, use Align RT Advance SGRT technology to begin monitoring and manually apply any gross corrections before placing the open-faced mask on the patient. To facilitate positioning, the user can utilize the Align RT Advance Postural Video subscription feature. Postural Video provides an outline of the reference surface superimposed onto a live video stream of the patient, showing a real-time view of the patient's overall alignment relative to the reference position. This is a great tool to resolve any gross misalignments of the head, chin, or shoulder position. The user can see a camera eye view from all 3 camera pods to ensure the best setup possible. Once gross misalignments have been resolved, place the open face mask on the patient. With the mask in place, use Align RT Advance to fine-tune the patient setup using the real-time deltas, which demonstrate where the patient currently is and where they should be in real time. The real-time deltas generated are based on the selected ROI. Adjust rotational deltas first, either manually or by using the adjustment knobs on the 3 degrees of freedom head adjuster. Then adjust translations by free-floating the couch or using the couch controls until all deltas read as close to 0 as possible. With the patient properly aligned, the user can then perform internal imaging according to department protocols and apply corrections if needed. After corrections have been made, the user can then take a new reference capture which zeroes out the deltas at the corrected position to monitor the patient throughout treatment delivery. Once a new reference surface is captured, the user can then review the regions of interest from which all deltas are derived with the help of the 3D photorealistic reference. The 3D photo license provides a photorealistic reference of the patient's surface, providing enhanced visualization to ensure proper drawing of a region of interest. The user is now ready to begin treatment. Align RT Advance monitors the patient even during couch rotations, providing continuous feedback to ensure there is no unacceptable motion during radiation delivery. Align RT Advance monitors 6 degrees of freedom in real time and with the proper configuration and licensing has the ability to hold beam if the patient moves outside of tolerance, thereby safeguarding the patient from inaccurate treatment delivery. Align RT Advance provides the ability to deliver treatment as planned, safely, accurately, and efficiently, giving your patients a comfortable experience and peace of mind. The intuitive interface and efficient workflow means you can provide these benefits for every patient, every fraction. Align RT Advance, advancing the science of surface-guided radiation therapy.
Over the next few minutes, we'll prepare you for your treatment. We use the latest generation surface imaging guided system to treat your cancer. Our CRAD Catalyst cameras are constantly looking at your body position to deliver your radiation therapy in the safest and most effective means possible.
And when you're ready, take in that deep breath.
And to provide the highest quality of care, our team of healthcare professionals are specifically trained to use this system. A series of lights will visually coach you during your treatment. while 3 cameras actively measure the exact position of your body with sub-millimeter accuracy. And all the while giving your medical team a 360-degree view of your body during treatment. This system keeps you safe by constantly evaluating the position of your body, and if your body gets out of alignment, it will immediately stop the treatment. Because it's so safe and effective, our CRAD system is trusted by some of the most respected brands in healthcare. Brands like MD Anderson, Northwestern, Mayo Clinic, and many others. The system also allows you to play an active role in your own treatment. Breast cancer patient Mary Beth Grassi had this to say about her experience. "I really liked the setup of the CRAD," Grassi said. "From the deep inspirational breathing to the visual cues, from the different colored lights, I felt like I was an active participant in my treatment and had some control over my care." While we can treat any cancer our cameras can see, the CRAD system was primarily designed to safely deliver radiation therapy for treatment areas that change with your breaths, like cancers found in the breasts, lungs, and abdominal regions. In this video, we'll focus on breast cancer treatments used in conjunction with a specific breathing technique. However, the same principles also apply to other types of cancer treatments as well. Before your treatment can begin, we need to do some initial planning. We call it a simulation. Your physician has determined that the type and location of your cancer will benefit from a specific method of treatment, DIBH, or Deep Inspiration Breath Hold. The purpose of the DIBH technique is to minimize the amount of radiation exposure to your heart. For your simulation, we'll take 2 scans to analyze your body position and pinpoint the area of treatment. The first scan is free breathing, where you breathe normally. For the second scan, we'll use the DIBH technique, or breath hold scan. As the name implies, you'll take a breath and hold it for 10 seconds while we scan your body position. While you're holding your breath, a series of lights will change the color of the room. These colors will visually coach you on your treatment. By the way, these visual color cues are the same for use of tablets and goggles as well. The room will turn blue when you're breathing normal. It will turn green when you're holding your breath and your body is in the perfect position. And if the room turns orange, you took too deep of a breath, and we'll instruct you to release some of your breath until the room turns green again. After your simulation, we'll add 3 tiny dots to your skin. These dots, together with a recording of your breathing, will help us properly align your body during treatment. Usually about a week after your simulation, you'll receive your first treatment. Before treatment begins, we'll take an X-ray to make sure your breaths and body position are consistent with your simulation. Then we'll practice your breath holds. The treatment room will change color just like in the simulation, giving you active feedback of your body position while you're holding your breath. During your treatments, your radiation therapist will be in the control room overseeing everything. They'll use the intercom to communicate with you every step of the way. Remember, if you can't hold your breath as long as you'd like, or if your body is not perfectly aligned, your treatment will immediately stop to keep you safe. Now, relax and breathe. You're in good hands.
When performing a DIBH treatment, the patient takes a deep breath and holds. Align RT verifies the patient is in precisely the right position and all 6 degrees of freedom before enabling the radiation beam. At times, patients may attempt to achieve the same vertical displacement as deep breath hold by arching their back. In this situation, even though the patient's vertical displacement is within tolerance, Align RT identifies that their position is not the same as in the true breath hold. Align RT holds the beam, protecting the patient from inaccurate radiation dose. When performing a DIB,
Your doctor has prescribed radiation therapy as part of your cancer treatment. You may not have realized that being in the proper position during radiation therapy is important to ensure radiation reaches the right spot and avoids exposing healthy tissue and vital organs such as your heart. We use Align RT, a state-of-the-art precision technology that tracks your skin surface 10 times a second to help ensure you're positioned correctly before and during treatment. How does Align RT work? Align RT uses a system of cameras mounted to the ceiling that sends information about your body's position into a software program. Each camera uses a projector and image sensors to create a 3D surface model of an area by projecting a speckle pattern red light onto your skin. This speckle pattern allows Align RT to reference thousands of points on the skin, acting as virtual markers. This imaging information goes to the software program, enabling accurate tracking of your position during setup and radiation therapy treatment. The system constantly monitors you and alerts your radiation therapist if you move from the optimal position. In some cases, it automatically pauses treatment if this should happen. Targeting the tumor and not surrounding healthy tissue, Align RT can be used for precision therapy on cancer sites from head to toe, accurately ensuring perfect positioning for breast, brain, prostate, head and neck, lung, sarcomas, and pediatric tumors. The Align RT system helps ensure that you are in the intended treatment position with high accuracy and can help reduce your imaging dose and treatment time. And Align RT uses less invasive frames and open masks to enhance your comfort while maintaining your safety. Align RT may also reduce the need for permanent tattoos or marks in some patients. In the past, patients were given 3 to 4 small tattoos to provide alignment of the affected area. We have chosen to use Align RT because it's been proven to provide more accurate positioning than tattoos and marks, and because patients have shared with us their preference for a tattooless or markless treatment approach. That's why we use Align RT technology to give you peace of mind, knowing you'll be getting the best treatment possible. Your doctor has prescribed radiation therapy as part of your cancer treatment. You may not have realized that being in the proper position during radiation therapy is important to ensure radiation reaches the right spot and avoids exposing healthy tissue and vital organs such as your heart. We use Align RT, a state-of-the-art precision technology that tracks your skin
defined by the collimator settings. And the third condition is comparable detector size. That is, if the detector size is comparable or larger than the field cross-sectional area, then also the field is called as small field. In modern radiotherapy, there is a growing trend towards the utilization of small fields. High dose to the small volume, as in like SRS and SPRT, subdividing the large fields to small segments, as in IMRT, VMAT optimizations, and non-uniform dose distribution, as in conventional simultaneous integrated boost. So, about the dosimetry of small fields. It includes reference dosimetry and relative dosimetry. Reference dosimetry means the absolute dose measurements, and relative dosimetry includes the PDD output factor measurements. And the important thing in the small field dosimetry is the machine specific reference field, which corresponds to the conventional 10 by 10 reference field for the machines which cannot establish the conventional 10 by 10 reference field, that is cyber knife tomotherapy, etc. So, since the field definition for the small field highly depends on the detector size, the choice of the detector for the small field dosimetry is very important. So, the aim of the study is to find out the output factors for small field as per the IAEA TRS 483 protocol using different dosimeters available at our institute, and to compare them with the Monte Carlo values. Moving on to the materials and method, these are the chamber details that I have used for the study: CC13, CC08, CC01 and Racer nano chamber. And among them, Racer nano chamber has the lowest volume, which is 0.003 cc, and CC13 has the highest volume. And for all the measurements, the chambers kept perpendicular to the beam central axis. About the workflow of the study, first profile measurement was done, and then FWHM was found out. From FWHM, the S-clinic value, which is an equivalent square radiation field, was calculated by using the equation root of A into B. Since the measurements was repeated for multiple times, the A is the mean value of inline FWHM values, and B is the mean value of cross-line FWHM values. Then output measurement was done, output factor was found out. Then output correction factor, which is given as a function of S-clinic in the documents, is applied. Then we will get a corrected output factor, and finally this corrected output factor is compared with the Monte Carlo data. Now, the study carried out in variant true beam LINAC with an energy of 6 MV flattened beam, and an IBS smart scan RFA is used as the phantom for profile measurement, and as a reference chamber, stealth chamber is used. A stealth chamber is the transmission type detector, which is have an active area of 21.9 by 21.9. With an optical transparency over 75%. Since it has this active area, it is suitable for the field measurements for 0.5 to 20 by 20 centimeter. And it is made of material called Lexan, about 3 mm thick. And for output measurement, the phantom used was IBA WP1D phantom. As the name suggests, it allows the chamber to move in one dimension only as depth-wise, and it comes with a smart control unit which allows the chambers to move with a step size of 0.01 mm to 100 mm, and the electrometer used is dose X. So, the determination of field output factor. The field output factor with respect to the machine specific reference field FMSR is given by this equation, and it is used to convert the absorbed dose to water for the machine specific reference field to the absorbed dose to water for the clinical field. The field output factor can also be derived as the meter reading ratio which multiplied by the correction factor, which is chamber specific. Now, about the results, the data shows the values from profile measurements. The stealth chamber as a reference chamber can cover the field chamber in the same beam direction, was very useful for the measurements. Since it covers the field there is no need to enter the treatment room to adjust the position of reference chamber, which helps to reduce the measurement uncertainty due to laser alignment and orientation dependence during the measurements. Since the dimension for CC13 was greater than the field size, it was excluded from the data, and from the output factor measurements, the p-value test implies that the Racer nano chamber and CC01 chamber shows a close agreement with the Monte Carlo data, and CC08 shows a significant difference with the Monte Carlo data. The charged particle disequilibrium and greater volume averaging for CC08 result in underestimation of the output factor for small fields. The output factor for square fields with correction, that is for CC08, the correction factor was not there in any published documents, so it is excluded in this comparison. The difference between Monte Carlo data reduced with the detector specific correction factor is when it is added. For the field size below 2 by 2, CC01 shows an overestimation of output, and percentage deviation for CC01 was 10.44%, and for Racer nano chamber it was 1.5% for 0.5 by 0.5 fields. And the figure shows the scatter plot of output factor with the field size for with and without correction factor applied. The output found to increase with the increase in field size for CC01 and Racer nano chamber. And in lower field size, CC08 shows the uncertainties compared to other chambers. Below 2 by 2, the readings didn't show any particular trend for CC08. As a conclusion, for smaller fields, the variations of output factor increased according to the detector volume. The Racer nano chamber with an active volume of 0.003 cc measures the output factors for small fields more accurately. CC01 also gives a comparable result. Below field size 1 by 1, CC01 is not suggested for the measurements. CC08 and CC13 are not preferred over the above mentioned chambers for small field dosimetry. So these are the references I've gone through for the study. Thank you.
It's open for discussion now. Shall I ask you the first question? The Racer nano chamber, TRS 483, that does not give the KQ values for it, no? Yeah. So where did you get the KQ values for Racer chamber?
From a paper, like it's a published document.
What is the reason for the overestimation of output factor in small field with CC01?
I couldn't find any justifying reasons from other journals. Like many papers reported the variation of around 11 to 12%, but all of them were underestimation of the data. But we got it as an overestimation.
Did you try anything with diode detector?
No, I was just trying with the ion chambers that we have.
Any other question?
You have talked about Monte Carlo values. Have you generated Monte Carlo values or taken from some publication?
Yeah, it was not a generated value. It is taken from the machine data.
Machine?
Like a variant, the data from the variant.
For the same machine?
Yeah.
Any other question? Okay, thank you.
Thank you.
So we move on to the next talk. It's Swati S. Kumar, and she'll be talking on dosimetric verification of doses delivered during a single fraction of total body utilization, treated using conventional manual planning technique. Your cheer is also going to be counted. So make sure you cheer for your friends, okay?
My topic is dosimetric verification of TBI using nanodot OSLDs. And the two main objectives are to report the surface doses during a fraction of TBI and to report the percentage variation in doses measured on patient surface compared to the prescribed dose per fraction. First, an overlook into the theory part. What is TBI? As we have discussed, it's a commonly used part of conditioning regime for bone marrow transplantation used in the treatment of a variety of diseases such as leukemia, lymphomas, etc., so that it suppresses the autoimmune system of the body and to prevent the rejection of transplanted bone marrow. We use a conventional 2D planning technique with extended SSD. Now coming into OSLD, it's an abbreviation of optically stimulated luminescent dosimeters. The sensitive region is aluminum oxide doped with carbon. Now getting into the TBI techniques, it has been designed historically to deliver a relatively homogeneous dose throughout the whole body, but due to large variations in the body geometry and tissue density, the whole uniformity window is being specified as plus or minus 10% of a prescribed dose, except where we need dose tailoring in case of critical organs. The most relevant method of delivering TBI is with patients standing or lying down at an extended SSD with the largest practical field size open. At shorter SSDs, we can have multiple abutting fields necessary, where the radiation of the whole body can be achieved by translating the radiation field or the patient, or by sweeping the radiation over a stationary patient. In case of megavoltage irradiation, skin sparing is often a desirable feature, but in case of TBI, we desire the skin surface to get nearly equal to the prescription dose. So in the lateral technique, a plastic screen is used as a beam spoiler. The mechanism is that the photons passing through the spoiler eject scattered electrons, and they deposit most of the energy at the shallower depths near the skin surface. This is the positioning of beam spoilers during the treatment. Next, coming into the patient positioning. As we know that TBI may last up to 30 to 40 minutes, so a comfortable and reproducible position is necessary. So when a pair of parallel opposed APPA direction is advantageous, as the body thickness in this APPA direction is usually smaller than the lateral direction, so we can obtain a more dose uniformity along this direction. First one is APPA standing up position, and the second diagram shows the lateral positioning. Coming into the compensators and shielding, on comparing APPA and lateral position, better dose uniformity is obtained in APPA positions, and the dose variations can be reduced by using missing tissue compensators or tissue equivalent bolus material directly placed on the patient body. Dose to the lung can be reduced by using lung blocks, but the complexity is that we may be able to reproduce it in all fractions. For lateral techniques, arms can be used as a lung shield. This is the placing of lung blocks on a patient and the EPID images of lung blocks. And the right side, you have the compensators mounted on the gantry end. Next, the measurement part of the TBI. Measurements for planning purposes include the thickness of the distance from the soles of the feet, and the points are top of the head, forehead, chin, suprasternal notch, xiphoid, umbilicus, central axis, pelvis, thigh, knees, calves, ankles, and toes. Next, into the QA part. Right side, you have the diagram of the QA we have done in our institution with the solid water phantom, the thickness directly closely matching the patient thickness, and with a calibrated ion chamber and a beam spoiler. Now, the materials and methods. It's an observation study conducted in our institution with 3 consecutive patients in SSD 340 centimeter in a 6 MV linac in APPA position. Both high dose and low dose are being considered. High dose is 12 gray in 8 fractions, and low dose is 2 to 4 gray in 1 to 2 fractions. And coming into the dosimetric part, we have OSLDs, nanodot OSLDs. During the first fraction for each patient, dosimetric verification is done with the help of OSLDs placed on pre-planned positions, and OSLD readings are acquired using an OSLD reader. These are the pre-planned positions: head, neck, right chest, left chest, umbilicus, right thigh, right calf, left calf, and the right palm. Right side, you can see the diagram, how we place the OSLDs just with a micropore. These are the patient setups. First one is a standing upright position. The second is the lateral recumbent position. This is the tabulation for all the 3 patients. First, you can see an APPA direction, patient A with total dose 1200 centigrade. Second patient with total dose of 200 centigrade in lateral recumbent position. And the third patient with total dose of 400 centigrade at the lateral recumbent position. And this is the observation table. We have observed it for separately patient A, B, and C, and a common percentage variation. And I have obtained the maximum percentage variation of 14.57 in right palm, which is an extremity. Now, getting into a discussion where we can discuss an advantage of using OSLDs for dosimetric studies: good reproducibility, dose linearity, small dependence of energy and dose rates, and it can be conveniently placed on patient body. The limitation of the study is that I've considered only a small number of patients, and OSLDs are highly sensitive to minor variations in its position during the treatment. And with this study, I conclude that we have observed a clinically acceptable dose distribution throughout the regions of interest with nanodot OSLD measurements. Thank you.
It's open for discussion now. Any questions?
Yeah. Actually, you have told that right now you are getting maximum variation of 14%.
14.57.
But
From the prescribed dose.
but the abstract which you submit shows some 54%. So So could you please clarify that?
So, abstract?
Abstract, submitted abstract. In that it is given some 54%. Maybe proper paper.
So, it is 14.5. So this one is the correct table. OSLD calibration. The same as we calibrate TMD. First, so you need the steps calibration. Okay. Okay. First, we radiate the OSLDs with different doses. Then, using an OSLD reader, we get the charge collected in coulombs. Then we plot a glow curve with corresponding dose and charge.
Could you please elaborate one or two advantages or disadvantages of OSLD over TLD? What is the benefit of OSLD over TLD?
Yes, sir. Dose linearity is better than smaller dose rate and angle dependence. Then it's easier to place on a patient more than TLD.
Threshold is what?
Dose range 50 kilo electron volt to 20 mega electron volt. Dose range.
Again, why that three different reference doses like 150 centimeter, 200, 200?
First one is a standing APPA, and the B and C patients is lateral recompense with two low dose and one high dose.
That's it? Okay, thank you. So we'll move on with the next presentation. Amar Jose, and he'll be speaking on overcoming the technical challenges in the commissioning of Halcyon TM ring gantry linear accelerator, insights from an institutional experience.
Good afternoon all. The topic of my presentation is overcoming the technical challenges in commissioning of Halcyon ring gantry linear accelerator, insights from an institutional experience. So recently, my institute regional cancer center have installed and commissioned Kerala's first Halcyon machine, and since we are used to conventional Siam Linux, a change to organry system was a challenge. So here I will be sharing the challenges and the experience in commissioning of Halcyon Linux in our institute. So let me begin with an introduction to Halcyon. Halcyon is an organry Linux having a single energy of 6 triple and a nominal dose rate of 800 mu per minute. And it is also equipped with MV and KV imaging, and it have a beam stopper which eliminates the requirement of a primary barrier, and it also have a stacked and staggered dual layer MLC. These are the dimensions of Halcyon, and it have a bore size of 100 centimeter. A bore is something which we are not familiar in case of conventional Siam Linux. So let's have a comparison between conventional Linux, for example, TrueBeam and an organry system Halcyon. So in case of TrueBeam have double, triple, and electron beams, whereas Halcyon have a single energy 6 triple beam. When it comes to the MLC leakage, true beam have 0.1% of MLC leakage, whereas for halcyon it is 0.01%. And in the case of Ganry speed, halcyon is 4 times faster, and in case of MLC speed, it is twice faster than that of true beam. And true beam have bending magnets, whereas halcyon does not have any bending magnets. And the Dmax of 6 plus beam of true beam is at 1.5 centimeters, whereas for halcyon it is at 1.3 centimeters. And another important feature is that you can skip the machine performance check in true beam, but you can't skip that in halcyon because that verifies the relation between virtual isocenter and the treatment isocenter. In true beam, we have pendants and couch side panel controls, where the pendants and couch side panel controls are missing in halcyon. Side panel controls are available on the Ganry. So even though halcyon have many things, halcyon is missing with optical distance indicator ODI, which we are familiar in case of conventional Linux, and it also does not have field light and crosshair. Even though halcyon have lasers meeting at the isocenter, even though halcyon have lasers, they are not meeting at the isocenter. And halcyon also does not have isocentric motion of couch. So these missing factors contributed to the challenges we had in commissioning. So Varium provide a representative beam data set RBD consisting of PDDs, profiles and output factors, and this RBD set is used by Varium to create pre-configured halcyon optimization and those calculation models in Eclipse. So there is no need of feeding data to DPS, but those missing factors in halcyon contributed to the challenges during this process of commissioning. So the challenges were in the placement of RFA on the couch, in setting SSD, and in accurately positioning the chamber at isocenter. So the first challenge was setting of the RFA on couch. So for most of our measurements, we used 3D scanner cylindrical RFA from Sun Nuclear. This RFA is detached from its supporting system and placed on the couch. The RFA have a dimension of a height of about 70 centimeters and a width of about 90 centimeters, and this need to be placed in a bore of dimension 100 centimeters. From this figure, you can see that how close the RFA is to the board. So utmost care should be taken to avoid any collision between the RFA and the board. So we used prefix couch positions of vertical -34, longi 129.5 and lateral 0 to position the RFA. And Sun Nuclear has supplied a couch positioning plate CPP to position the RFA. The design of CPP is such a way that it matches exactly with the 3D scanner lift rig and also the couch positions of F1, H1 and H3. And since halcyon does not have a 6D couch, it will not correct the sag that will be created when we place the RFA on the couch. So in order to compensate the sag, there is a wedge design for the CPP. So the next challenge we faced was to set an SSD. Since we don't have optical distance indicator, imaging was the only method to set the SSD. In order to set an SSD of 100 centimeter, high quality MV static images were taken from a Ganry angle of 90 degree, and then we will be measuring the difference between the isocenter plane that is showing the green line and the water surface, and we will apply that vertical shift, and again we will take an image to verify. So the edges will be sharp and it will coincide with the isocenter plane. So for the first time when we are doing, it was very difficult because we were know where the SSD 100 is. So we need to fill the water, take the image, again fill the water and take the image till the SSD is become 100 centimeter. So after the first measurement, we mark the water level in the RFA to avoid the repeated imaging. So that is the case when the SSD is at 100 centimeter. You can take images from 90 degree. But what if the SSD is not 100 centimeter? Suppose the SSD is 90 centimeter, we need to take image from another angle, and this angle can be found using this formula, cos inverse of the depth divided by the source to isocenter distance. So it will be 84.3 when the SSD is 90 centimeter, and edges will be blurred even if the Ganry is off by 1 degree, that you can see from the figure. So the next challenge was on the placement of chambers. Anterior and lateral images are used for the field detector placement, and chamber cap is used for the better visualization. Not only the chamber, any detector placed at the isocenter requires image verification. So the placement of reference detector within the field was more challenging because in the conventional Linux, the field light helped us to safely place the position the chamber. But the reference chamber is placed at a height, and it will be more difficult as the field size will be very small at a height. So we need to take anterior images, and the chamber holder supplied by some nuclears was very difficult to place correctly. So we indigenously designed a 3D printed chamber holder for this purpose and used for the measurements. So the lasers of the halcyon system is at the bore and does not have enough range. So for the ease of setting of obese patients and pelvic cases, and to minimize the rotational errors, we installed an external laser. The external laser, you can see the green line is by the external laser. It is 60 centimeters away from the virtual isocenter. So in conclusion, representative beam data supplied by variant lessen the commissioning time, and the conventional QA equipment as well as the methodologies can be adopted, but unique features of ring and ring demanded additional improvisation and development of innovative methods, and image verification became a mandatory in Halcyon. That's all. Thank you.
Questions, please.
You told where is supplying the dosimetric data for the TPS.
Yes.
Correct. What are the additional parameters you want to know?
Actually, we need to check those things, what they are supplied is correct or not. We need, during the acceptance tests, we need to verify, and we did TPS QA to verify the data supplied to the Eclipse system is right.
What about the output?
Yeah, the output need to be checked and corrected.
No, they are that also they are feeding in TPS. So we have to.
We can correct that by measuring if the output is wrong.
Doesn't have an isocenter, right?
Yeah, it have an isocenter, but it is not coinciding with the virtual isocenter. The treatment isocenter is inside the board, but we have a virtual isocenter outside the board. And there is some shift to be applied from the virtual isocenter to the treatment isocenter.
That's why you are taking the imaging.
Yes.
And what is the Vmax difference? Why it comes?
That is because for conventional linac, there is a bendy magnet, so the energy slips are there. But whereas in halcyon system, there is no bendy magnet and there is no energy slips, so there is no purification of energy happening. So the Vmax will be small.
For the 6 triplet,
yeah.
both are?
Yeah, both are 6 triplet.
Then why that difference?
Yeah, that's what I said. In conventional linac, you have a bendy magnet. For in case of this 2B, you have a bendy magnet, so there will be energy slips in the bendy magnet that will absorb this lower energy.
Okay. So imaging, which energy is taken for imaging? Triple of energy.
Yes.
With triple of energy, you are taking imaging.
Yes. MV images are taken.
Any questions from the audience?
Yeah, there was one red laser.
Yeah, that is the external. That is the laser of. There is no red laser. It's actually blue.
Yeah.
This one, no. This red lasers. This is an equipment used by the people who install the lasers. So this have a system like a laser is suspended in water. So this and this that red box have a system which produce laser lights, and it is placed in water. So that laser is matched with halcyon's laser, and the projection made by this red one is marked.
Halcyon laser is outside, right?
Yeah, halcyon laser is a blue one.
Then how
this is that red one is an instrument used to fix the laser, fix the external lasers.
Oh.
That is not QA, that is used for the installment.
What is the need of this virtual isocenter? Yeah. What is the need of this virtual?
Okay, virtual isocenter is used in the patient treatment. For the patient treatment, the patient can be aligned to this virtual isocenter, and there is a switch to take the patient to automatically to the treatment isocenter. That works only in the case of treatment mode.
Is it possible to position transmission type detector as a reference detector during measurement?
Yes, we can place transmission type detectors. I have seen a document in placing this transmission type detector within Halcyon, but you need extra things like the height to place it on RFA. You can place it on RFA because the RFA ring will be rotating. No? So you need
just one last question. So if in the ordinary linac, in the case of ordinary linac, if my laser is not working at a fine day, so can we treat?
Yeah, you can verify that by imaging.
No, not verifying by imaging.
Can you can
set up the patient.
Yeah, sure. You need to set it at isocenter. Like you can rotate the gantry and there is crossfire. You can match the crossfire with the fusions and can treat.
Okay, I guess that's it. Oh, there's one more question.
Was a wonderful presentation. My question is when during the commissioning of the Halcyon, you told that if there is incorrect, like any data incorrection while commissioning,
yeah.
So you told there are two actually ISO centers, virtual ISO center and real ISO center.
Yeah.
For example, if there is any incorrect like correction in case of your data, the variant provides you with the like data to install this commission this setup. So if there is any incorrection factor, how can you determine that factor if you are not able to like how will you determine the virtual ISO center and real ISO center?
Okay, here comes the importance of machine performance check that you have to do daily for Halcyon machine. That's why I said you can't skip the MPC for Halcyon. Yeah.
I'm not saying about the daily. For example, during commissioning, you will not be able to determine.
Yeah, this MPC verifies the difference between the virtual ISO center and the treatment ISO center. Or to do a QA, you can actually place a phantom in meeting the virtual ISO center, and you can shift that to the treatment ISO center, and you can take the image and verify whether the virtual ISO center from the shift is a fixed shift, that is 57.76 centimeter is inside. The treatment ISO center is 57.76 centimeter inside that of the virtual ISO center. So you can apply that shift manually and check whether this in imaging it is matching.
Okay, thank you, Amar.
Yeah, we did some scope test and all.
For example, you have a plan and you run the plan on a phantom and see the fluence on a film, whether it is any such test can be done.
No.
Okay, thanks, Amar. Next talk of today.
Architect was and I think for your question, if there is a shift in the virtual ISO center, what can be done? Actually, from our side, we cannot do anything. If we notice that there is a shift, then the engineers has to calibrate it. From the physics side, we cannot.
Next talk is by Amalu Hannah Alex, and she's talking on the feasibility study in Halcyon, in using Halcyon TM ring gantry linear accelerator for spine SBRT.
Good afternoon. The title of the study is Feasibility of Using Ring-Mounted Halcyon Linac for Spine Stereotactic Body Radiation Therapy. Stereotactic body radiation therapy for spine is highly effective treatment that is capable of delivering ablative doses to target while sparing critical organs at rest. Spine SBRT requires steep dose gradients and tight dose limits to OARs. SBRT, given using VMAT, provides more conformal dose distribution, faster dose follow-up outside the target, better sparing of OARs, and quicker treatment delivery. So such treatments require dedicated linacs. Patients receiving SBRT at our institution are treated on variant TrueBeam STX. This linac is equipped with 60 pairs of high-definition MLCs with inner 32 pairs of 2.5 mm and outer 28 pairs of 5 mm leaf width. This linac is also equipped with a 60 couch with translational and rotational corrections. This helped to yield improvement in target conformity, plan quality, and normal tissue sparing. The question is, can we use a non-dedicated ring gantry linac for SBRT? Variant recently introduced their new model Elite Halcyon, which is a single energy 6-minute triplet with a maximum dose rate of 800 mu per minute. The gantry speed is 4 RPM and it has a 3D couch. It is equipped with a double-layered stacked and staggered proximal and distal MLC of 1 cm width, which is kept at a 5 mm offset, which results in 5 mm equivalent MLC width at isocenter. This results in an ultra-low MLC leakage and transmission dose of less than 0.5%. It is also have a reduced penumbra due to very small dosimetric lead gap. These specialties can make Halcyon a potential linac to treat SBRT, and this is investigated through this study. A. This study aims to understand the feasibility of using ring-mounted Halcyon linac for SBRT spine by comparing treatment plans done for Halcyon linac and a conventional CM linac. Special objectives include comparison of plans in Halcyon and TrueBeam in terms of plan quality, target coverage and dose distribution, dose to critical organs, plan delivery accuracy, and treatment speed. Methodology. Patient selection was the first step. Patients treated for spine SBRT in TrueBeam were taken for the study. These include 6 patients. PTV volume, treatment sites, and dose prescription of all the 6 patients are tabulated. Next step was the generation of plans for the comparison. TrueBeam plans of already treated cases were taken as the reference plan, and Halcyon plan are generated with the same beam geometry, collimator angle, dose calculation algorithm, and optimization objectives. Next step was the comparison of Halcyon and TrueBeam plans based on NRG BR002 and TG101 protocol. These are the lists of plan specifications that are used for TrueBeam and Halcyon plans. A cumulative dose volume histogram were used to analyze dose received by PTB and critical organs for both TrueBeam and Halcyon plans. Those parameters evaluated for planning target volume and that of OARs, especially for spinal cord, are listed on the slide. These are the equations that are used for the study, which includes conformity index, heterogeneity index, gradient index, and modulation factor. A pre-treatment patient-specific QA was done on portal dosimeter, and the evaluation was done using gamma analysis with 3% 3 mm criteria. Statistical analysis. Descriptive statistics such as mean and standard deviation of each dosimetric parameters for both TrueBeam and Halcyon plans were estimated. A two-tailed pair t-test was done to analyze any difference between both the plans. A p-value less than 0.05 was taken as statistically significant result. Results of the study with regard to PTV. TrueBeam and Halcyon plans were comparable with regard to PTV coverage and plan quality, and this is validated in the table. All the plan quality indices of both the plans were within the criteria of NRG BR002. The figure shows the isodose distributions showing 100%, 50%, and 30% of prescription dose in both the plans, and it shows that both have comparable coverage and rapid dose follow-up outside the target. Results of the study with regard to dose to the spinal cord shows that there is no significant difference, and this is tabulated in the table given, and the graphs shows D.35 cc and Dmax of TrueBeam and Halcyon plans for all the 6 patients, and both the plans satisfied NRG and TG101 criteria. The results with regard to other OARs, the dose constraints with regard to OARs and the values got for TrueBeam and Halcyon plans were tabulated, and here we have to note that OARs for different patients are different because of the treatment sites. Now talking about the results that I've got for the treatment delivery parameters, total monitor units and modulation factor have a statistically significant difference between TrueBeam and Halcyon plans. Gamma analysis of 3% 3 mm criteria also shown a significant difference between both the plans. From the results, we can understand that Halcyon plans have similar dosimetric plan quality in terms of target coverage, treatment target conformity, tumor dose heterogeneity, and gradient indices. Halcyon plans satisfied NRG and TG requirements, and it have a similar and better OAS pairing. It also have an accurate treatment delivery. MSF Halcyon plans required less monitor units to deliver the same dose due to less beam modulation across the target, and this is validated by Pochrane et al. On a similar study done on lung SBRT. Lesser MU does not mean lesser beam on time. This is because the maximum dose rate of Halcyon Linac is 800 mu per minute, and that of the TrueBeam is 1400 mu per minute. As a suggestion, upgrading Halcyon's maximum achievable dose rates to a practical 1000 mu per minute may potentially match or improve the beam on time related to TrueBeam. Inability to do rotational couch corrections was another limitation of Halcyon. AMPI-KC et al. In a study shown that when rotational residual errors can be limited to 1 degree, when it is limited to 1 degree, the rotational residual errors can be set to minimum. As a suggestion, if possible, a 6 degree of freedom couch in Halcyon Linac as a future development can make it more attractive option for spine SBRTs. Conclusion. The result of this study indicates Halcyon platform is capable of generating SBRT spine treatment plans that meet clinically acceptable constraints with high delivery accuracy. For clinics that only have Halcyon as the sole treatment delivery option, administering spine SBRT is feasible and safe. However, caution should be taken with patients requiring rotational corrections of greater than 1 degree in the absence of 6 degrees of freedom couch corrections. These are the references that I've used for the study. Thank you.
Questions? Any particular reason that you took spine SBRT only and no other site?
To specify that, with lung and liver, there is tumor motion, and since this in spine, the tumor motion is minimum compared to other sites, and that's why I took spine.
Retrospective study അല്ലായിരുന്നോ?
Yes.
നമ്മുടെ മറ്റേന്റെ CT, we have taken CT for 2.5 mm ആണ്. ഇത് 5 mm ആണ് minimum.
അല്ല. No, ma'am. No such requirement. Leaf width is 0.5 mm ആണ്. 5 mm ആണ്.
5 mm ആണ്. Okay. ഡിഫറൻസിൽ എന്തെങ്കിലും കാണുന്നത് ട്യൂമർ സൈസും ഈ മറ്റേ ലീഫ് ഡിഫിറ്റും തമ്മിൽ എന്തെങ്കിലും ഇത് വരുന്നുണ്ടോ റിലേഷൻ?
അതായത്
size of the tumor മറ്റേ ലീഫ് വിഡ്ത്ത്. ട്രൂബീമിലെ ലീഫിന്റെ സൈസ് എത്രയാണ്?
ട്രൂബീമിലെ ലീഫ് വിഡ്ത്ത് 2.5 mm ആണ്, and for Halcyon it is 5 mm.
Okay. The tumor size, small size എടുക്കുമ്പോൾ TrueBeam is it better than the Halcyon?
The difference that I've shown in this table, based on the for OAS pairing, it changes. I changed actually. In some cases, it's shown better pairing for Halcyon, and in some cases, it's shown a better pairing for TrueBeam. It is not based on the volume of the target.
It doesn't mean.
See, the MLT size is different, right? Basically.
Yeah.
So, the conformity index. P-value index, homogeneity index, you have a table now? Yeah. The P-value is giving high value, means it's not statistically significant.
1 second.
So, By using a you can close that clock.
Yeah, that's why I'm doing.
This means
I couldn't see the mouse.
see by using a finer MLC, but there is no change in conformity index and the homogeneity index, right? According to your study.
Yeah.
So how can you justify that by using a finer MLC? Still, you are not getting a better conformity index or better homogeneity index.
Even though we have, since Halcyon is having a 5 MLC and just TrueBeam is having just a 2.5 less, but it doesn't shown much increase in the conformity it doesn't show much increase or decrease in the conformity that I've got from the TrueBeam plan.
Yeah, that's the result. I was asking how you justify that. Whatever general idea was when using a lesser MLC set, then conformity should be good.
Yeah.
So you are not getting that. That's why.
It doesn't show much. The recommendation is that to use always use a finer MLC, but and since Halcyon is included in that recommendation, we can use it for the SPRT treatments. Thank you.
How many plants do you have communication?
Six.
Do you think a sample size of 6 is statistically significant?
Yeah, that's why I've used a two-tailed pair t-test, which can be used for sample sizes less than 30.
That's okay. 6 is enough?
Yeah, I've seen papers with the same sample size.
Because it may affect your result.
Yeah, this statistical analysis.
I think 6 samples is enough for a statistical significant result.
Yes, sir. But
at least you can take 20.
Yeah, in our institution had only treated such number of rate.
So you can
improve. Yes, sir. But one more thing is that this type of test, that is two-tailed parity test, can be done only. I mean, this analysis can be done only for the sample size if the sample size is less than 30. So it can give you a good analysis with that.
Okay. Oh, what is the one basic value you have taken to compare two plans? Means you have one plan and you have made another plan. Now the second plan is same coverage or some condition should be there. So what is the condition you have taken for making the second plan?
Okay.
Which second plan should be acceptable according to you? Means you have made a second plan with Halcyon. Now you can optimize it again and again. So you can make a better plan. Now, what is the end point you stop the plan?
I've tried it to so that it cover the target perfectly, and also I've ended the planning so that it is well within the criteria for the OAS.
So it is one thing should be same, then only you can stop the plan and compare other things. So if you have a PTV coverage and the same PTV coverage is made, then the OAS pairing is there.
After reoptimizing also in Halcyon plans, after reoptimizing also, it showed the same, almost the same result.
Yeah, that's it.
If you take 95, 95, or you can for the same conformity, something you have fixed. Oh, okay. That's what he says.
Yeah. One criteria should be
and
there.
I've also kept the prescription isodose same as that of the TrueBeam plans.
If that's the case, then V 100% and V 95%, that both are same. Already you have made it, right? Then why you do that P test again? Because you have made same already. That is the basic condition to make the plan.
Yeah.
Now why you do the P test again on that criteria?
Okay. This since I've taken the readings, I've just tabulated it. Thank you.
We are running short of time, so let us move on to the next presentation. It's by Arvind S. And he'll be talking on the feasibility of using Halcyon linear accelerator for whole breast radiotherapy after BCS using 4 different techniques.
Good afternoon. Halcyon Lina for conventional and advanced radiotherapy technique in left-sided breast cancer patient after breast conservation surgery, a feasibility study. Yeah. The whole breast radiotherapy after breast conserving surgery is the standard treatment to prevent recurrence and metastatics for early stage breast cancer. The current standard of care in our institution for whole breast RT is using parallel tangential photon field on a CM linac to treat the whole ipsilateral breast, including chest wall. In 2023, our institution has installed a new linac called Halcyon. The aim of this study is to evaluate the feasibility of using Halcyon linear accelerator for whole breast radiotherapy after BCS using 4 different planning techniques such as field in field with the dynamic flattened beam, field in field using combination of DFB and triple F beam, electronic tissue compensation, and volumetric modulated arc therapy. Specific objective of this study is to assess the difference in plan quality, dose to area, and total monitor unit for these 4 techniques with respect to clinically accepted reference plans from a traditional CM linac. 5 patients with early stage left-sided breast cancer were selected with an average IFD of 20.6 centimeter. The 40 grain 15 fractions were the prescription. The key criteria for determining optimal treatment were volume of PTV receiving at least 95% of prescribed dose is 95 or higher, volume of left lung receiving 20 gray should be less than 15%, and mean dose to heart was less than 5 gray. The first technique, field in field with a dynamically flattened beam. Planning in Halcyon starts with selection of imaging technique and correct positioning of the couch. Placement of isocenter should be within 10.5 cm from the CT origin in longitudinal direction, and lateral and vertical range is limited to prevent the collision of couch with the board. As you can see in the figure, if you are not careful, there is chance of collision. The tangential field is defined based on beam side view of the breast. The distal MLC is used to shield lung and heart. A flash margin of 2 cm also given in the nipple side of the breast. The opposing field is generated and first calculation is performed after placing the normalization point. The additional subfields are generated to reduce the hotspot. Subfields are also DFBs, so only distal MLCs can be manipulated for shielding. Subfields cannot be merged together since they have flattening sequence in the proximal MLC layer. In total, 8 field will be in for each DFB plans. Field in field using combination of DFBs and triple F beams. Step 1 to 6 of previous method are repeated here. The flattening sequence of subfields are removed. Sheeting is done by the manipulation of both proximal and distal MLCs. We need to verify the leaf position after each manipulation of the MLCs to make sure the proximal leaves are trailing the distal leaves, or else this red color will be indicated. 3 subfields per fields are generated for all plants. After obtaining satisfactory plan, the subfields are generated for shielding are merged. This is possible because the absence of flattening sequence. The third method is electronic tissue compensation. Steps till the placement of 2 tangential beams are identical to the previous method. New irregular surface compensator was selected for MT field with a penetration depth of 50%. Same is repeated for the LT field. Skin flash of 2 cm is given by the skin flash tool. The same is represented in the left side. Fluence in both fields are iteratively edited by dose painting. A small tip, use the brush tool for increase or decrease the transmission factor by a defined value. 0.015 turned out to be an optimum value for mine. The fluence is converted into deliverable leaf sequence by smart LMC. Sliding window option with the 166 number of sequences were used. For volumetric modulated arc therapy, 4 partial arcs were included. The arc design is given as in the table. Same arc design and same optimization criteria were used for all patient plan. The field size was automatically set to 28 by 28. Here, no flash was provided. As you can see, this is the color wash, isodose color wash for different plants. In the fourth plant, plant 4, which is the VMAT, you can see there is low dose pillage. The color wash scale is from 200 to 4300 centigrade. Plant quality evaluation parameters. The mean dose, maximum dose, and volume receiving 107% of prescription dose for PTV, along with homogeneity index and conformity index, as was used for plan evaluation of PTV. Dosimetry parameters for heart, left lung, and contralateral breast were also evaluated. Statistical analysis, one-way ANOVA was performed, followed by post-hoc test with a Befferoni corrected alpha value of 0.005. Results. PTV coverage. The mean dose, maximum dose, and volume receiving greater than or equal to 107 of prescription dose show no significant difference among all 4 Halcyon plants. As we can see from the figure, the conformity index of VMAT plants were the highest among all plants, including the reference plant, but the homogeneity index show no such statistically significant difference. These are the data. Here in the significance chart, the green represent highly significant and red represent no significance. For ipsilateral lung, the mean dose to lung show no significant difference among all Halcyon plants. Maximum dose was lowest for VMAT plant among all plants, and difference was significant. The volume receiving 5 gray and 10 gray had no significant difference among Halcyon plants. However, the 20 gray for the was lowest for the VMAT plant, as we can see from the figure. It has only around 3.23%, and the significance that is also given. For heart, dosimetry parameters show no statistically significant difference. But however, 3D-CRT plants in Halcyon had the lowest mean dose to heart, but for VMAT plant had the lowest maximum dose. The difference was not statistically significant, however. Contralateral breast. The mean dose to CL breast and volume of CL breast receiving 5 gray is highest for VMAT, and all 3D-CRT plants, including reference plant, had very low dose to contralateral breast. Maximum dose to CL breast showed no significant difference among different plants. As we can see, the VMAT plant had very high mean dose and a volume of 5 gray. That was already seen from the above figure, where the low dose was spilling. Total monitor unit. The Halcyon plant had significantly more MUs than reference plants. The modulation of proximal MLCs to create DFP resulted in increased MU for plant 1 and 2, but both proximal and distal MLCs are modulated in the electronic tissue compensation and VMAT plant, resulting in still higher MUs. If we look at the reference plant, the mean MU is only around 352, but Halcyon plant, it is more than 700 or nearly 700. Limitation of the study. The sample size in this study is not large enough to highlight the superiority of one planning technique over the other. The actual treatment time in Halcyon for breast irradiation, including patient positioning and daily imaging, is not accounted for in this study. There is still room for improvement in VMAT beam arrangement for better OIR sparing, especially the contralateral breast. Patient population with a large IFD was not considered for this study. The dosimetric result in this study is based only on the TPS. Results presented here are applicable only for patients after breast conserving surgery. The breast motion during treatment were not accounted in the VMAT plan. Results. Field in field with the dynamically flattened beam plants in Halcyon resulted in highest number of fields. Field in field using combination of DFPs and triple of beams resulted in equivalent plants as the previous one, with a less number of fields with a slightly lower total MUs than the rest of the technique. Ecom plants were very time consuming and depend on the skill and experience of the planner. VMAT plants have lower dose to lung but significant higher mean dose and volume receiving 5 gray to the contralateral breast. Total MUs in Halcyon plants were twice as high as in the reference plants in a normal CM linac. Planning technique resulted in acceptable plan, and 3D-CRT breast treatment is possible in Halcyon at least for patients with the IFD less than 21 centimeter. Given the limited sample size, it is inappropriate to state dosimetric superiority of one planning technique over the other in terms of target coverage and OR sparing. These are the references I took. Thank you.
Any questions? This only test one with my SEL is not the study.
No, I specifically selected with no notes, patient without notes.
How did you take the how did you take the flash and all, like extended body technique, right?
Madam, as a matter of fact, for VMAT, I haven't used the flash. I have already mentioned that as a limitation of the study. I haven't used the flash for VMAT, but rest of the 3D CRT technique, I have used the 2 centimeter flash, and even for ECOM, I have used the flash tool provided in the Eclipse TPS to provide a 2 centimeter flash. Actually, flash can be given in VMAT, which is a bit complicated. We are still working on it. Yeah.
You have piloted the significance in red and green alone.
Yeah.
What is the value you have taken?
Value, the alpha value was, p value was 0.005. That because the sample size is very small, I have to correct for Befroni correction. But the p value, original p value was 0.005. It has to be divided by the number of these, as I can. This number of groups, you can see there is 10 groups, so I have to divide it by 10. So it won't give any false positive. So the values were so many. I don't wanted to cluster it there, so I just kept it simple to have an idea whether it is. And anyway, this is not sample size is not large enough to say any dosimetric superiority. So I kept it simple, straightforward.
Contralateral breast dose is more.
Yes, yeah, contralateral breast is more because the maybe for the VMAT, the arc design maybe I have. This is not an may not be the ideal arc design. We need to work on this. I'm still working to optimize to have a better arc design because as you can if you see this gantry angle starting at the 300 to 150 for the sake comparison, I kept it same for all plans. But if I have changed from plan to plan, would have better result. I would have got a better result. But for sake of comparison, I kept it everything same. I should have changed it to match the patient.
So that's it, I guess. Thank you, Arvind. We have the last presentation, Meera Ismail, and she's talking on rapid arc-based total marrow and lymphoid irradiation.
Good afternoon, everyone. Today I'm talking about the topic rapid arc-based total marrow and lymphoid irradiation. So as we all know, patients must undergo conditioning prior to stem cell transplantation in order to avoid relapse, ensure engraftment, and to achieve immunosuppression. Total body irradiation, TBI, plays an intrinsic role as a conditioning regimen prior to allogeneic stem cell transplantation. TMI, total marrow irradiation, or total marrow and lymphoid irradiation, TMLI, can be used as a better alternative conditioning regimen for TBI in some of the centers with certain technical difficulties, including the room sizes. So the advantages of TMLI includes it enables the possibility of dose escalation. It can be specified as an attractive option for the patients with higher potential health risk, and also In the centers with technical difficulties in setting up for the requirements of TBI, including the room size, it can be used as an attractive option, and it enhances the patient comfort and also more dose homogeneity. So our objective in our radiotherapy center was to aim was to use Rapidac-based total marrow and lymphoid irradiation as a part of conditioning regimen prior to allogenic hematopoietic stem cell transplantation to overcome the technical difficulties for TBI. So as we all know about the workflow of radiotherapy procedures starting from consultation. So I'm talking about simulation. We have done simulation for 3 aplastic anemia patients coming under the age of 7 to 8 years, and the simulation is done with the CT machine, Siemens somatum emulsion, and these patients are positioned in the supine position, arms by side with backlog encompassing the whole body, and a 3-clamp thermoplastic brain mask is used with the support of headrest. All these are indexed to the all-in-one board. So talking about the fiducial markers, we have kept 5 sets of 3 fiducial markers in skull, chest, abdomen, pelvis and thigh. And the CT scans were taken in 2 positions. The CT scans were of 3 mm slice thickness, and it is taken in 2 positions with head first supine position initially for the upper body parts, and then feet first supine positions for the lower body parts. And the images which are taken are exported via DICOM, and then the planning is done in Variant Eclipse Treatment Planning System version 13.6. So about the treatment planning, our prescribed dose was 2 gray to be delivered in single fraction as well as 4 gray to be delivered in single fraction. And the target volumes and the organs at risk were contoured using RTOG guidelines. And we have 7 isocenters in total, and the planning is done accordingly, and all these isocenters are kept in the same coronal and sagittal planes such that only the longitudinal plane moves. And then talking about the treatment planning done for brain and neck. So we have kept 1 isocenter and 1 full rotations for each brain and neck, and this we kept as the base plan, and the rest of the plans including chest, abdomen and pelvis is done by keeping the brain and neck plan as the base plan. So for the chest plan, there were 3 arcs, and the 2 arcs were partially blood collimated arcs in order to reduce the length dose. Then the abdomen and pelvis plans, it is 1 isocenter and 1 full rotation for each. So here we can see, so there is 1 isocenter for brain and neck and 1 full rotations for each, and there is 1 isocenter in the chest and 3 full arcs, where 2 arcs are partially block collimated arcs, and there is 1 isocenter for pelvis and abdomen. And then for the lower extremities, we have planned using APPA fields. We have done the 3D CRT method, and there were 2 isocenters we have used. And okay. Then about the patient-specific quality assurance, we have done using Octavius 4D modular phantom with Octavius RA detector 729. The dose maps are measured, and then the gamma criteria of 3% dose difference and 3 mm distance is evaluated. We have also verified using electronic portal imaging device EPID, and gamma passing rate is evaluated. The treatment delivery. The treatment is delivered using Variant Unique Performance Edition Linear Accelerator with 6 MV photons, and each isocenter is broken into singular plan, and then the images are taken. First, we will visually align the CT marks, and then we will verify the position of the patient using MV imaging, and after verifying the position of the patient, we will align the lasers in the thorax isocenter, and then delta shift is applied to the brain, and then the portal images of brain was taken, and then the longitudinal shift is applied, and the treatment is then delivered for the brain. Then the lasers are aligned in the isocenters in neck, chest and abdomen region, and the treatment is delivered. After that, the lasers are aligned in the pelvis region, and then the photo verification is done for the region, and thereafter the treatment is delivered. Then the patient is rotated to 180 degree with same immobilization and alignment in place for feet first supine position treatment, and the treatment is done from thigh to ankle. So this is the overall dose distribution of the patient according to our plan. So as we can see, the 98% of the volume received greater than 95% of the dose. It is a PTV coverage, and all the ORs are in the accepted limit as well. So this is the DVH of the particular plan. And then talking about the hotspot, we obtained is like for 120%, it is 1.4 cc. Thank you.
It's open for discussion now. Some few questions, please.
You're positioning the patient at the first, right? With the lateral remainder, like that. How you are positioning the patient?
In the supine position, we are placing first head first supine position, and then we will rotate the patient for taking the 2 scans. 2 CT scans are taken actually.
In the machine, you are setting the patient, right? How you are setting the patient in the machine?
First, we will set the patient in the head first supine position, and after delivering the treatment up to pelvis region, we will rotate the patient. It is like.
Then you are not moving the patient. You are getting the patient straight.
No, we will rotate the patient 180 degrees.
You are moving the patient, I'm asking. If there is some change and all in the position of the patient, though you are having all the what you call immobilization and all. If there is any change.
No, immobilizations are not changed. We are rotating the patient, keeping the immobilization fixed.
You are taking the image all the area. Are you taking image before treatment?
Yes, we are taking the images. We align the CT, and the treatment is the verification is done using taking the image of the patient.
Whole patient.
Whole patient.
Where did you calculate this homogeneity index and heterogeneity index?
We are studying. We didn't calculate it. So.
Homogeneity index and heterogeneity index, which will give you a clarity on homogeneity of those.
Currently, we haven't calculated it, but we'll do it. Since we have done for 3 patients, we are currently focusing about the planning we have done. So.
How much time will you take to achieve a good plan?
Like planning for the complete plan?
Yeah.
The planning was like, it was done for about 2 days. Like the appropriate time for the treatment was about 50 minutes, and for the planning it like took almost 2 days of planning.
I guess we can wind up now then. Okay. We are moving on to the next session. The result of the presentations will be announced after Meet the Professor. So till then, I hope you all will be sitting inside. The next presentation is by Ms. Janvi Das, and she's from Radiant Medical Systems, and she'll be presenting on large field radiation therapy on Halcyon. You all have heard a lot about Halcyon now. So this is large field radiation therapy on Halcyon.
Good evening, everyone. I'm Janvi Das, and I am basically a product specialist for Radiant Medical Systems, which is a unit of Siemens engineers now. So the topic for today would be large field radiation therapy on a Halcyon platform. We have been discussing a lot about TBI, TMLI, a lot about Halcyon, but I would be combining both now with my presentation. And I hope this presentation, I can collaborate with you all and move towards creating a world without the fear of cancer. With this, I think I also have an additional responsibility in my shoulders to keep everyone awake after the amazing meal. So I'll just get straight to my presentation and give my best. So I really don't want to spend too much time here talking about the Halcyon platform. I think we have got enough information about it, but just a gist, it's a ring-based gantry, 100 centimeter board, dual stacked and staggered MLCs, past 5 centimeters, up to 5 centimeters per second speed, and it's 100% IGRT treatments that you do on a Halcyon platform. And the console or the control system of a Halcyon platform is very similar to how a TrueBeam works, a very intuitive workflow. And the whole idea of a Halcyon actually has come out to provide high quality of care, operational excellence, and to really give a human-centered design when we have created this platform. So coming to the first paper, this was basically a study done in Kindai University, Japan, where it has been compared to how TBIs are done with extended SSD techniques or CAM-LINAC. But this is a planning study. It shows the result shows that it's very comparable to the other techniques. But I want to take a more realistic approach and present cases where patients have been successfully treated. So I would go forward and talk on these two papers, which is a very proud moment for India because these are the first papers published for Halcyon doing a TBI treatment, and it has come from our own country. So the first paper that we see here is basically from Apollo, Kolkata. They have done quite an elaborate study. And the next paper that we see is from Nanavati. They have also successfully treated a patient with the Halcyon for treatment. Now, starting with the first paper, which is from Apollo, Kolkata, just to give a build a case how many patients were treated and everything. So basically, they took a total of 4 patients for TMI or TMI treatment, out of which 2 were females, 2 were male, with the respective weights given here. 2 were the disease that they had were chronic myeloid leukemia, and 1 each with acute lymphoblastic leukemia and acute myeloid leukemia. Unfortunately, they could only go ahead and treat 1 patient, which was a female patient diagnosed with AML, because from the process of simulation to treatment, they had some complications because of which they couldn't go ahead with the treatment. So only 1 patient could get the treatment here. So in the preparation part, if I talk about the immobilization, the whole full body vacuum bag was used to immobilize the patient. They used a head and neck immobilization board and a foot stabilizer, which basically was used for reproducing the position of the legs and feet. The head was immobilized by a 3-clamp thermoplastic mask. The fingers of the hand and the feet were tied together with adhesive tape so that they couldn't move and the position was reproducible for planning and treatment. And the impression of the arms, the position of the arms was also made on the vacuum bag so that it could be reproducible for the different fractions that were treated. Apart from that, different axial levels, whether the head, the shoulder, the chest, the pelvis, and also the sagittal plane was marked so that you can actually reproduce the position day on day. Talking about the simulation, as we have already discussed for VMAT techniques, there were 2 CTs taken, which was a head first supine and a feet first supine CT image. So for the head first supine, we took it till from head to mid thigh, and for the feet first, we took it from the pelvis to the feet. And this was taken in 5 mm slices in a Philips Bigboard CT, 16 slice CT, and it was contoured in our own variant contouring system, Soma Vision. So on the contouring part, the total lymph nodal stations and the bone marrow was all contoured for CTD, and on top of that a 5 mm margin was applied for PTD. And for ease of optimization, the whole PTD that was on the head first supine scan, it was divided into 5 sections, which was the abdomen, the hands, the head, the pelvis, and the thorax, so that the optimization was fast and easier. Talking about the OARs, we have all the whole list of OARs which were delineated, but the primary focus was basically on the lungs, kidneys, the legs. And then coming to the treatment plan parameters, Halcyon is a 6 MP triple F DMAC, so that energy was used. The planning system was Eclipse, the version 15.6, and the optimizers which were used was basically the photon optimizer for VMAC and our AAA algorithm. So we know that we have 2 CTs and we have to combine these 2 CTs to get an overall dose. So they had taken a junction contour on the knee area of 10 centimeter length, which they had placed a 5 centimeter wire also for reproducibility and to make the planning process easier, which bifurcates the 10 centimeter. And then an APPA plan was made for the junction area. So how they started was they took the head first scan first, and then in this junction area they drew the border of the PTD that we had drawn for the head first supine scan, that was matched for this outline also for the junction contour, and then an APPA plan was made with 90-degree collimator rotation, which we named as the head first supine junction plan. Now the same plan or the same contour was also drawn in the field first scan, and this plan was copied basically on the field first scan, and again the gantry was the collimator was rotated by 180 degrees to basically replicate the same thing that has been done for the head first spine plan. The VMAP plans for the rest of the PTDs were done independently, but this head first supine, this junction plan which we have made for both the scans, that was taken as base plan dose when we were planning for the arcs for the head first supine, rest of the PTDs in the head first supine and the peak first supine scan. Finally, when we wanted the whole dose distribution for the complete body, we basically combined all the PTD dose summation of the head first supine scan, the junction area of head first supine, and the peak first supine. So that's how we got the complete dose distribution for the body. Now, coming to how they had basically placed the isocenter. So the median number of isocenters, which this is the sum of the number of isocenters on the head first supine plus peak first supine, was somewhere around 17. So 17, this is basically an average of all the 4 patients where they had treated, not for the one who went on for treatment. They had planned for 4 patients, but only 1 could go ahead. So the median number of isocenters was 70. The spacing of the isocenters was planned in such a way that the adjacent pairs, like 1 and 2 or 3 and 4, those were placed around within 8 centimeters of each other, so that the number of CBCTs which was taken could be minimized. And the second and third, fourth and fifth, they were kept within isocenter a distance of around 15 to 18 centimeters. So this strategy was made in such a way that obviously the number of CBCTs should reduce. How do we manage the dose that is in the junction area, and also to minimize the dose that is actually given to the OARs. So these 3 points were taken into account when the whole plan or strategy for replacement of isocenters was made. So to give you an example, so as we know that Halcyon has a field of around 28 into 28. So if there is so for a 10 centimeter overlap, the distance between the isocenters would be around 18 centimeters. And again, suppose it's a 13 centimeter overlap, then the distance between the isocenters would be 15, a total of 28 basically. So that is how the whole strategy was taken. Talking about the art placement for the VMAC plans of the heterosupine and supine. So the first in the cranial region, they had done 2 arcs. Also for the feet for supine glands, also they had taken 2 arcs, and only in the region starting from the shoulders to the pelvis, we had taken around 3 to 4 arcs because it's a larger area. So in this region where they took 3 to 4 arcs, the additional partial arcs were basically planned from gantry angle 220 to 140, avoiding 300 to 60, basically to reduce the dose to the OARs. And the collimator angles which were chosen was 45 to 1 and 135 for the region up to pelvis, and later downwards it was 280 and 80 degrees. Another feature which was used while making all these plans was the auto dose feathering on eclipse, which basically helped in reducing the junction cold spots or hot spots that could arise. This is a feature in the eclipse system in head and neck. So talking about the dose goals and what they were able to achieve, the dose prescription was a standard of 12 gray per 6 fractions. The aim was to at least get the 95% of the target covered by the 95% of prescription dose. 100%, 107% of dose was not supposed to exceed 5% volume of the PTV. The mean lung and kidney dose was planned to keep lower than 10 gray, and the dose for lens was to be kept lower than 8 gray. For the rest of the OARs which were drawn, it was as low as achievable, while not compromising the PTV coverage. So if we see at the dose distribution that they were able to achieve, these 4 pictures that you can see is basically the dose coverage for the patients that they had taken, and the full body view can also be viewed in the one in this picture that you can see, and it shows that it was quite well distributed. Going a little deeper into the values or the data, this I want to again stress that is not for one individual patient which went for the treatment, but an average of all the 4 patients for whom they planned, even though they could treat only one. So here we can see that the coverage of the PTV was quite well. 95% dose was given to 95% of the PTV, and even if we look at the volume of P107, it was just 3.3%, a little more than 3.3%. Looking at the OAR dose, again, both the lens were well within 5 gray, which is a standard. Here we have even taken an upper limit, which was 8 gray. And if we look at the lung dose, it was a little over what we had expected, a 10 gray. But here it is an average of the 4 patients. And another thing that has to be taken into consideration is that they had also got a very obese patient, which was also a challenge for them. They realized that the body weight also, or the height, body weight of the patient also played a role in how well they could achieve those goals. And kidneys were also well within the level that they had wanted to achieve, which was 10 gray, but here we can see close to 9, 8 gray. This is the DVH for average DVH of these 4 patients, which we can see here, which shows also a good data. And they went for a patient-specific QA for NU to dose correspondence by using a 0.6 cc ion chamber in a solid water phantom, and that also showed acceptable values for both point dose verification and volumetric dose verification. And even portal dosimetry was done using the EPIC, and there also we can see that within the criteria of 3% 3 mm, most of the cases were very close to 100% passing rate. So there also whatever was planned to be achieved was very easily achieved. And coming to the success story, So the plan that we had made for the patient with AML, she was successfully treated. Her transplant was done after 3 days of her completion of the therapy, and she received her, she was doped by the marrow of her 23-year-old brother, so we have a success story there. Talking about some challenges and observations from this paper, they realized that, as I mentioned, the dose distribution was highly susceptible to the height and weight of the patients. Even more challenging to really gain the required dose or the desired dose for the pulmonary dose. But for lean patients, it was quite easier for them to achieve, and it was achieved. The total number of isocenters that were used per CT was close to 10, and 2 to 4 full arcs were used for each of these isocenters. The average couch time, treatment time, also taking into account the imaging time, was around 83 to 91 minutes. From the results of the paper, they realized that Halcyon produces a clinically acceptable plan and a much faster delivery than a traditional TBI box technique. Another additional benefit which they found or realized was that it reduced the patient contact with the staff and lowers the risk of infection for highly immunocompromised patients. This is the second paper. I don't want to spend too much time here because I know this is the last presentation and everyone must be planning about what to do in the evening. This is basically from Nanavati, which I mentioned. They had taken a prescription dose of 3 gray in a single fraction. It was for a 21-year-old guy. And if I talk about the simulation, it was very similar to how it was done for Apollo Kolkata. The only difference was that they had also used isocenters that were placed laterally, and the collimator angles that they used was what usually in the talks we had mentioned for true beam be rotated by 90 degrees. They had also done the same and taken lateral isocenters as well. Their isocenters were close to 15, and the dose goal was basically that 90% of the dose is received by 95% of volume, which was achieved. Lungs and kidneys got 80% of the prescribed dose, and the maximum dose of less than 130% was received by 2 cc of the volume. The total time which was taken was 1 hour 15 minutes, which is quite close to how Apollo Kolkata had also performed. So this is just to give a gist of the paper. I would be happy to share this with you for you to go through it properly. The key takeaways from both these papers is that the isocenter separation should be chosen, which I already had mentioned, 3 factors: lower the number of CBCTs, optimize the dose to the gradient regions, and minimize the dose to the OARs. That is the whole strategy of how you choose the isocenters. A point which we should note that there were multiple isocenters needed. I have already shown that there were close to 10 isocenters required for the network support, which is quite large, I know. But this can give you the idea that increases the treatment time quite a lot. But then Halcyon has proven that it is quite an efficient system. If you look at the whole operation of how Halcyon works, starting with the imaging speed, the MLC speed, or the treatment speed of 2 RPM, that really compensates for the longer time that you would be taking for these multiple isocenters. The auto dose feathering and the base dose plan features in Eclipse really help, to manage the dose that is in the junction regions to basically compensate that, okay, this APPA plan has been already made for the junction and I have to account for that when I'm planning for the rest of the area. These features will help you with that. Velocity is basically variance offline adapted solution, but it can also very well help you in this situation where you're doing the dose summation for different CTs. And there are some future technical enhancements which are coming up for variant. I cannot explicitly talk about it right now, but with the application of surface guidance, hypersite is something that is coming up. Can't share the leads right now, but with those enhancements, it would make the workflow much easier, we feel. And another point which is not included here and should be taken into account is that Halcyon is a comparatively newer system, and the adoption of TBI and Halcyon is also new. So these two papers or another paper is being worked out on are very new or less experienced. The people are less experienced in the platform for now. So with time and more experience, we expect that these results would be better very soon, and we want you to look up for that. With that, I would end my presentation. Thank you so much. If there are any questions, please feel free to ask.
What kind of institutions do you recommend?
For Halcyon? So if I talk about a Halcyon system, sir, as I said, there are three pillars on which the Halcyon platform was built on. High quality of care is always the first, but it also gives you operational excellence. So, I mean, centers who want to treat a high patient load, they want a very efficient platform. If they were looking for, then Halcyon, I think, would very well fit their requirement. Apart from that, I know there's an idea about that it's a single energy LINAC and it doesn't really fit into all the clinical needs that clinic might have. We have different models of Halcyon, basically, starting from B to E, and now the ethos is also there. So I think all Halcyon platforms have something different or unique to offer, which can fit into the requirement of the clinic. But if I really have to say, a Halcyon is a very efficient system, which can very well take care of the high patient load that you have, give you efficiency. Even for special techniques like TBI, CSI, it can very well cater to those needs. So, yeah. Sir, some suitable cases of SBRT can be performed. It has a 5 mm MLC in one of them. In the elite version, you basically have 5 mm MLC. And even if you go for ethos, you have 5 mm MLC there. So some suitable cases of SBRT can definitely be performed. Even for SRS, we would not suggest that you treat a trigeminal neuralgia with a Halcyon, never. But there are some cases where you can apply, and we have seen people applying it. So it is basically, it depends on your judgment, how comfortable you are to use this platform for those cases, or the cases that you get. Sir, it is quite a few now. It is over 50 in India.
It should be you have 60 couch.
Yes.
While Halcyon is not. So is there any issue?
Sir, actually, we don't have it yet, and also because it is a closed bore LINAC, so there are some technical challenges because of which we are not able to introduce it. I am not sure. There might be some future development where they might come with that.
Yes,
But
angulation is only up to 3 degree.
yeah, we do not have a 60 positional correction. But to help you out, you can also use surface guidance on a Halcyon platform, which will give you the whole 60 corrections with which you can position your patient. Before imaging only, you can correct the rotational errors also. But currently, if you say about the couch, we really have 3 translations. In future, we'll just watch for that space. Maybe there might be a development. But yeah, till now, it's not there.
Thank you, Janvi. I request Ms. Seja Joseph to hand over a token of our appreciation to Janvi.
Thank you so much.
So with that, we come to the end of the seminars and talks. And now we have the Meet the Professor event. The aim of this event is basically to introduce the youngsters here to the past, the people who have actually shaped radiation oncology and radiation physics in Kerala. Let me start with Dr. PGG Guru. Guru sir, he started his career as a faculty of GMC Trivandrum, and later on, when RCC was started, he moved to RCC and worked there for a few years. Later on, he moved to Apollo Cancer Center and retired from there in 2015. Sir has demonstrated exceptional academic and administrative skills throughout his career, and right now he is the chairman of AMPI-KC chapter. Next is Dr. G. Ramakrishnan. Ramakrishnan sir, as we all call him. Sir started his career as lecturer at Medical College, Alapi. He served at various medical colleges after that. We get transferred frequently. He served at various medical colleges in Kerala. And after that, he took charge as the director of Directorate of Radiation Safety. He retired from government service in the year 2011 and has since been working as RSO in SMCSI Medical College. Dr. Ramakrishnan is an approved research guide of KUHAS and has guided many medical physicists. Dr. Dinesh M., you heard his talk in the morning, and Sir started his career as lecturer in pediatric oncology at RCC Trivandrum. Later on, he completed his MD and DNP in radiation oncology from Kidwai Memorial Institute. He is the first person in Kerala to work on a modern linear accelerator. Sir was also instrumental in starting the radiation oncology department at AMC Mangalore. At present, he is working as the head of radiation oncology at Yenapoya Hospital, Mangalore. I'm sure you all would be interested in talking to them. As of now, let me begin by asking them what is their opinion about the evolution of medical physics and radiation oncology in Kerala.
Fortunately, I could start with very primitive radiotherapy facilities and treatments in the Medical College, Trivandrum, where the radiotherapy started first in India, in Kerala. Subsequently, there were addition of equipments, facilities with the machines and people, and improved the treatment facilities, treatment conditions, also the type of treatments were changed, and with the modern developments of radiotherapy equipments, now it has come to the level of high-end radiotherapy facilities in most of the depending on centers. So in Trivandrum, the first radiotherapy was started in General Hospital, Trivandrum, with some amount of radium. I think about 200 milligrams or over 200 milligrams of radium we received. Also, there were deep X-ray machines. GE and Siemens were the first to provide deep X-ray machines in our state. We had a 400 kV X-ray machine, which was more like a big tank with like a beta drone, which I have seen in Vedur sometime when it was installed. So it was not able to rotate or angulate, can give only vertical beams. It was used only for a few years. Then the Siemens rotational, or not rotational, Siemens deep X-ray machines came, which was on a gantry, which could move to various angles and treat from various angles. APPA, lateral, or fields could be given. And in Toronto, we got the first radiotherapy telecobalt machine sometime in 59 or 60, something like that. First radiotherapy machine, telecobalt machine came to India at Adyar Cancer Center. It was the Eldorado A, which is also was able to deliver vertical beams and horizontal beams. Of course, it could move from vertical to 90-degree rotation, rotation with the various angles in between. And that was the first model of Eldorado machines, where the source was fixed, the shield was moving. So that was the only machine with the shield movement. Subsequently, it was all source movements. And what could be the shield that could move in and out of the source? It was a liquid. So we used mercury as the shield. And there are a lot of problems like a leakage of mercury, and we used to pick up mercury balls from the rooms at the end of the day, pour it back into the tank and use it. Later, all the Eldorado series of machines came, and then equipments like Theraton. Eldorado 6 also is a vertical beam, which was able to move up and down only. No, that was a source movement. Right? Source was on a drawer which was moving. So only the source which was fixed was in Eldorado A, which is the first model of AECL Canada machine. Yeah, Janus came sometime later, which was developed by idea of Dr. H.K., who thought that in the third world countries, a lot of cervical cancer patients who do not need much of precision in treatment. They want more patients to be treated. So it was a dual head machine. One source moved from one room to another room. So when the advantage was, when you set up patients in one room, the treatment can be continued on the other room. So setup time could be minimized or avoided. And there was no collimator as such. People used to adjust the lead shields in a tray behind, in between the source and the patient. Like you use shields in the modern machines. So we could make regular, rectangular or square fields. You cannot make circular fields or irregular fields. It was very difficult with those machines. So basically, it was defined for cervical treatments, where either a hexagonal field or a square or a rectangular field was used. Then only the modern machines came with the multi-leaves, shutters, small fields. Now, then came the what is that? All modern gadgets, probably Dinesh should be able to give more modern gadgets. Of course, I also have worked in some of them. Now we have come to this machines like what you have seen now. Cyberknife came. Of course, the cyberknife, I had the opportunity to operate the first cyberknife in the country. It was also giving circular tubes, small circular tubes. It was basically used for only radiotherapy. So these are the developments that you have gone through in equipment wise. Similarly, there were developments in the planning systems. Initially, we were all doing with the charts, doing calculations, taking patients' separations, and doing the midtime calculations or calculations at various depths. But nowadays, these are all, probably you are not aware of those things. Most of the people sitting here. Today, some old people like Dayalan or Chendil. Chendil is not old to say that. Then Ramakrishnan, we are all used to that kind of treatments where you could use the isolar charts or the depth of squares and calculate those at various depths or at the midplane. Now you don't know about that, you don't have to use those things. We have all various kinds of planning systems where you put in the patient's contour and the machine will calculate with the beam data provided in that, and you could be able to, you could get the dose distributions, you know the dose at various points, and you know how to restrict those. All these facilities are available nowadays.
So at this point, so you were telling about how we started off with the cobalt and reached at this level. So, and Dinesh sir has also gone through this particular thing. So from the clinic side, what has brought, what's the difference that you have seen when we went from that era to the youth era where planning system decides your plan? So earlier the oncologist used to decide, okay, this was the plan that I need. So now most of the plans, even though it's generated by back-end people, your final decision is based on what the computer shows you. And what is the clinical outcome that you get from that? Or is there any change that has come up?
Yes, I mean, we have walked through the cobalt and radium era to the modern DNAC times. As a clinician, it's a wonderful transition because we don't have that, we have wonderful options, in getting a more refined plan these days. As a clinician, I don't see that kind of toxicities I used to see during the cobalt era. The kind of analgesics and the medical treatment we use for head and neck treatment has minimized so drastically, and you can push a really high dose to your targets with less collateral damage to the normal structures, the xerostomia, the dysphagia, and in the recent papers like DO AMRT, dysphagia, dysphagia optimized IMRT and all, is possible in the modern era. And unlike the olden days, there is a more rapport with the medical physics also, because there is a good opportunity to review the plan, to tune the doses, and to have better control over your organ at risk. So it's more of a teamwork these days, unlike the earlier days where so a good time is required, because what is happening now is so many patients are being treated even on a LINAC also, and that minimizes the amount of rigorosity and the quality you can deliver in the timing system. So that is also important, a weekly review of the charts, because there's no point in doing IMRP when you're not able to review your counting CTs as astutely as you would want to, and to get whether you should have good trained technologists who can really, give a lot of attention to this line. So it's a big teamwork. It's not like earlier days. If you want to deliver good quality technology, you need to be good at all levels in your team. So that is also very challenging. The brachytherapy also has made significant difference from our radium era, HDR era. So the toxicities from I don't think the survival rates and the results have increased dramatically, but still there is, you are able to, from a personal point of view, one thing I'm doing in NVR and NIAS also would have seen, we have all been trained in the Christie era where we used extreme hypofractionation. 5 to 15 was our bread and butter those days. So we have inducted those kind of treatment philosophies in the modern treatment planning also, because the damages, we can actually get a better tumor control. The CPI-MRT is our passion these days, because I don't think there is any point in doing IMRT without a SIP. That's my personal thing, because conventional doses should now be the practice. Should be a SIP, because the GTB requires a higher dose, and that can be delivered more effectively.
Even the 5250 regime, even now we have shifted from a cobalt 2D to IMRT and BMAT, so it's still being practiced.
We have got good success stories and total cases where people have done the case as palliative, is cured, and it's completed 3-4 years with good local control. So the technology gives you the strength to deliver the higher doses these days. Like CT Snow said, technology offers you a lot of gifts, but stabs you in the back also.
So at that point, like when technology comes in, and there is more challenge on the radiation safety point, because most of the things are done from the back end, which we hardly understand. So that brings in new challenges for radiation safety. So for a radiation safety point of view, how can there be a regulatory body which looks into the newer equipment? Or like both, nowadays it's not like separate therapy equipment and diagnostic equipment as a different one. They all come as a single unit.
But I think this is a very slightly complex thing, because now we have certain regulations, but these regulations are based on certain concepts, like what is called as you do that thing, you do this thing, something is simple. But when you go to the practical side, you got a lot of things. Yeah, I still remember in 1983 we published a paper that is a leakage radiation from the cover. Now that time we took some film, and it is a very difficult thing. Took some film, and then the first simulator given to us was a very, I think Sarah would remember that. We had to get that first simulator, very difficult to simulate. But those eras were gone now. But when it comes to the regulatory aspects, the people form certain rules, and now the question is whether the rules is followed. Especially, I am not very much versed with the rules and regulations, because ARP says so many things, you have to do that thing, you have to do those things. But they wanted only in paper, that you send some reports and all this. But of course, in radiotherapy they work, because you have certain things they used to visit. But other areas, how it is?
No, I think in that perspective, in radiotherapy, it works better and it's under control of the medical business than in the diagnostic, because in diagnostic, we know what happens now. Yeah. Like there are agencies who just issue certificates and which can be directly uploaded without doing any quality assessment.
No quality assurance is required, no room planning is required. Now all that thing is required is you just give what is called as some data you give, some undertaking you give, your team will be up. Now the next question is, now how to go about it? Suppose many passwords are missing. Diagnostic side, many passwords are missing. You cannot enter it unless you get the support from it. Now these are going to be a problem. Now recently I came to know that somebody in ARV was funny. Why not DRS again? Because abolished, I think for no reason. It is running very well. I was a director for 8 years, from 3-4 years. So we didn't compel any extra users to see post-terminal. We only make them comfortable. We do this thing, we do that thing. Everybody else will be doing it. There's no problem.
So again, the thing is, like when technology advances, all these things come to the clinic.
Yeah.
And whoever like gets qualified and come to the clinic to work, for them they should have a basic understanding of how the equipment works and how to handle it and what is the regulatory aspect and how to as regional bodies, how can we handle on that? So, like, because you have seen things, technology getting developed, and as each technology come into the field, like for example, AMPI-KC, because during your period in Apollo, that AMPI flourished. Like I'll say, it take a U-turn, and from 3D CRT, everybody was shifting to AMPI. So, and now it's still AMPI, but it's slowly getting refined.
Yeah, now also it is IMRT only, but I think there is more refinement in the treatment and delivery of IMRT. So, as Dr. Dinesh was telling, earlier we were afraid of going to 50 gray or 55 gray to the tumor. You all know that from experience, higher the dose, better the tumor control. But we are not unable to increase the dose level because of the dose to other critical structures and normal structures. And with this EMRT, we were able to spare the normal cells and critical structures. We could identify them. We could give them some dose constraints and restrict the dose to those structures. As a result, we could increase the dose to the tumor to 70, 80, even 100 gray. So some of the small lesions like the in the brain, we could go to 100 or 160 gray. Of course, that is a volume of less than 0.5 cc. So that kind of accuracy we are able to establish to smaller volumes, which we are not able to even dream those earlier days.
Yeah, I still remember Apollo had the only recon-based SRS system.
Yes.
And they were practicing that even in their in the 90s or those period.
Yeah, trigeminal pneumonia we treated with a tip of the nerve, which is less than 0.5 cc, but 0.3 is the usual volume you treat with 160 gray. With very minimal dose to eyes, the spinal cord, or all the other structures around. So these are all able to do because of the high quality of the machines and the quality control we have done for these equipments, and there are systems we are able to check the quality control of these equipments and delivery. So these days it is possible, which we are not able to even think of on earlier days.
Simon sir, could you enlighten us on this aspect, like what is coming up in the future and the new equipments that are coming up? And, yeah.
Now you are asking about say the regulatory aspects. Now one point which strikes me is now MD radiotherapy, MD radiodiagnosis, even for cath lab with a separate course. Now no way of protection is being taught. Yeah, even you may say that in the syllabus it is there, but practically there is no paper on radiation physics or radiation safety. So that is included as a general paper. General paper, only one question will be coming every year: what is protection, what is safety. Now my professor used to tell you take 100 classes. No students will be coming to your classes, definitely, because there's something like drawing class or drill class. I think this should be. And cath lab technician doesn't have any idea about radiation. Because one of our own students, I asked, why you come for hospital? How you come for, you can go to cath lab. For cath lab is very, very difficult because a lot of radiation is there. Now, even in Chitra Medical Center, it's not that. Now, at that time I was doing my PhD. I had a lot of work with Chitra. That I was talking to the professor. Then he said some they took some classes somebody will do.
Yeah, even now in cath lab, the dose to the cardiologists are high, especially their extremities. I have seen doctors with the skin red, almost red, with no hairs. So these things. Intervention radiology is also similar, but there it is radiologists who are little bit more aware of these hazards. But in cardiology, they don't know. They don't care. That kind of system is practiced even today.
But what I again noticed is that all these DNA batches read only the road. So it's not a topic, but see how it can happen. It's what I'm because somebody was saying they are not using that.
Yeah, today the era of radiotherapy is actually reached the peak. I don't think actually we will have actually multiple emission of information. What is going to happen? Probably the high energy will be reduced. Like 18 maybe nowhere now we are using it. Though we purchase some probably the 15 use also slowly coming down because of the arrival of IMRT. Maybe we settle with somewhere around 6 and 10 MeV, somewhere around. That type of machine may come. Maybe LCR is the one of the reason for that also is. It is a cost-effective, easy maintenance. And apart from that, there is one area which is called flash radiotherapy. That is also emerging. Clinical trials are going on. Another one is grid radiotherapy. They said actually you can have segments like matrix format. Particular grid you can expose actually localizedly still high dose. These are the emerging areas may come in the form of linear accelerator itself. There is no beyond linear accelerator, but these are the things may be possible in future. Probably high dose rate actually is possible. So we can, as you said, it is possible to shorten the treatment time as well as actually we can avoid the movement. We need not have much immobilization as we use now, and very good dose escalation is possible. That may be the future of radiotherapy. The same linear we may have this format.
Thank you, sir. We are running short of time. I guess all of you have your reservations there. So to wind up the session, I request Dr. Raghukumar P. to hand over a token of our appreciation to Dr. PGG Guru. May I invite Dr. Sushma to hand over a small gift to Dr. G. Ramakrishnan. Thank you, sir. I invite Dr. Vijay Gopal KS to hand over our token of appreciation to Dr. Dinesh M. It's a mark of respect from our side. Thank you so much, dignitaries. It is an honor to have you all amongst us today. Thank you so much. Please take a seat in the audience. Now I'm eager, the students are very eager to know the result of the presentations. So, okay. Should I start with the third prize or the first prize? Third prize. Okay. The third prize goes to Aravind S. Aravind, where are you? Let me invite Dr. Kayalan sir, Dr. Niaz and Dr. Saju to the dais as well. That's the honor, sir. That's the honor. Yeah, so the third prize of the presentation goes to Aravind S. Thank you, Arun. The second prize goes to Aman Jose. Aman Jose. Very good, Aman. And finally, the first prize, Abjishri S. Her prayers have been answered, it seems. She was the one who recited the prayer here. Thank you, sir. Thank you all. I request Niaz to kindly deliver the vote of thanks.
Good evening, dignitaries on the dais and off the dais. Just I will cut short my vote of thanks. I'm feeling honored to get this opportunity for conducting this wonderful program. I actually, in fact, it's a one of the best memorable reunion of our fraternity as well. And I'm sure we had some very good academic fields, academic presentations in the event. And I believe this conference, first of all, I would like to thank AMPI Kerala chapter for giving this opportunity for conducting this conference at this campus. When I approached the management, they were very open. So I just want to convey the vote of thanks here on behalf of this organizing committee and AMPI-KC Kerala chapter and MBR Cancer Center. As you know, this conference, any conference won't be possible without a good dedicated team or wise working hand or support from any corners or other blessings. So let us give all thanks to the whole team who assembled here. I would like to mention our Honorable President of AMPI Kerala chapter, Dr. PGG Guru. He has actively participated in this conference. Thank you, sir, for your valuable presence and your time here. And I would also dedicate our thanks to our Dr. Narayan Gutivaria. He is our medical director of this hospital. He has come on this holiday and inaugurated this function. Dr. Rebecca John, the chief operating officer of this hospital. Dr. Vijay Gopal, he is the head of radiation oncology. I would like to mention our sincere thanks to all of them. And Dr. Dinesh, he is a former HOD and he was actively involved through all the sections by answering questions, everything. So many thanks for your wonderful presence here. We are very lucky to have you here. And I would like to mention my sincere vote of thanks to our chief of the day today, our Dr. Thayalan sir, professor. Sir, very thank you so much for your time. You have been traveling around to reaching this campus, this outskirt campus. So many thanks for your presence. And I will also mention our speakers, invited speakers, Dr. Henry from CNC Vellore. Thank you so much. And Dr. Mr. Jayadevan, Ashwari, and John Bose, And in fact, Dr. Saju, I don't want to mention him. He is the man who behind all of this. He is the secretary of AMPI, as you know. So many thanks, sir, and everybody who was here. I could not forget. Like the participants, delegates. You know, we have got 145 registrations for this conference. We never thought that we will get this much of response for a chapter like this. And after 145 registration, and you won't believe 100 plus attendance for today's program. This was amazing. I don't know how to express my sincere gratitude to all attendees and delegates here, especially students. They are very active for the sessions and questions and everything. We are very sorry we did not give much of time for you clarifications, because as you know, this is running out of time and everybody's train is scheduled at 6, 7, 8 in the night, so it's taken another hour to travel from here to there. So again, I would like to thank Dr. Ramakrishnan sir. He is one of our chief guests today, and other delegates. And I would also like mention our sponsors. Without them, we cannot do these functions this much of like in this way. I just want to mention the name Varian Medical System. They supported us, Electra Medical System, PTW, IPA, INRT, CRAC, and Meditronics, POCL, Radian, Accure, etc. And many of those representatives are here. They came here from long distance, and they reached, some of them reached yesterday itself, and they were staying here. So sincere gratitude to all of them for this, for making this occasion is wonderful. And I would also like to mention my word of thanks to my hospital team, especially the chairman, medical director, CEO of this institution, secretary, and other managing team, who was very positive to give all the facilities of this hospital, like auditorium and other department facilities. I would also like to mention very sincerely to our IT team. Even they started their work yesterday itself, and the whole day they are here. And this program is telecasted actually in YouTube. So many people are seeing from other sides, so they are getting messages from different groups of medical physics with good clarity of these presentations and all. So IT, facility team, maintenance team, housekeeping, and all other supporting team of this hospital, and of course my team in behind this program, my traditional colleagues, the doctors in the hospital, and the physicists team and technologists team, and the students and interns in this hospital. So everybody made this event as very beautiful. I sincerely thanks everybody. With this, I would like to conclude this session with the permission of our today's chairperson, Dr. Tijigo. So let us wind up this session. So any announcement? Thank you all. Thanks.
Thank you all. I'm sure all of you have something to take back home other than the water bottle and the diaries. So, wishing you all a very safe journey back home. Please, tea is served outside, and we have to stand up for the national anthem first.
अधिनायक जय हे भारत भाग्य विधाता, पंजाब सिंध गुजरात मराठा द्राविड़ उत्कल गंगा, विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा, तव शुभ नामे जागे, तव शुभ आशीष मांगे, गाहे तव जय गाथा, जन गण मंगल दायक जय हे भारत भाग्य विधाता, जय हे जय हे जय हे, जय 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 हे.
Tea served outside, and the buses are available from 5:30 onwards. Buses to the town are available from